I think we have to start. As you know, we have a very full program, all 3 days, almost 12 hours, I mean, with some breaks. So we will start, and for those of you who have not registered with your QR code, please do that at the break, later in the morning break or during the afternoon break, but we do not want to lose a lot of time waiting here. So, on behalf of Professor Huisman, who will of course say quite some words for himself, I do not doubt this, I mean, we wish to, to welcome you, Stavros Konstantinides, and we wish to welcome you to our 5th spring school. So we have now covered a period of almost 10 years. We started in 2013, but together with all the preparations, we have covered 10 years. And we are really very happy because we are really one of the first, I would not say the first, but one of the first major events that now happen live and with physical presence. So we are very proud of this, as I was briefly saying yesterday. And we are really very thankful to you all that you responded to the call, yet you were so happy to come to join us, and we hope that you will not be disappointed. Before I give for 3 to 5 minutes some housekeeping information, Benno, I will let you say a few words.
Just 3 words. You are fantastic.
Yes, thank you very much. So, okay, so we will, as I said, I will start very briefly because then our experts will start with the epidemiology on VTE, and this is difficult enough, so we will have to have, not to make you very tired, you have to be able to pay attention. So a few words on the organization. I think it is self-evident, nevertheless, I will show this. We have hygiene rules, as you know, as you all have. The bureau, Mrs. Gastugnotti from the agency, will be able to inform you about the rules. If there is anything that you need to know, please ask her. The general rule is, so I think this is some kind of automatic chain animation. Do not worry about this. In this case, please know we do have a mask obligation indoors, not for the speakers of the seminars. Of course, you can always wear your mask if you want, also outdoors, but we have to wear masks indoors. And when you are here for the faculty, when here at the podium, you do not have to wear a mask, of course, but during the workshops, because we will be closer to each other, we will have to wear the mask as well. So this is the important thing, and all the other regulations will be explained to you if you need that. You do not have to wear a mask, of course, during lunch, during dinner, or when you're outside. So this is one important thing. The other important thing is what I would like to personally ask you for. I mean, some people would like to undertake, to go somewhere here. Of course, you can do it. I mean, you are free. But please note, if you want to hire a car or whatever, Crete is a difficult place to drive. So having a driver's license in the Netherlands or the UK does not mean that you can drive very safely in Crete. So do not be too adventurous. You can do that when you travel on your own on vacation, but we do not want to be held responsible if you are lost in some gorge or something, right? So this is... And we have a very full program. I mean, if you can make it and come back and be back for the afternoon sessions, that's fine, but actually it's not very easy. So there is now one thing that is important. Of course, we will have our sessions, and usually at the sessions we ask all members of the faculty and all presenters to stay within the time limit. I think that's clear. Of course, if there is one or more, a couple of minutes, we are not cutting the microphone. There is one exception, the oral abstract presentations, which is a very brief summary of the abstracts. There we ask you to keep the 3 minutes time. I mean, our chairs, our moderators of the abstract sessions will make sure that this works. And this must be kept, otherwise we will not be able to accommodate 12 abstracts in an hour. So please keep to the 3 minutes. This is the only absolute upper limit. And of course, this is just a brief summary of your abstract. Then we have our big screens outside, and you will be able, and we ask all of you after the abstract sessions to go and join the presenters and discuss with them their abstract. So there will be one abstract. So this animation is a little bit. So there will be one abstract there will be 2 presenters per table, and per screen. So you will have time to join them. The other thing is that we will ask you to register in advance for the afternoon workshops, because the workshops will be split. We will have always, every workshop, as you know, is being held twice. So today, for example, you have workshop 1 and 2. So workshop 1, for example, will be here, and then workshop 2 will be in the smaller chamber. This one is being also streamed and video recorded, so this workshop will also be available to our colleagues who could not make it personally, and then we will switch. So each one of you has the chance. There are 2 parallel sessions every time, but each one of you has the chance, of course, to attend a workshop, because it will be repeated once. So you will be able, and you are asked to be present at all workshops. And we will ask you to fill out this list. So let's say 60, if we are 100 people, 60% will join the workshop 1 today here, and 30 over there, the workshop 2, and tomorrow we will exchange. And this is how it will be done. We have also, all workshops are interactive. There we do ask you to discuss with the faculty. We also have hands-on tutorials. This is how we start today. We have a very interesting right heart cath simulator, and we also have a cardiac ultrasound handheld device to show you. So many thanks to the companies, the Cathy company and Philips Greece, for coming over and also bringing these devices. So please join us and please support this effort. Tomorrow there will be also an extra demonstration and simulation of this right heart cath simulator. I mean, you know, we have many colleagues here who talk about pulmonary hypertension and CTEPH or write about it. And I mean, those who are not cardiologists, I think it's always good when you write about something to know how it works. So I think it will be useful. And then one last thing, I mean, it is a hybrid event. We have to do all events as hybrid events, and some colleagues could not make it. So we are being streamed and filmed here. So always keep this in mind. So let's say behave decently so that you will not be recorded. So of course, if someone does not want to be recorded, you can stay further. So I saw our Dutch colleagues all went to the back, so do not worry. I mean, this is of course, it is not, the cameras are not fixed on the people who are sitting and attending, and they are fixed on the people who speak. And of course, on the discussions, we will have, for example, Professor Prandoni, who will be participating online when Professor Huisman is speaking, and then we will be seeing him here. So, but just keep this in mind. I mean, this is a streamed and recorded event. If you do not agree with this, which is absolutely okay, you can sit further back. I mean, the camera is there. So there are no hidden cameras. There is one here for us, and one here will be for the workshops. Yes, so for my part, I think this is what the most important information. Any other information, we're all here. We'll be happy to, and this is, it's a school, right? It's not a congress, so please join us later and during the lunch and dinner. Very few words. Special thanks to our sponsors, to our lead sponsors, Daiichi Sankyo and Boston Scientific, and we are very happy that our colleagues from these companies are also actually attending the school. To our sponsors, Inari Medical and Philips Greece. And I would particularly like to thank the organizer, in this case the University Medical Center Mainz, because for the first time this is an event that is the majority of the budget, the greatest part of the budget does come from public funding, and they were not only helpful with this, and they allowed us to do it, but they also allowed us to do it during COVID periods, which was not self-evident. And I would like to finish by saying that until 2019, we had with us Professor Guy Mayer. I mean, everyone, I think, who works in the field of pulmonary embolism, venous thromboembolism, knows Guy. He was an excellent friend. And actually, in 2017, he could not attend because he told me that a good friend of him had just died. And he said, it's so sad when people die young. and unfortunately 3 years later he died himself at a young age. But it is very important because all of his legacy, I do not want to list all the things that Guy has done, you know them very well, but it's very important to know that all this legacy continues, and that we will, and of course the spring schools are one proof of this. He was with us in 2019, and of course all this series of the Python studies, which he initiated in the year 2002, continue, and now the third study has been successfully launched. So I think Guy would be happy to see us all together again here, and I really hope, and we hope that we will have a great event and a lot of interaction. We will have fun, and we'll be very happy to be speaking to you through these 3 days. And with this, Menno, I do not know if you want to say something else, but then we will hand over to our other colleagues. So thank you very much again for coming, and let's have a nice workshop and school. So with this, I think we will hand over to our speakers, Sigrid Brækkan and Stefano Barco. Sigrid, 1 second. So that's it. Okay, because now I was worried because I didn't. That is correct, right?
Yes. Yes.
Perfect. So I think we can be. Yes.
Yes. Okay. Good morning, everyone. It's really a pleasure for me to be here. I would like to thank the organizers for inviting me. My name is Sigrid Brækkan, and I work as a professor in epidemiology at the Thrombosis Research Center in the Arctic University of Norway. So I live very, very far north in Tromsø. So it's extra nice for me to be here because we are preparing for winter in Tromsø. The other day I was biking to work in 2 degrees, and now to come here to 20 degrees is extremely nice. Well, we have a session that is called Venous Thromboembolism, Global Trends in Incidence and Mortality. And I'm sharing this session with Stefano Barco. And we have decided to split it into 2 parts. And I will talk about the first part, which is time trends in incidence and risk factors of VTE. And then Stefano will continue with trends in mortality, and then there will be room for questions and discussions at the end of this session. Yes. So I assume that you are all familiar with venous thromboembolism as a common term for deep vein thrombosis and pulmonary embolism. The incidence rate is around 1 to 2 per 1,000 per year in the adult population, and this translates into more than 1 million cases of VTE in Europe every year. VTE has a substantial disease burden, and we will of course learn more about that during these days, I can see in the program. So we are gaining more and more knowledge about the mechanisms of venous thrombus formation, but still a lot of pieces of the puzzle are actually missing. A very commonly accepted hypothesis is that the thrombi occur in the vein valve pockets. And on the inside of the vein valve pockets, we have a vortical flow that serves to flush the blood out as the valve open and closes. But in cases of turbulent flow and also due to gravity, we can get these double vortexes, which actually, or secondary vortexes, which actually induces local stasis and hypoxia. And the hypoxia may activate the endothelium, which expresses more adhesion molecules such as P-selectin, E-selectin, and von Willebrand factor, and these may attract circulating leukocytes, microvesicles, and platelets. And then we know that activated monocytes and microvesicles may express tissue factor, which can activate the extrinsic pathway of coagulation, while polyphosphates or procoagulant phospholipids from microvesicles and also extracellular DNA from nets may activate the intrinsic pathway of coagulation. But still, we don't really know all the sequence of events that occur when thrombi form in the deep veins. There is also this question on whether all pulmonary embolisms actually origin from peripheral DVTs. And in this nice study from Leiden some years ago, they actually did a whole body MR scan of 99 PE patients, and they could actually find signs of a thrombus in only 44% of the cases. We also know that some risk factors are much more strongly related to DVT than to PE, and vice versa. For instance, factor V Leiden and other procoagulant genotypes are more strongly associated with DVT, while conditions that occur in the thorax area, like atrial fibrillation, myocardial infarction, pulmonary infections, and COPD, show a much higher risk of PE than of DVT. So I think there is also more to explore with regards to the mechanisms of PE. I guess you're also familiar with the work of Triad, the pathologist Barco proposed more than 150 years ago that there are three key components that lead to thrombosis, and these are stasis, vessel wall injury, and hypercoagulability. And what we know about VT risk factors today is that we can fit all of these more or less into these three categories. We also tend to classify DVTs as provoked or unprovoked, and we classify them as provoked if they occur in close proximity to a trigger, a strong major transient risk factor such as surgery, trauma, and acute medical conditions. But we also know that around 30 to 50% of the events are classified as idiopathic, but still these patients can have minor persistent risk factors such as obesity, for instance. So what about time trends? The title was Global Time Trends, but I will start for me very locally with a study that we performed in the Tromsø study. And I guess one of the advantages of being a very, district area is that the city of Tromsø is a city with around 80,000 inhabitants, and the next nearest city with a hospital is more than 250 kilometers away. So if you get a venous thrombosis and living in Tromsø, you are very likely to end up in this hospital. So it's easy to trace people, and this means that it's easy to get reliable incidence rates because we can follow people very closely. And what we found was that the incidence increased by 27% in the period from 1996 to 2010. And this was mainly driven by an increase in the incidence of PE. And you can see that apparently the rates of DVT are also decreasing, but this is probably due to the way the events are coded. So if you have a PE and a DVT, you're in the PE category, and as you detect more PEs, then the rate of DVT goes a little bit down. In Tromsø, CTPA was introduced in the late 90s, and as you can see on the curve, there is a quite steep increase in this time period. Of course, probably because we were using more CTPA, detecting more events. But still, the curve increases also at the end of this period. If we go to the US and look at the Worcester study, it looks strikingly similar, I would say. The trend is also an increase in the overall incidence of VTE, and here is the PE curve, which also increases in the same period, and then DVT seems to go down a little bit, and they coded their events also in the same way as we did. So some of the increase was probably due to the introduction of CTPA, but this is a more recent study from Denmark. And you know, Denmark is not only a country, it's also serves very, very well as a large cohort study because they have extremely good population-based registries. And here you can see that also the rates of overall VTE and the rates of PE are still increasing a bit now in the era after the introduction of CTPA. And then the title was Global Trends, and I have shown you curves from Nordic countries and the US, and there are also some recent studies from China and Korea that shows the same trend. In China there's seems to be an enormous increase, but this was also due to an expansion of the hospitals. So more capacity in the hospitals made them detect more events. But I think we can, by looking at these curves, we can at least for sure say that the incidence of VTE is not going down. It's either quite stable or it's increasing slightly. And what can be the contributors to this increasing incidence? Of course, improved diagnostics, as I touched upon, that the imaging quality is getting better. Also more awareness. There has been this awareness campaign, the World Thrombosis Day, more focus in the public and among healthcare professionals of the disease. And this may lower the threshold for suspicion and diagnostic workup. But I think also some of the explanation is explained by an increased life expectancy. We know that age is a very important risk factor for VTE, and the population is getting older. And also, I think it can be contributed to an increase in major risk factors for VTE. And actually, when we look at this graph showing data from the Netherlands, we can see that the prevalence of major risk factors for VTE has increased during the period from 1998 to 2010. If you see in the upper left corner, the number of hospital admissions and patients with invasive malignancy increased by almost 50% in this period. Panel B shows that the population is getting older and more obese, and also, at least before the pandemic, we tended to travel more by plane. You can see that the flights from Amsterdam has increased by almost 80%. We are also performing more surgeries, particularly total knee replacements has increased a lot, and even though we are getting fewer children and have fewer pregnancies, the mothers are older, and we know that a high maternal age is also a risk factor for VTE. The same has been shown in the US. This is a study from Height and co-workers, where they showed that the incidence in this population was stable or slightly increased during the period from 1988 to 2010. And they also showed in the same population that major risk factors such as obesity, here in yellow, surgery and active cancer increased during the study period. And they also calculated population attributable fraction, or population attributable risk, which is the proportion of the total VTE events in the population that can be attributed to a certain risk factor. And for obesity, surgery and cancer, the PUF increased during the study period, and 30% of the idiopathic VTE cases could actually be attributed to obesity. And this corresponding number was 22 for surgery and 11 for cancer. So I think we can agree that improved diagnostics has contributed to increase the rates of VTE, but still we can see that now in the era after the introduction of CTPA, the risk is still, or the incidence is still increasing. There is a higher prevalence of VTE risk factors, but we are also using more prophylaxis. So the question is whether advances in thromboprophylaxis has sort of prevented a further increase in the incidence. We have established thromboprophylaxis regimens for in high-risk situations for high-risk patients, such as cancer, surgery, and medical conditions. But this is, of course always a bit challenging to balance the thrombosis and the bleeding risk with regards to prophylaxis. But we know that 50% of the VTEs in the population can be related to a hospital stay, either that the patient has gotten a VTE while admitted to hospital, or in the period shortly after hospital discharge. And Height and co-workers actually wanted to investigate whether the improved or increased use of prophylaxis influenced the rates of hospital-related VTE. And as you can see from this graph, the prophylaxis rates for those with an indication on prophylaxis actually increased from 40 to 90% in this period. And the question is, did it influence the incidence rates? And the answer is actually no. The rates of hospital-related VTE did not change despite a near universal prophylaxis regimen. So how can we improve? I think that there is still a way to go to try to find better risk assessment models for prevention of VTE. And there is also this discussion with regards to duration of prophylaxis after hospital discharge. But this is, of course, challenging. And I think also the fact that the hospital-related VTEs or the incidence of VTE does not go down despite that we're using more thromboprophylaxis may imply that we have an existence of what we call the Rose prevention paradox. This can occur if the high-risk population only comprises a small proportion of the total number of those at risk. So even though we, in a high-risk approach, try to prevent thrombosis in high-risk patients, we are sort of moving these individuals into a normal range risk. Then we have the other sort of opportunity of primary prevention, which is the population approach, where you, by targeting risk factors in the entire population, may sort of shift the entire distribution of risk. And I think that lifestyle factors for VTE has generally been thought to give a minor contribution to VTE risk. But if we look at, again, the population attributable risk or population attributable fraction, we can see that actually obesity accounts for a quite large proportion of the total number of cases. These are data from the US. It's probably a bit lower in Europe, as the prevalence of obesity is still a bit lower in Europe. Also, we know that physical inactivity is important to avoid, and the PUF or PAR of inactivity contributes to 4%. So maybe there is something to gain, at least for obesity, if we can prevent people from gaining weight. But we know that, of course, the access to food is a little bit too good, and it's not so easy to fight the epidemic of obesity. But maybe if we can find out what the mechanisms for obesity-related VTE actually are. Is it purely stasis? Is it inflammation, adipokines, other things that actually gives the increased risk in obesity? Then maybe we can still find strategies to prevent VTE in obese. And actually, we only need to look over to the arterial side to see that this kind of population approach actually works. I think this is really a successful story. You can see that the incidence of acute myocardial infarction has substantially declined over the same period as the incidence of VTE has increased. And why has this occurred? It's actually because we are intervening on risk factors. We are giving our patients antihypertensives, statins, antidiabetics. We encourage them to stop smoking and to be more physically active. And actually, my colleagues in Tromsø calculated that 66% of the decline in incidence of acute myocardial infarction could be explained by a more favorable profile of lipid levels, blood pressure, smoking, and physical activity. So it really works, but we need to sort of find the equivalent of high cholesterol for VTE to really be able to intervene at the population level. And except from obesity, I think we don't really have or know these risk factors yet. So how can we get there? I think that the future is translational. We should really try to keep an effort to combine population-based research with laboratory research to try to identify VTE risk factors at the population levels and translate these into the lab and find out what are the mechanisms for the increased risk. Is it possible to find targets that we can intervene on that doesn't give an increased bleeding risk? And I think also there's a great opportunity now with the big cohorts that have high-quality biobanks and validated VTE outcomes. There are becoming more and more of these cohorts, and we can apply multiomics, genomics, proteomics, metabolomics, transcriptomics, and try to really put this into a system biology concept and see if we can find biomarkers or a set of biomarkers that increases the risk of VTE at the population level, and whether we can use this information to increase our knowledge about pathways and mechanisms for thrombus formation, and potentially targets for intervention, so that we can target risk factors at the population level. So to summarize the first part of this talk, I would say that the incidence of VTE have persisted or slightly increased during the last decade, despite that we are using more thromboprophylaxis. And this is partly explained by the increased prevalence of major risk factors for VTE. So we have a challenge to try to bend the VTE curve. And how can we do that? I think we need to try at least to find targets for prevention at the population level, because this may lower the incidence. And then to get there, we need to identify risk factors, and we need to know more about the mechanisms of DVT and PE to try to find new ways of intervention. So then I would thank you for the attention so far. And just to say that the Northern Lights season in the Arctic has already started. I took this picture with my mobile camera on Saturday. So yeah, but it's quite cold though. But we will take questions and
Perhaps can we continue with the second talk?
Yeah.
Because we have 15 minutes until the end of the...
Oh, Emma, have I talked to...
But then of course, thank
Yeah.
you very much.
Yeah.
So Stefano will now say everything that's important within 10 minutes, and we'll get the time for questions.
So, please, the slides were the right ones. So, I'm Stefano Barco from the University of Zurich and Center of Thrombosis and Hemostasis Mainz, this double affiliation. If I were a VTE paper, I would start saying that VTE is the third most common cause of death and encompasses DVT and PE, etc. And actually, we did this, we repeated this as a mantra over the past years, saying that more than 400,000 deaths per year in Europe are caused by VTE and 400,000 in the US. And this data actually come from the VIII study and from the study. Actually, it was only an abstract published 2007, and that actually estimated 400,000 deaths due to VTE in Europe per year. But if you think that they only account for 6 countries, this would lead to a mortality rate of 1 per 1,000 population per year, which is exactly the incidence that Sigrid just shown. So probably this epidemiological model was a little bit too pessimistic concerning mortality in Europe, but actually we didn't have much better data until recent times, and the final mantra was that in the US and Europe VTE causes more deaths than AIDS, cancer and car crashes. So this has always been used to raise awareness. And if you look at, let's say, official data from the Bill and Melinda Gates Foundation, there is this yearly update on the global burden of 369 disease in basically all countries and territories. VTE and PE was not included, and the 2 main reasons were that PE is an intermediate cause of death, so patients are not dying because of PE, but it's always something else causing PE and then finally leading to death, and has been classified as a garbage code. So actually it was just assigned to myocardial infarction, and that was all. And this was like this for the past years. So, and before COVID-19, VTE was not included in the WHO list of non-communicable diseases with global plans to fight VTE globally. So thanks God, we had COVID, and then we have now very good plans all over the world to improve, as Sigrid said, the thromboprophylaxis among hospitalized patients. So I would focus on this key question, dying from or dying with pulmonary embolism, and the 3 main points will be then assessing pharmacological intervention. It's not only relevant as an academic question, but also to really target and tailor the therapies and the strategies that we have. And finally, I will focus on trends in PE mortality and fatality. So it's only recently that the group led by Tobias Tricher and many colleagues from the ISTH and DSC actually summarize what dying from PE is. And they took all the papers from the literature and they defined PE-related death as with this hierarchical scale starting from the best evidence, let's say, autopsy with no other causes of death. So just having an autopsy showing you that there is a PE in a dead body is not enough to classify, formally to classify this death as PE-related. And they define this as together with the absence of other likely causes of death as the most clear evidence that the patient died from pulmonary embolism. And then they added subsequently two additional definitions. And the main aim of this definition was to standardize the evaluation that we do of intervention strategies and finally the interpretation of clinical trials to prove that the treatment is effective or is not effective to prevent PE-related death. And so if we test the treatment, any treatment, it would be nice that we can impact overall mortality. So we have a treatment that is reducing mortality within hospitalization, within a couple of weeks in the case of acute diseases. But in this case, it's also important to target and to study strategies that are reducing PE-related mortality, in this case defined as PE-related case fatality formally. And I try to identify, following this main question, dying from or dying with PE, two main groups of patients. The first one are those patients who have a high risk of dying, let's say cancer patients, COVID patients, and ICU. And in this case, the baseline or the main disease is not VTE. VTE is probably more a marker of disease, of the severity of disease. This doesn't mean that it's not relevant to prevent VTE, because VTE can lead to long-term sequelae, complications and problems, and the well-being of the patient will be impacted. But just to say this patient would likely die from the main disease, and then on the side they might develop VTE because they are very sick. But on the other end, on the other side of the spectrum, we have patients with high-risk PE, and these are the patients who are most likely to die from PE because PE is the main driver of their disease. And I found a nice case report in the literature. The senior colleagues from you know this certainly. And so the Dr. Professor Brenner postulated that Jesus Christ may have died of pulmonary embolism. So off, I can assume, Andrew might correct me, off means from, or so PE, the main driver of death. So, and he also realized that some of the risk factors listed by Sigrid were present: multiple trauma, immobilization, dehydration, etc. In this case, PE was probably preventable, because if you just avoid hanging from a cross, you would not get a PE. But on the other end, PE-specific treatments would have not worked, so just giving thrombolysis might not improve the outcome because the PE was not the main driver of death. Same thing is for COVID-19 patients. So we have very sick patients with COVID-19 in the ICU, and we have now very good data from phase 3 trials showing that therapeutic anticoagulation compared to prophylactic actually reduced the number of VTE during hospitalization and PE, but fatality was not impacted because the main driver of the prognosis of this patient was COVID itself in the most severe form. On the other hand, it appears that therapeutic anticoagulation might not only reduce VTE events among patients not admitted at the ICU with COVID-19, but might even improve survival and reduce organ dysfunction, just because actually in this case, VTE is pathophysiologically involved in the process leading or not leading to death. And I think this is also the same case for cancer patients if you look at the phase 3 trials. So. The final point concerning this optimization of outcomes in epidemiological perspective is actually how can we reduce PE death, not because PE death is the best outcome for PE patients, or at least only for some PE patients, but because this is the topic of today's talk. So prevention and timely diagnosis is clearly a priority. And on the other hand, if we have this subgroup of patients with high risk or with severe right ventricular dysfunction, who they should first of all be identified, and second, we should provide them with PE-specific treatments. And these are the PE-specific treatments that one would apply to patients with severe PE. and finally do not harm. So an intervention should not increase the risk of other complications such as bleeding. Now finally let's move to the final part, so trends, resources allocation, global strategy. So this is the third answer why it's important to answer the question whether one is dying from or with PE. The incidence rate data has already been shown by Sigrid, and here I'm showing some data on case fatality rate. So case fatality defined as the number of PE deaths, not in the general population, but among patients with the diagnosis of PE. You see that for some countries there are two values. Actually, these data, the lower data, are accounting for PE as the main cause of death, as the underlying cause of death in the vital registration databases. The higher values are referring to PE as a concomitant cause of death. And you see that there is a reduction in case fatality rate, which actually a bit is in contrast with the increase in the incidence rate. And one of the reasons could be that actually we are performing better treatment, doing better treatment to these patients. So actually treating these patients centrally in high volume centers, and it was nicely shown by the VIII group. Dr. Jimenez is here today, that the more experienced the center is, the better the prognosis of our PE patients is. So this might also lead to an improvement or partially explain these trends in case fatality rate. Another reason is that we are now diagnosing more low-risk patients. So if you see these figures, you see here that the proportion of fatal PE might have remained the same, only if you account and you calculate the case fatality rate. If you inflate the denominators, you have more PE diagnosis, automatically the case fatality rate will fall. And this might explain in some studies why the case fatality rate, but the incidence rate is increasing. So it's only an apparent increase of the number of PE cases. It might be due to overdiagnosis. Some would say so that now we are diagnosing the right number of VTE, so it was underdiagnosis before, not now an overdiagnosis. One could also postulate that there is a better general treatment of patients with PE, or other factors related to the way we classify these patients, so DRG reimbursement, legal issues, or assessment or counting basically the prevalent cases and not the new cases, the incidence case. So this all might explain the decrease in case fatality rate. And actually coming back to the first slide, it was very hard at that time to find any study telling you what is the mortality rate, the annual mortality rate due to PE. So as said, case fatality rate is the number of PE deaths out of total PE patients. Mortality rate is the number of PE deaths out of the general population. So this should not be influenced by having more low-risk PE being diagnosed, because it's independent, so the denominator is just the general population. And funnily enough, there is a database, a WHO database with this data made public, so you can actually do some analysis, and this is what we did to fill this gap in the literature. And we showed that there was a decrease in PE-related deaths from 13 to 7 per 100,000 population. This, however, refers only to PE cases diagnosed as the underlying cause of death. So PE, cause B, cause C, cause D, which led to death. So this is really a very sensitive assessment and estimate, so it might be only higher than this. And what we also found is that the highest mortality was observed in Eastern Europe, as it is for other cardiovascular diseases, and there is an increasing trend in Central Asia. And then we repeated the same analysis with the Wonder CDC data from the US, and we found more or less the same information. So there was an overall decrease in PE-related mortality. But again, there are some subgroups or some areas where the mortality was much higher, particularly among black people and among middle-aged adults, which actually showed a similar trend also for other cardiovascular diseases. So overall, the PE-related mortality trend is a decreasing trend, but in these two groups, actually stable, or in middle-aged adults is increasing. And what we also found is that if you consider PE as the main cause of death, you will come to a 7 to 10 deaths per 100,000. If you consider PE in any position of the death certificate, then this percentage is much higher, so 15 to 25, but still much lower than the estimates from the VIII study. Cancer, as shown, is now the main risk factor for PE-related deaths. So among PE deaths, PE was listed as the fourth cause of death in 30% of the patients, which is exactly what you would expect in observational cohorts. So out of 100 patients with VTE, 30% would have a unprovoked, so-called unprovoked VTE, and it was funny to see that there was a consistency about that. But now cancer prevalence is increasing, and is increasing much faster than in a non-PE population. So it's now explaining 1/3 of PE deaths, and a much lower proportion in non-PE, among non-PE deaths. And I think another very, and I have another 3 minutes, another very interesting information we got was the relative impact of PE. So in this case, the number of deaths are calculated out of the total deaths. So you see here that overall in Europe, and these are data from the US and Northern America, are a bit bigger, between age of 15 to 55, PE explained approximately 2% of deaths among young women, but this was not the case for men, for whom the curve was a little bit flatter. So I think that if one wants really to propose and to push and to increase awareness of VTE, one should not just count deaths and say, okay, we are the third most important disease because we have 400,000 deaths per year, but just telling the general population that it can be a fatal disease among young, otherwise healthy women. And Lucas Robin, Dr. Robin, did a very nice study last year and studied what is the impact of PE on among pregnant women. And in Germany, over the past decade, PE still causes 15% of maternal deaths. And women who are presenting with PE and who are initially decompensated have a case fatality rate during hospitalization of 37%, which is absolutely incredible in Western countries in 2015. So I think this would be a very good argument to say that PE is relevant on a global level. And this is for sure an area for which one should improve diagnosis first, prevention, and also treatment, because actually what we found is that many of these women did not receive any type of thrombolysis or reperfusion treatment. And this was probably the explanation why the case fatality rate of young women was exactly the same as one would expect in 80-year-old with high-risk pulmonary embolism. And just to conclude, very final analysis published a couple of weeks ago, we put together all the available data from the national registration databases from 123 countries, so more than 2 billion people assessed and studied the proportional mortality and the mortality due to PE across the globe. And we found that there is a correlation, so the higher the income of the individual country, the higher proportional mortality and the PE-related mortality. And this has clearly to do not only to the prevalence of risk factor, but also to the fact that there were more diagnosis and more awareness probably in these countries. And you see this clearly here for proportionate mortality, but was the same for PE mortality. And just to conclude, everything we have discussed today concerns basically just a very, very tiny part of our globe. So these are the countries for which we actually got information on PE-related mortality, and this is probably just 1/3 of the whole general population. So always keep in mind that the evidence we have, the epidemiological data we have, etc., just refer to a minority of the population. And with this, I would like to thank you very much for your attention.
Perhaps you can also come to the podium for a second. So, many thanks to you both. Could you show the previous slide? I mean, before Zurich. I think that's interesting because Stefano did again the map of the world, right? And not the Mercator scale. So now it's correct that the countries in the north are not as huge as they appear. So that's really great. Many thanks to you both for the perfect presentations. And I think you succeeded in making a subject of epidemiology, which is generally, let's say, dry. It's not like showing cases of clot busting in PE, but it's of course very important. Brief question. We only have, let's say, 3 to 4 minutes. A brief question to you both, perhaps to Sigrid first. You said very nicely, does this work? Yes, it works. You said very nicely that, of course, prevention is great. It worked for myocardial infarction, but there, of course, the industry found also some nice field like statins or antihypertensive medication, antidiabetics. Well, here in VTE, it's more difficult, and losing weight is unfortunately eating less, and that's not so easy. It's not a lot of market in it. But do you believe? I mean, there have been some thoughts about giving statins for primary or secondary prevention. They more or less stopped when the DOACs or NOACs came out. Now there is some resurgence. There's also a study coming from Canada in which we participate. Do you think that this might work in VTE, or will we still be seeing these stable or rising tendencies and just hope that people will get less fat?
Yeah, that's a good question, whether statins for primary prevention of VTE, whether there is a room for it. I think, well, for secondary prevention, there has been some studies, and statins might have a role there. But for primary prevention, I think we are not still there yet. I think it's difficult. I think it's, well, first we would need a trial to actually look at this, but I think the numbers needed to treat, to prevent one would be too big for the general population. So I don't think there is a room there. But yeah, maybe for some certain high-risk group, I don't know. But yeah, we're not there yet. Yeah.
Yes, it's difficult, I think. Yeah. And Stefano, brief question. COVID-19 era, not VTE related or due to COVID disease. I mean, Olivier will be speaking about this, but do you think we will be able to show any trends or any spikes in the year 2020 or 21 due to sedentary lifestyle and not moving in the COVID era, or will this be very difficult to dissect?
I think some very recent data shows that there was for sure a trend in CT-PA use. So in some countries it increased, it boosted. In other countries it was reduced, and consequently also the incidence of PE. So I think this was also nice information to have. We might see in 2 years what the results are. So CREATE 2023 will show this data perhaps.
Very good, thank you. So any burning question from the audience? So if not, in order not to get the, I mean, these are our lectures, our plenary lectures. In the interactive sessions you will have, of course, more time for questions. I must say that, of course, Zurich is, with the lake is more beautiful than mine, although mine is also okay, right? And so that, and yeah, and with this very nice lectures, thank you very much. And we'll now move on to Menno Huisman, who will talk to us about one of his, so Menno can talk about anything regarding PE, but he will talk about cancer and PE, and we will have, of course, also a special guest. You saw, Menno, that we have the Leiden University Medical Center in the middle, so that's, and we will also have Professor Prandoni online at the end of Menno's talk. Thank you.
Thank you very much, Stavros. So good morning, everybody, again. So let me first tell you that I can talk indeed on several subjects, and not in the least on mythology. And I want you to remind this, because this will come back at a later moment at this spring school. So we have just heard from beautiful lectures that there are many risk factors, but cancer is one of them, and it's very prominent. This was indicated by Sigrid, and then followed up by Stefano, and referring to his paper in Lancet Respiratory Medicine 2020. A huge work he has done, and I really advise you to read it. By the way, since this is recorded, you will get a possibility to look back at all the presentations after you have left this school and get back to your country. Let me last do the introduction that really looking at the Barco presentation, I do not want to get a PE because middle-aged, there is a trend. Now, the burning question is, am I middle-aged? But that is for the gin and tonic interval. Okay, let's kick off. So I'd like you to have a short look at this picture. This is not Amsterdam, this is Leiden. And although it has some similarities, all Dutch cities, who has been to Amsterdam once? Yes. Who has been twice in Amsterdam? Yes. Who has been 5 times in Amsterdam? Yes. And more than 5 times. And who is living in Amsterdam? Nobody. Okay. Who has been to Leiden? Oh, twice to Leiden. 5 times to Leiden. Who is living in Leiden? No, not me. Okay. So Leiden is not a small Amsterdam, it's a different city. Let me just tell you that this is a bridge across the Rhine, because the Rhine starts in Switzerland, but it ends in the North Sea, but it flows through Leiden. And that's why Rembrandt is not called Rembrandt, his surname is called Rembrandt of Rhine. And he was born, by the way, in Leiden and died as a poor man in Amsterdam. One word about Dutch thrombosis network might come back in the interval. We have a very interesting network of networks called Invent VTE, and it's particularly interesting to become a member of the national networks. And one of the national networks is Dutch Thrombosis Network, and we try to expand this. And there are many networks, many countries, so in the interval, please come to me or come to Stavros. Stavros has a network in Germany. Mark is active, Righini. There are many members, David Gimenez, so please, keep in mind. Now about the subject. Let me just give my disclosures. So I have been a member, I'm still a member of the Caravaggio steering committee, and we have published, as you probably know, many of you, and will show in detail the Caravaggio study comparing apixaban and dalteparin in patients with cancer and venous thromboembolism. And the LUMC gives grants and fees from a body of Heart Foundation, Dutch Heart Foundation, and also companies. So let me present you a case, 70-year-old male with a gastric carcinoma. This patient presents with what turns out to be a pulmonary embolism. Let's be very short. Good blood pressure and bilateral segmental pulmonary embolism at CTPA. There's also tumor progression. The patient will start soon chemotherapy, which is consisting of paclitaxel and ramucirumab, an anti-VEGF2 monoclonal antibody. This is some laboratory, so some slight reduction of thrombocytes. As you see, anemia, creatinine clearance is fairly okay, and no increase of troponin. So my first question, and we just do by hand raising, how do we treat this pulmonary embolism right from the start? So who is in favor of the first, low molecular weight heparin followed by vitamin K antagonist? Nobody. Low molecular weight heparin for 6 months. A few. Low molecular weight heparin followed by a DOAC for 6 months. 3, 4. I mentioned which, but for sake of time, I'll just continue. And DOACs at front for 6 months. Whom? Nearly nobody. Okay, so that's interesting. And there are a lot of fingers not raised, which is why I have this talk. Okay. There's some rumor in the audience, that's good. Just discuss with each other while I'll just continue. And this is a graph taken from Sihan I. It's a beautiful paper. I'd like you to read it. Thrombosis hemostasis some years ago. And I often use this because it nicely depicts the risk factors, which can be tumor-related, right upper part, patient-related, and treatment-related. And there are also, interestingly, some biomarkers, and these are particularly interesting when you look at what the risk is to get the thrombosis when you have a cancer. This is not the subject for today. I'm not going to dissect all the details of this, but just have a look at it when you read this paper. Now, of course, we know that there are now DOACs. In the Netherlands, we use them since 2008 for prevention after knee or hip surgery, and we use them for VTE since 2016. This may vary, of course, from country to country. This is interesting to discuss at the coffee break. But it's intriguing, of course, how they have been developed. If you look back at the development, read the papers on pharmacology, this is really interesting how they came into play and how long it took before they came into practice. That's another thing I'd like you to remind. We're now seeing factor 11, anti-factor 11 molecules coming up and being evaluated, but it takes a long time. This is not for today, but factor 11 is of course interacting with the contact activation coagulation, and this might be the winner for preventing thrombosis and artificial heart valves. Some features, only mentioning one or two for those who are not daily working with them. You know, you have one thrombin inhibitor, this is dabigatran, and a couple of 10A inhibitors, so only inhibiting the activated factor 10, or the thrombin, the activated prothrombin, and there is a clear difference in renal elimination, so preponderously eliminated the dabigatran, which you have to take into account, and of course with cancer there is a lot of renal failure, but unfortunately dabigatran has not been evaluated per se in cancer patients present VTE. There's a small part in the non-cancer comparisons. And these are not eliminated so much by the renal system, so that is an important difference. And there's also a difference in terms of half-life. It's longer for dabigatran than for 10A inhibitors. Now, one quick view at the meta-analysis done. There are a couple of meta-analyses, and this is a bit of chauvinistic. This is one we did. It's, I think, in fact, the first. Tom van der Hulle published years ago. What we showed and others showed that there is no difference in terms of efficacy if you compare DOACs to the traditional vitamin K antagonist preceded by low molecular heparin in a population which was not at all saturated by cancer patients. Only 4 to 8% cancer patients in these trials, primarily smaller cancers. So non-inferiority in terms of efficacy, and really the difference were made, as was seen in some of the DOACs in AF population, in the bleeding, and the different parts of the bleeding you can see on this forest plot. So this was of course a very important message, so significantly less major and fatal bleeding. This is why the DOACs, apart from the practicality, have become so much in vogue. We just saw an overview in the Netherlands the other month, and 9 out of 10 patients really get a DOAC and not vitamin K antagonist anymore when they present with DVT or PE. Now, what is relevant for a moment for DOACs in patients with cancer? So first, liver and renal dysfunction occur often, as I said before, and liver, of course, you have to remind that in the official label of the DOACs is liver enzymes. Do we measure them? Well, sometimes we do, but you have to be a bit careful if you are confronted with a cancer patient. Cancer patients often get invasive procedures, and of course they often or sometimes have thrombocytopenia. This, of course, for most with the hematological cancers, but it can also occur with the more invasive chemotherapy in solid tumors. Then there is a potential interaction between DOACs and chemotherapeutics, including immunotherapy and angiogenesis inhibitors. And this is, of course, important, but a general rule of thumb, we always say to each other in the hospital, anti-cancer drugs influence DOACs, that direction, but in general, not the other way around. And this is very relevant when you discuss with your patient or with your colleague oncologist, because there is hesitation. And at the end of my presentation, I have a very useful website where you can look up all the cancer drugs interacting or not with the DOACs. And this is particularly relevant also for our patient. Okay. Now, Paolo Prandoni published years ago this seminal paper, and Paolo is listening because he will give comment on my slides. And he was particularly, of course, interested in looking at this slide. He knows by heart. So what is at stake in the patient with VTE and cancer? Well, first, you have an increased risk of recurrent VTE during treatment. And this is depicted on the left side in this Blood 2002 paper. But this is, well, old or traditional anticoagulants. You know, this is not with the DOACs, I warn you. And it's unfortunate that also they have a higher risk of bleeding while on anticoagulant treatment. So this is why it's really a dilemma. Now, we know that this seminal publication of Agnes Lee was published, and this really introduced low-mercuric heparin as a first-line treatment for the 6 months of treatment in VT and cancer. There was much more recurrence in patients put on low-mercuric heparin followed by vitamin K antagonist than in patients put on dalteparin over time in the first 6 months. But I remind you, and this is a bit obscured sometimes, that the comparator was vitamin K antagonist and the INR was the TTR, so that's the time in range. INR was 47%. So this is not very high, but the command always of Agnes was, yeah, this is one regimen versus the other. And we know that due to the intervention, individualized INR, this can wax and wane. And that's why low-mercuric heparin came out. Now, I'm going to switch gears to show you 3 studies that have been published. And the first published is the Hoxha VT cancer study. Many of you have contributed to this study, a very important study. And the design was fairly straightforward. So patients with confirmed VT and cancer, and the definition was active cancer or diagnosed in the previous 2 years. I cannot comment on these previous 2 years, but a sub-analysis, very short, had shown that you stay at risk for recurrent VT, even if you have had this cancer within the period of 2 years. That's why. So just over 1,000 patients randomized between low-mercuric heparin, followed by edoxaban. That was the same regimen used in the non-cancer edoxaban trials. And the regimen of the edoxaban was also the same. So there was a reduction of edoxaban when you were a bit more fragile. And the comparator was, in any study of these studies, dalteparin. So titrated dalteparin, 200 units per kilo in the first months, and that traded down to 150 over 12 months. And that's a particular feature of this study. They went up to treatment up to 12 months. And it's different, for instance, with our study, the Caravaggio study. Now, these are the main results in one slide. So edoxaban did better than dalteparin, and particularly so in DVT, but it gave more major bleeding, and that was a surprise. And that was a surprise. When it was presented at the ASH meeting 2018, that was really a surprise to all audience. And why was this more major bleeding in the edoxaban-treated patients? Well, that came out to be particularly in the gastrointestinal side, and much more in the upper than in the lower gastrointestinal side. And that's why, of course, I took the patient with gastric cancer. Urogenital was a bit less, but also some signal. And people have, of course, wondered, and there have been sub-analysis done, and of course, it sometimes has been played down a bit. It's, you know, major bleeding, including hemoglobin lowering, but still, you know, if you get this signal, this is important. You have to be careful. You have to choose your patient when treating with edoxaban or low-mercuric heparin. And it has been said that these are the soft tissues, and there's some interaction giving bleeding with the 10A inhibitors. This is food for thought and research. There's another more pilot-like study, the CELAC-D study, evaluating rivaroxaban, also published some years ago. And it virtually is the same signal, so it was better for the DOAC. Also, because people took better their DOACs. It's no surprise. The punctures are not very friendly. We did one study, follow-up study, per-value study by Saka van der Wal, published in GTH years ago, and we saw that 1 in 5 at least stop before 3 to 6 months because they cannot stand the injections. Everybody knows this. So the same signal for major bleeding, even so that during this study, the steering committee halted the inclusion of gastrointestinal cancer patients. And this is, of course, it's well reported in the journal, but this, of course, is an important message. Now, I'll tell you, when this signal came through, we were still busy with the Caravaggio study, and we emphasized, our investigators begged them to include the patients with gastrointestinal malignancy. And we were successful in that. I'll show you in a minute. So don't read all the figures, but this just an overview. When you go back to my slides tonight, of course, after the drink, and you see that there was also a smaller study, but this is really a small pilot study, Adam VTE study. It's also published now, which was giving a very low incidence of recurrent VTE as well as major bleeding. I think the Caravaggio study is much more important. So I don't want you to read all this, but the lower part is, I think, very relevant, and it came not pre-hoc, but while we were busy with this study. The clinical benefits of the DOACs, then published, so edoxaban and rivaroxaban, was a bit limited by an increased risk of bleeding, mainly occurring at the gastrointestinal sites and to some extent also the ureterogenital sites. So we had the same design as the Hoxha VT cancer study. I don't go into detail. The same regimen as in the apixaban non-cancer VTE trials. So starting with 10 milligrams BID for a week and then tapering off to 5 milligrams BID. We had an endpoint at 6 months, and the endpoint, by the way, in the Hoxha, I forget to tell you, was a mixed endpoint of recurrence and bleeding. We had the endpoint of recurrent VTE because it's an antithrombotic, isn't it? And the main safety endpoint, of course, was major bleeding. Now we included, to come a bit closer to our patients, so symptomatic or incidental VTE. This is also interesting, of course, for one moment, because, of course, due to staging, CT scans are made and they look at the pulmonary arteries and they find an incidental PE. And that patient could also be in this study, and we had a cap of 20% because we were interested to look at the follow-up and whether they will behave the same as the symptomatic PEs. So, as again said, we had an efficacy outcome as a primary outcome and major bleeding as a safety outcome. Now, these are the patients at baseline, and these a lot of figures. You can read it in the New England Journal of Medicine paper in 2020. And what is, I think, relevant is to highlight, so a bit over, you see, oops, yeah, a bit over 50% of PE with or without DVT. So it's a really serious population. And again, 20% of incidental, but the majority had symptomatic PE. And there were active cancer in nearly all patients. And what is, of course, relevant, coming back to my point of putting in enough gastrointestinal malignancy, this is the type of cancer in both treatment groups, randomized study, of course. You see there is a lot of colorectal, but there's also pancreatic or hepatobiliary, upper gastrointestinal, but not so much. So this is again relevant when we look back to our patients. Now, I assume that most of you have seen this, but just for repetition, those who have not seen it, we didn't see any difference in terms of outcome, either apixaban or dalteparin. And there were some differences when you break down, but this is, of course, post-hoc viewing and hypothesis generating. The primary endpoint was really meeting non-inferiority. The biggest surprise in our study was the outcome of bleeding. The outcome of bleeding. So the major bleeding was the same in both groups. And of course, we're particularly interested in looking at major gastrointestinal bleeding. This was looking back. So again, hypothesis generating, but nevertheless, I think important. You see no difference in the non-GI bleeding. There were more, slightly more clinical relevant non-major bleed, but then we, of course, look at the very sensitive endpoint. Can be still relevant if you combine all the studies together. We are busy with doing an EPDMA, but this is a logistical hurdle to say the least. So it's still in play. If you look at the size of cancer, then you see that there was really a comparable number of gastrointestinal tumors in both treatment groups. Important for looking at this sensitive group. And now it gets more interesting, but the numbers, of course, get smaller. If you break them down to the cancer site and major bleeding, you see that there is the same. But there is 2 in the apixaban in the pancreatic or hepatobiliary. Of course, 2. The numbers are very small. And the gastrointestinal malignancy, upper gastrointestinal malignancy, very small, but the same. Now this, are a complicated slide, numbers, because a lot of numbers, and there was a sub-analysis published in the first answer, Walter Ageno. And this is, of course, interesting because we were asked, is there a difference between resected and non-resected cancer? Which makes sense. Of course, if the tumor is still present, you might envisage that there is a higher risk of bleeding. Now you see that this is the resected part, and you see that there is no bleeding, and this is the non-resected part. And then it's, of course, interesting, what does the apixaban do? Again, the numbers are very small. It's a hint. And the same for the upper gastrointestinal, and the same also for hepatobiliary, although here again you see, of course, this major bleeding is more prevalent, but the numbers are very small. One remark on these Kaplan-Meier curves, as was seen in other studies, but it was very interesting that the recurrence rate came up after 30 days. And of course, you might think that this is due to the fact that patients took less of their drug when they had to puncture. You know, it was an open study, and well, we cannot tell for sure. There was some difference. It was more prominent in the Hochschild-Vitican study after 6 months. A lot of patients went off their low mercury heparin when they were randomized to that group. Was a bit less prominent in our group. Still, there is a difference. So what are the unresolved issues? The clinical benefit of DOACs in patients after 6 months remains unclear. We have now the APICAT study, which is a very interesting study, comparing full dose of apixaban, 2.2 times 5 milligrams versus 2.5 after 6 months in tumors, and it's led by Isabelle Mahé of Paris. If you're interested in this study, please come to me or Olivier Sanchez, who is a close colleague of Isabelle. More data are required in patients with known intercerebral metastasis. This is interesting for a point. Think of that in atrial fibrillation, much less intracranial bleeding. So why don't we put patients with intercerebral metastasis of primary brain tumor on DOACs? They're excluded, and they were excluded in the most of the studies. And the same is for acute leukemia. And then finally, the observed absence of gastrointestinal bleeding with apixaban, although promising, should ideally be confirmed in studies with a larger population. Well, this is, of course, a nice thing to say, but will there ever be such a study? I don't know. So, very short, these are the ESC guidelines, because guidelines will guide our practice, but not to the extent that we do not make local hospital protocols. This is, I think, crucial. It's not the same. But this was in 2019. First author is a well-known person present in this audience, and edoxaban or rivaroxaban should be considered as an alternative to low mercury heparin, with the exception of patient gastrointestinal cancer. I think we were dealing for 2 days on this sentence, very sensitive, of course, but we put it like this.
And that was, of course, before the Caravaggio.
Yeah, I'll come back to that in 1 second. Thank you. This was before publication of Caravaggio. Now, and I couldn't resist tell you what our recommendation were since last April, when after publication of New England Journal of Medicine, we said that DOACs are equal to low mercury heparin, who went a bit further, and apixaban is equal to low mercury heparin treatment in patients with cancer, including gastrointestinal malignancy. So if there's the colorectal cancer, we have no problem. We are still a bit prudent with the upper gastrointestinal malignancies. And that is stomach, esophagus, duodenum. And we're deciding this with Eric Clock in 1 minute. Okay. Finally,
Eric is getting slow.
that's right. I'm nearly finished. So this is the handy website. Excuse me for putting it like this. But you can look at interactions. I think it's an FDA website, but I'm not pretty sure. Interaction between ramucirumab and apixaban, I had never heard of. Who has ever heard of ramucirumab? Ramucirumab. Who has ever heard of this? Perfect. 1. Increased risk of bleeding with ramucirumab only. That's what it says. It doesn't explain how high the risk is. You know, pharmacists, hospital pharmacists, who is a hospital pharmacist here in the audience? Okay, they will always tell you there is an interaction, because that's one of their job definitions. But we tend to play down. But we looked at it and we said, well, we cannot deny it. And on top of that, that we're prudent, since gastric carcinoma is in situ, no apixaban was given to the patient. So this is what is the treatment for this patient. We start this patient on low molecular heparin. Of course, we know that this patient is in danger of his life. Coming back to the presentation of Stefano Siegert, you know, this is a very severe cancer, and this is another ballpark. And I can inform you that Eric Klok just sent in a Horizon grant application for end-of-life treatment with anticoagulants. Very interesting. Many of you contribute to this application. We hope it will shed light on this difficult decision process. So take-home messages. CAT is associated with a high risk of new thrombosis and high bleeding risk during anticoagulant treatment with VIII. I didn't comment on the outcomes in Caravaggio. Specifically, they're still occurring, but it's less than during the old treatments. The DOACs show superior effectiveness in the treatment compared to standard low molecular heparin. The bleeding risk among DOACs vary by DOAC, but of course it's not a direct comparison, so we have to be a bit careful in stating. And they are the first choice, you may say, if patient is qualifying, but there is still some questions on GI tumors. Thank you very much.
Good morning, everybody. Good morning, Stavros and Meno. Thank you very much for inviting me to give a small contribution and give me the opportunity to be with you, at least virtually. So, not surprising for me, the presentation of Meno Huisman is extremely clear, didactically effective, and very stimulating, and basically agree on all his conclusions. Finally, we have oral drugs that are easy to administer, do not require laboratory monitoring, and possess a favorable benefit-to-risk profile for people who are expected to require a long-term anticoagulation and in whom vitamin K antagonists perform disappointingly. As Meno said, the new drugs should now be regarded as the first choice treatment in patients with cancer-associated thrombosis. The length and the intensity of treatment beyond the first months is still uncertain, but is likely to receive a proper answer from a few ongoing studies, including the APICAT study that was just mentioned by Meno. However, I would like to draw your attention to 3 points. As Meno said, based on the findings of available comparative studies, the novel drugs are expected to reduce the rate of recurrent VTE over low molecular heparin, while probably increasing the bleeding risk from the gastrointestinal and the urinary tracts. That is the area of absorption and elimination of the drug expected. Not surprisingly, because it's a common find to observe this kind of bleeding also in patients without cancer, while on the novel diuretic or anticoagulants. However, in my opinion, the superiority of the novel drugs over heparins in terms of efficacy is uncertain. In all available comparative trials, the dosage of dalteparin was reduced by approximately 25 to 30% after the first 3 to 4 weeks, according to the scheme adopted in the CLOT study. If we look at the results of the single as well as the combined study, the difference between the two drug categories in terms of recurrent VTE became evident only after the first month, when the dose of a low molecular heparin was reduced. There is no evidence that the DOACs would have been more effective than heparins if they had been compared with uninterrupted full doses of heparin, according to the scheme adopted for tinzaparin in the CATCH study, or for enoxaparin in the CANTANOX and the ONCANOX study. Second, needless to say, the generalizability of the study results is problematic. In all available comparative studies, the proportion of patients considered for inclusion but then excluded was on average 2 to 3 times higher than that of recruited patients. The reason is easy to say. Patients with severe renal or liver failure were excluded, quite common finding in patients with advanced cancer, as were patients with thrombocytopenia or recent bleeding, patients with brain metastases, carriers of vena cava filters, patients with unstable pulmonary embolism, with antiphospholipid syndrome, with extension of recurrence of venous thromboembolism while on anticoagulation, those require antiplatelet drugs, except for low-dose aspirin, those with conditions precluding the ingestion of drugs, those with prostatic heart valves, with thrombosis in unusual sites, and so on. So as the proportion of cancer patients with one or more of these conditions exceeds by far that of patients without them, unfortunately for the time being, in most cancer patients, the use of the novel drugs cannot be considered yet. And a lot of work remains to be done in order to extend the use of the novel drugs to the vast majority of cancer patients with VTE. Last but not least, the novel drugs lack that flexibility of use represents the most appealing aspect of happenings. Indeed, the happening dose can be modulated in a wide variety of conditions, requiring dose adaptation according to the fluctuation in clinical or laboratory features that consider the variation in the body weight, the fluctuation in the platelet count depending on the cycles of chemotherapy, the fluctuation in the liver and or renal failure depending on a variety of conditions such as dehydration, fever, additional therapy, development of metastasis, the common occurrence of nausea, vomitus, impairing the use of oral drugs for a variable period of time, for example, in the postoperative state or during chemotherapy, the development of extension of recurrence of VTE while of treatment, requiring an escalation of therapy currently not allowed for the dogs. So for the time being, the flexibility of dogs is very low, if any. In conclusion, fortunately, we still have drugs such as the low molecular heparins in our therapeutic armamentarium. However, a great step forward in scientific research and the clinical practice has been taken with the introduction of the novel drugs, and I thank Menno for presenting so clearly the evidence we now have in favor of their use. Thank you very much.
Thank you very much, Paolo. So thank you for this most stimulating comment, and I wouldn't have expected less of you. And I also am looking at your beautiful landscape slide behind you. This is perfect. I would suggest that we do two things. We have time for short questions. Let me start by who wants to raise a question to Dr. Prandoni. Any comments? Let me just start very short that I think your point of flexibility is a crucial one. This is what we have to remind ourselves and we confront in general practice, because indeed some patients cannot stand oral drugs for some time. So patient journey in terms of anticoagulant treatment while putting patient on DOACs is one of the crucial points. Another point taken, of course, Paolo, is the exclusion criteria, which nearly always are there. And they are coming back into clinical practice. Antiphospholipid syndrome, you cannot use DOACs, renal dysfunction, etc. So, David, please.
I'm pretty sure that you presented your case just to set up the stage, but please, we have to take into account that anemia was a universal exclusion criteria for the use of anticoagulation in all the cancer trials. So I missed a choice being inferior vena cava filter. Can you comment on this, please?
Yeah, so the question, Paolo, I hope you understand, and anemia exclusion criteria, well, what's a bit different among the different studies. We had an exclusion criterion for thrombocytopenia, and in fact, in the Caravaggio study, you know, we didn't encounter this so much. Of course, if there is anemia and patient has a thrombosis, you have to consider whether it's too low. I would say that in general practice, if patient has an anemia of 6.0, we would still start if there is no suspicion for bleeding from this gastrointestinal malignancy. If there is, of course, we might be prudent, and then, of course, if there is a contraindication, we would consider a retrievable filter. So thank you. Any other question? Yes, please.
A comment on urological malignancies, please, because we use DOACs, urological, bladder.
Yeah, but you'd like me to comment? Okay. Well, there was some signal also in the Caravaggio study. There was a signal in Hoxha-VT cancer. So it was not to such an extent we consider it a contraindication, but we tend to be careful, and it's a clinical decision making. And if a patient has a sign of bleeding in that malignancy, then of course we may go to low molecular weight heparin, but don't forget that low molecular weight heparin also can give bleeding. So it's of course a relative difference, and the difference is not so extensive. So I don't know what your process is. We will come back perhaps in workshops if we can attach to such a patient-related problem.
May I have a
yes,
question?
Piotr.
Yes. Since apixaban and other drugs are so good in patients with malignancies, could you define a patient with VTE whom you would like to treat with molecular weight heparins?
Well, that's Piotr. Your point is really coming back to our patient. If a patient has an upper gastrointestinal malignancy, either resected or non-resected, but especially if it's non-resected, we tend to not give the DOAC up front, unless a patient is really do not want the low molecular weight heparin. That's another way to go in terms of patient journey. You can start on low molecular weight heparin if the patient say this, I cannot stand this anymore, and you have seen that there is no bleeding problem, you can switch to a DOAC even in this patient.
Okay.
Paolo, you like to comment?
Yes, I agree. Let's not forget that most contraindication to the novel drugs are contraindications also to low molecular weight heparins. This should be very clear in this regard. Heparins can be more easily adapted to each single individual according to his or her condition. Yep. You can modulate the dose, give a little more, a bit less drugs according to each single situation. This is the small advantage in favor of heparins over the novel drugs.
Yeah, thank you. There's time for some question. So, yes, please. The microphone to the back.
Yes, is the bleeding risk increasing over time, or is increased at the first months of the treatment with anticoagulant and then decreasing because the tumor is removed, or because...
Yeah, I think it's an excellent point. Per se, I do not know the details of Caravaggio. I would have to go back, and of course the number of bleedings are relatively small. What we have seen in the older studies that there was a tendency to have bleeding more in the first weeks of treatment, which makes sense because that's the sensitive spot, and if this sensitive spot is influenced by anticoagulant treatment, you are likely more see that in the beginning. And as a gastroenterologist colleague of mine always say, you know, anticoagulant drugs do not cause bleeding, but they aggravate bleeding. So I think that's a sensible remark. But we have to go back to the studies, and to end this remark, that will be the beauty of the IPDMA, because then we have much more bleeding endpoints. But you want to attach a question to that? Go on, please.
Yeah, would you be more prone to accept the patient to have a DOAC if during the first 3 or 4 months with low weight heparin he has no bleeding.
Yeah,
or not?
I think is an excellent point. Again, I reiterate, that was my answer to Piotr. You can start with lumbicant heparin and see that it's going all right, and then just go on with the dogs. I think that happens in practice now and then. Stavros has a question.
No, I have a question on the time.
Aha.
I just wanted to say, of course, that we will have, as Menno said, we will have, hi Paolo, as Menno said, we have our interactive workshops where of course we do not have long lectures, and this is exactly for questions and A, so I don't know if, because we do not want to eat up your lunch break especially, I don't know.
And also not the coffee break.
And
who drinks coffee? Who drinks coffee? Okay, who drinks tea?
Never mind.
There is no tea break, sorry. So the tea just goes on here. Okay, no, it's a joke.
We reconvene in 25 minutes, so we will reconvene in 25 minutes.
Yeah.
30? 1:30? Okay.
Well,
so
between 25 and 30, don't forget to do inscription for the workshops and also register, okay? And wear the mask always inside but never outside. Okay, bye.
And if the line is too long, have your coffee, you can also register later. 10:30 will be here.
Grazie. Tempo. Paolo, grazie.
we we will start, some colleagues. I'm really very sorry that someone has to keep the time here, but I mean, that is for you also in order not to cut the break and so that everyone can have enough time for lunch. So I will hand over to Professor Olivier Sanchez, who you all know from the famous group at the European Hospital Georges Pompidou in Paris, and who will talk to us about a subject on which this group has really worked a lot on and published excellently. I just want to remind you, after Professor Sanchez's talk, we will have the talk on diagnosing PE, and then after the combined presentation by Professor Ainle and Professor Righini, we have the abstract session. So all abstract presenters, please move forward, and you will be, I hope that you have all given your abstracts into the master presentation. Sticks will not be allowed, because otherwise we will lose a lot of time. So whoever has not integrated their presentation will not be able to present orally. But Olivier, without further delay.
Thank you very much, Stavros. Thank you, Menno, for this invitation to give this talk on preventing, diagnosing, and treating VTE in the COVID-19 pandemic. Here are my disclosures. I would like first to begin my talk on a first clinical case from my center, illustrating the relation between COVID-19 and pulmonary embolism. It was the case of a 51-year-old man without comorbidities. He was hospitalized during the first wave in France. At the end of March, he had a cough and fever. A few days later, he was admitted to the emergency department for dyspnea and chest pain. He has moderate tachycardia, preserved blood pressure, but low oxygen saturation. And the CT without injection showed moderate lung damage extent, 25–50%. We prescribed oxygen, antibiotics, and enoxaparin, 40 milligrams per day. And a few days later, he experienced respiratory worsening. He was admitted to the intensive care unit. He was intubated. And under mechanical ventilation, we had incomplete improvement, and a few days later, an acute respiratory worsening occurred, and the CTPA showed a proximal pulmonary embolism. We prescribed RTPA and curative anticoagulation, and then its clinical situation improved. He was extubated and discharged a few days later. And I think that these, many of us have been faced to these of such many situations, and several studies across the world aim to assess the incidence of VTE among patients with COVID-19. And David Jimenez performed an interesting systematic review and meta-analysis. And despite a high level of heterogeneity across the studies, the pool incidence of VTE was 17%. The pool incidence of PE was 7.1%. And the pool incidence was significantly higher in the most severe patients, patients in ICU. The incidence was 28%. Whereas it was 7% in the ward. So I will divide my talk on three parts: the diagnosis, the treatment, and lastly, the prevention. For the diagnosis, the last ESC guidelines validated several diagnostic algorithms in both populations, patients with without hemodynamic instability, and also in patients with suspected of high-risk pulmonary embolism. And using such diagnostic algorithm in outpatient without hemodynamic instability in three parts. First, to assess the clinical probability of PE. Second, to use the D-dimer test. And lastly, to use the CTPA. we have a low failure rate. The 3 months VTE rate in patients left untreated based on the basis of a negative algorithm is very low, only 1%. So it is safe to exclude patient, PE in patients using this diagnostic algorithm. But in the COVID-19 population, we don't have specific data evaluating such diagnostic algorithm. First, the clinical suspicion is highly challenging because the signs and symptoms of COVID-19 mimic those of pulmonary embolism, and we don't have any validated clinical prediction rule in this specific population. The second thing is the use of the D-dimer. You all know that the D-dimer is a very useful diagnostic test, and because of its high sensitivity and high negative predictive values, with various validated cutoff, fixed, age adjust or adjust to the clinical probability, it is we can use the D-dimer to safely exclude pulmonary embolism without any other diagnostic test. But we always know that this test is the specificity of this test is very low. But it is interesting and quite confusing to see that in the COVID-19 population, the clinician use the D-dimer as a clinical suspicion test, and the suspicion of PE is based on the results of elevated D-dimers in such population. And it is quite difficult to understand that because it is exactly the opposite in the non-COVID-19 population. And the interpretation of the literature is complex and confusing, and such studies didn't report important information such as the type of assay, the time of dosing, etc. However, several interesting data have been published, and in this Spanish multicenter retrospective study, investigators aim to determine the D-dimer cutoff value on admission associated with in-hospital VTE. They included less than 10,000 patients with an available D-dimer value at admission. They confirm VTE in 2.2% and PE in only 1.6%. And you can see that with increasing value of D-dimer, the specificity increase, and the post-test probability for pulmonary embolism, the positive predictive value, increase from 4% to 11%, meaning that probably in patients with the higher level of D-dimer at admission, the probability of pulmonary embolism increase. Another thing is that clinicians use the increase of the D-dimer during hospitalization. And in this retrospective study from the Wuhan group, they derived a predictive model using D-dimer on admission. The increase of D-dimer during hospitalization over 1.5-fold and low fibrinogen on admission. And you can see that the diagnostic performance of this model is quite good, but of course this model was not externally validated. So it is difficult to interpret the data on D-dimer in the setting of COVID-19 population. When to suspect pulmonary embolism, the study from Lodigiani suggests that the majority of PE was diagnosed during the first 24 hours after admission for COVID-19, and we performed a small prospective multicenter study at the end of the first wave in France, including 106 patients admitted for COVID-19 to the emergency department, and we performed in all these patients CTPA unless contraindicated, and whatever the results of D-dimer at admission at emergency department. And interestingly, despite a low level of clinical suspicion, we confirmed pulmonary embolism in 14% of patients. And interestingly, during the 3 months prospective follow-up, we didn't have any additional pulmonary embolism diagnosed. Interestingly also, patients with pulmonary embolism had a longer time from COVID symptoms to hospital admission. They need more frequently oxygen on admission, despite a similar lung damage involvement on the CT. It was confirmed in the other French cohort study published by Benjamin Planquette, showing that the respiratory support was associated with the risk of pulmonary embolism. However, in this study, the extent of lung damage was associated in this study with the diagnosis of pulmonary embolism. So in summary, for the diagnosis of PE, I think that we must keep a high level of clinical suspicion, even in the absence of classical VTE risk factors. At admission, of course, particularly in case of long time between COVID-19 symptoms and admission, probably also in case of discrepancy between oxygen supply and extent of lung damage. But I agree that this is not very objective. And of course, in case of chest pain, signs of DVT or hemoptysis. What about the very high level of D-dimer at admission? It is a good question, and I have no very good response to this question. During hospitalization, in case of respiratory worsening or ICU admission, what about the important elevation of D-dimer? Also, I don't have a definite response to this question. This is the same for the D-dimer testing in the setting of COVID-19 population. The CTPA remains the first-line diagnostic test, and in the most severe patients, in the case of non-transportable patients, the use of bedside transthoracic echocardiography or compression ultrasonography of lower limb can be useful to objectively confirm the diagnosis of pulmonary embolism. And this is what it was reported in the last ISTH guidance. Practitioners should use standard of care objective testing, and routine screening for VTE is not recommended, even based on elevated D-dimer level during hospitalization. So what about the treatment? The treatment, the last ISTH guidance stated that established guidance should be used to treat patients with confirmed VTE and COVID-19 with advantages of low molecular weight heparin due to the potential instability of these patients. But DOACs can be used in the post-hospital after discharge of this patient. The duration of treatment should be at least 3 months, but I think that COVID-19 can be considered as a major transitory VTE risk factor. Therefore, a fixed duration of anticoagulation treatment can be used in most patients. What about the thrombolysis? In high-risk pulmonary embolism, you know that systemic thrombolysis is recommended, but I think that we must have an objective confirmation of the diagnosis before prescribing thrombolysis. In case of intermediate high-risk PE, the question of the evaluation of systemic thrombolysis is a question of research. So I think that it is not recommended. But in the setting, in the COVID-19 population, I think that PE must be the dominant pathology in the clinical presentation. And for example, a subsegmental pulmonary embolism in patients with severe RDS related to COVID-19 is not a good candidate for systemic thrombolysis. So I think that it is important clinical information for daily practice. So what about the prevention? The pulmonary embolism is considered as the most common preventable cause of hospital death, and thromboprophylaxis is a crucial component in the care of hospitalized patients with COVID-19. Multiple society guidelines recommend prophylactic anticoagulation for hospitalized COVID-19 patients without contraindication. However, as a result of high rate of VTE despite standard thromboprophylaxis, many institutions have implemented the prescription of higher doses, including intermediate dose and even therapeutic dose without evidence. And recently, several randomized controlled trials have been published evaluating various doses of anticoagulant for thromboprophylaxis in patients with COVID-19, and we are going to see the results of these studies. The first question was the efficacy of therapeutic anticoagulation compared to standard anticoagulation in patients with COVID-19. The REMAT-CAP Active 4A and ATTACK investigators perform open-label adaptative multi-platform randomized controlled trials, mainly in UK and US, including 1,103 patients with severe COVID-19 hospitalized in ICU. These patients were randomized to receive either therapeutic anticoagulant according to local practice, for example, enoxaparin 1 milligram per kilogram BID, or prophylactic or intermediate anticoagulation according again to local practice, enoxaparin 40 milligram per day or up to 0.5 milligram per kilogram BID. These anticoagulant regimens were prescribed up to day 14 or hospital discharge, whichever comes first. And the primary endpoint, efficacy endpoint, was days alive and free of organ support to day 21, and the safety was major bleeding. The enrollment in this study was stopped for futility, and the probability of therapeutic anticoagulation dose was 95% for inferiority of therapeutic anticoagulation dose compared to usual thromboprophylaxis in achieving the primary efficacy outcome. And again, interestingly, the probability, the 87% of probability was demonstrated for the major bleeding risk in therapeutic dose arm compared to usual thromboprophylaxis arm. The similar design was used in non-critically ill patients, mainly included in US and Brazil. 2,219 patients with COVID-19 hospitalized in ward were included in this study. Same regimens of anticoagulation, similar endpoints, efficacy and safety endpoints. And in contrast to the most severe patient, in non-critically ill patients, there was a 99% probability of superiority of the therapeutic dose over the usual care thromboprophylaxis in achieving the primary efficacy outcome. And interestingly, these positive results were observed independently of the level of D-dimer at inclusion. But they observed a probability of increase of major bleeding in the therapeutic anticoagulation arm as compared to the usual care thromboprophylaxis. In the ACTION study published by Renato Lopez, it was a pragmatic open-label multi-center randomized control trial in Brazil. 615 patients with COVID-19 and elevated D-dimers hospitalized in ward were included. They were randomized to therapeutic anticoagulation. This therapeutic treatment was prescribed until day 30, and prophylactic anticoagulation was prescribed during hospital stay. The primary efficacy outcome was time to death, duration of hospital stay, duration of oxygen supply at day 30, and they use a win ratio method, meaning that a win ratio over 1 means a better outcome in the therapeutic group. The safety was major bleeding and clinical relevant non-major bleeding at day 30. The study demonstrates no benefits of the therapeutic anticoagulation in this study with a win ratio under the value of 1. So the efficacy was unchanged in the therapeutic arm versus prophylactic anticoagulation. And interestingly, there was no effect, positive effect on the treatment, on the therapeutic anticoagulation for preventing composite thrombotic outcome, venous thromboembolism, but also arterial thrombosis. But, and it is important, there was a significantly higher rate of major bleeding or clinically relevant non-major bleeding in the therapeutic anticoagulation arm as compared to the prophylactic anticoagulation arm. Lastly, the Inspiration trial evaluated the intermediate dose, so a lower dose than therapeutic, in an open-label, multi-center randomized control trial in Iran. 562 patients with severe COVID-19 hospitalized in ICU were randomized to receive intermediate dose, you see the dosage, until day 30, or prophylactic anticoagulation. The primary endpoint was a composite of all-cause deaths, venous and arterial thrombosis, or ECMO supply within 30 days, and the safety was major bleeding. The study was negative, with no difference in both arms for the composite efficacy outcome. And there was a trend for a higher rate of major bleeding, 2.5% in the intermediate dose arm versus 1.4% in the standard dose. And the common, and there was also an increased risk of the composite of major and non-major bleeding in the intermediate dose group. Lastly, Peripu performed a small study. It was an open-label, multi-center randomized controlled trial in US. Only 176 patients with severe COVID-19 hospitalized in ICU were randomized, intermediate anticoagulation or prophylactic anticoagulation. The primary efficacy outcome was all-cause deaths at day 30, and the safety was major bleeding, and the study was negative. No difference between the two arms for the primary efficacy outcome, and no difference in terms of major bleeding. So if we want to summarize the results of these studies with various design, various endpoint, etc., I put a color code. If the outcome is improved, I use the green color. If the outcome is unchanged, I put the orange color. And if it was worsened, I put the red color. For the therapeutic anticoagulation dose in ICU, we have two studies. The last studies was presented during the last ESC by Spiropoulos. It was the HEP COVID studies. And these two studies, the ATTACK and the HEP COVID studies, demonstrate that the efficacy for therapeutic dose was not superior to standard anticoagulation, and is also associated with an increased risk of major bleeding. However, in contrast to the most severe patient, in patients in wards, they demonstrate, both studies demonstrate a better efficacy for using therapeutic doses without any difference in terms of safety. However, the ACTION study didn't demonstrate this similar safety with an increased risk of major bleeding in the therapeutic anticoagulation arm. For the intermediate dose of anticoagulation, in ICU, we have data on ICU, and you can see that the outcome of efficacy or the safety was unchanged in both arms. Interestingly, the effect of these various anticoagulant regimens on thrombotic events seems to be unaffected by the dose of anticoagulant. And you can see the rate of various thrombotic events reported in these trials, except for the attack, or there is a trend for less thrombotic events in the therapeutic arms as compared to the standard dose. In other studies, there was no difference. So I think that the story is not ended, and we need to have some additional information. And this is the purpose of the COVID studies performed in France with Professor Stéphane Zuilly in Nancy. This study will compare the intermediate dose with a weight-adjusted low molecular weight heparin versus standard anticoagulation with a dose of enoxaparin 40 milligram per day, increased to 40 milligram BID in patients in ICU. The efficacy outcome is VTE and death, and the safety is major bleeding. We have included 1,000 patients, and we are waiting for the results very soon. So in conclusion, COVID-19 is associated with coagulopathy, and VTE is frequently diagnosed, particularly in the most severe patients. The diagnosis is challenging, and we must have a high level of clinical suspicion on admission or in case of worsening. The CTPA remains the first-line diagnostic test, and the utility of D-dimer remains an important question. A fixed duration of curative anticoagulant treatment is prescribed in most patients, and for prevention, recent randomized controlled trials do not support the use of therapeutic dose for prevention in critically ill patients. In contrast, in ward, therapeutic dose seems superior to standard dose, but the safety needs to be confirmed. And what about the intermediate dose? We are waiting for the results of COVID dose. Thank you very much.
Thank you very much. Well, this is not working, just standing up. Thank you very much, Olivier, for this provocative talk with outcomes which are still important because we are having a lot of fakes like the Thalassa here. There will be multiple waves of COVID, so I reassure you the mask will not be out. Patients will come in. Questions? We have 2 to 3 minutes, so short question, short answer. In the middle there is a question. Yes. One sentence questions, please.
I wanted to ask, what standard prophylaxis regimen would you recommend to COVID patients in the intensive care with severely impaired renal function, or those with high risk of severe impairment, for example, with the progressive multiply organ dysfunction?
Okay,
not yet bad?
Dose, prophylaxis, intensive care, renal, severe renal dysfunction.
Curative anticoagulant should not be prescribed in these severe patients, and I think that standard dose, meaning for example, enoxaparin 40 milligram per day in case of normal renal function, and in case of impaired renal function, unfractionated heparin can be used using the standard dose of 5,000 international unit BID. I don't know if intermediate dose can be prescribed and can be useful, because the results of ATTACK study mixed the two population, the two dosage, the prophylactic 40 milligram of enoxaparin, but also 25% of these patients received intermediate dose. So it is difficult to compare face-to-face intermediate dose or curative or prophylactic dose in the critically ill patients. But I think that the most important information for daily clinical practice is not to use curative anticoagulant treatment in the most severe patients.
Okay, that's more than one sentence, but you're the speaker, so this is important answer. Yes, Stefano.
So you mentioned that you use an anatomical criterion to indicate and to perform thrombolysis in these patients. What is the main criterion that you use in patients who are on catecholamines at the ICU, intubated, to decide whether he or she should receive a thrombolysis or not, apart from the anatomical one?
The anatomic is important because the distal pulmonary embolism is not a good predictor for efficacy for thrombolysis. I think that the clinical parameters are important to decide to prescribe. Cardiogenic shock, of course, but also respiratory acute respiratory failure associated with proximal pulmonary embolism.
So I realize that this is a vice versa discussion, but that should go on afterwards. The point is made. Let's go to the next question.
Very quick question. If you have a patient in atrial fibrillation and is in DOAC and have VT with COVID, what do you suggest?
We have some data suggesting that patients under anticoagulation before hospitalization for COVID-19 had a better outcome than patients with no anticoagulation. So I think that if in this case of patients, we need to continue the same treatment using DOACs if the renal function is okay.
Okay. David?
Any explanation to reconcile the negative results of action compared to the positive results of the multi-platform trials?
Well, I think that the patient is not very, probably not comparable. First, the outcome is not, and the methodology is not similar, so it is quite difficult to interpret this data. However, the science in terms of safety is consistent between these studies. So I think it is difficult to compare all these studies because of various methodological analysis.
May I just have a quick follow-up on this? I would have asked the same question, Olivier. Is it not counterintuitive that there is no reduction in terms of recurrent VTE or extension of thrombotic events, and there is a positive outcome in terms of the endpoint chosen in these multi-platform trials? This is very quizzical.
I agree.
So there must be another effect of the anticoagulant. That could be the case. But you know that low-molecular heparin has been responsible for a lot of things. But let's go on with the question of Piotr.
Two short questions. Do you think that there is a difference in outcome between patients with proximal clots and patients with more distal clots in patients with COVID? Do you think that there is a difference?
You mean between local thrombosis and between thromboembolic?
Yes.
We don't have very specific response to this question. I think that I don't have any good response.
Okay, so this is for the future. If you're interested in cooperating with trials, please come to Olivier, to other persons, including me. I'm sometimes get a bit tired of COVID, but there's still work to be done. Olivier, thank you very much. And now we move on with the diagnosis of VTE, and this is to be done by Fiona Ainle and Mark Righini. I don't know who goes first, or you do a duet. That would also be nice. But please come to the floor. Thank you.
Fantastic, thank you. So, ladies and gentlemen, dear colleagues, dear friends, it's a pleasure for me to be here today. And I just wanted to thank Menno and Stavros for the kind invitation and also for organizing this VT Spring School despite the COVID pandemics. So I was given 25 minutes to discuss recent data on PE diagnosis, and afterward, Fiona will discuss of diagnosis in pregnant women. I have divided my talk into 4 parts. I will first have some general considerations on PE diagnosis. I will then discuss diagnostic tests and sequential strategies for PE without hemodynamic instability. I will have 1 slide on PE, on diagnosis of PE in case of hemodynamic instability, and I will finish with some conclusions. So my first general consideration is quite basic. As you know, pulmonary angiography is considered as a gold standard for PE diagnosis. Obviously, the test is expensive, invasive, and not devoid of risk. And as we discussed more than 2 years in the same meeting, CTPA might now be considered as a gold standard for PE diagnosis. However, the crucial information we retain from these times where pulmonary angiography was used is that the risk of thromboembolic events in patients left untreated after a negative pulmonary angiography is not of 0%, but it's around 1 to 2%. And that means that our modern diagnostic strategies, which are not using any more pulmonary angiography, should have a 3 months thromboembolic risk, which should be in line with the one observed after a negative pulmonary angiography. And at a first look, this was confirmed by the subcommittee on diagnostic and predictive variables of the ISTH, which stated that a strategy safely rules out PE if the 3 months thromboembolic risk is below 2%. And in fact, this criterion is even more stringent because, in fact, it's the upper bound of the confidence interval of the 3 months thromboembolic risk, which should be below 2%. And here you have an example of a recent diagnostic study, and you may see that the upper bound of the confidence interval was below 2%. At a second look, what in fact really proposed this paper was a safety threshold dependent on disease prevalence. And as you may see, this paper proposed a mathematical formula. I will not go into details how it was computed, but this formula allowed to calculate the maximum acceptable point estimate of the failure rate. And you may see it's highly dependent on prevalence. And you may see that a prevalence of 20%, which is probably the highest prevalence we will now have in Europe, you may see that the maximum failure rate is just below 2%. And this is it's very nice. It's nice to assess the safety of our trials. However, I think it's important to remind you that in some clinical settings in Europe or North America, typically nursing homes, in hospital patients, and in many countries, or I should say in many continents, North Africa, South America, they have much higher prevalence of the disease, which are around 40%, and obviously they will have higher failure rate than this 2% margin that is proposed by the ISTH, and probably we have to keep this in mind when planning our study according to the clinical setting, and I will discuss this point also later. Another important general consideration, which was recently discussed by Freund and co-workers in GTH, is that we should focus on patients in whom care is changed by the new strategy. And for example, if you try to plan a strategy which will adjust the D-dimer threshold in a study of 1,000 patients, but which actually will change the clinical decisions only in 100 patients, the often used denominator is 1,000, despite the fact that the strategy is relevant only to 100 patients. And here, Freund and co-workers gave an example here. You may see that if you have a new strategy that misses 10 PE, your conventional failure rate is of 1%, and you could think, okay, it's safe, but in fact, in reality, the failure rate is 10 out of 100 patients, which is obviously not safe. So again, we should think about this when planning our future studies. Another important general consideration that everybody of you know is that the prevalence is decreasing in patients tested for PE, and you may see in this work that the prevalence was around 30 to 40% in the early 90s, and it's now around 5 to 20%. And as you know, in the United States, they have in some centers prevalences around 2 to 3%, which is also a problem because that means that they are performing 100 CT to diagnose 2 or 3 PE. So the message at this time was to say that we should adapt diagnostic strategies according to the expected prevalence. And this is not so easy because often physicians do not know the prevalence or the exact prevalence to which they are faced with. And I will show then some unpublished data which suggests that maybe we can adapt rather to the clinical setting. My last general consideration that which is an unanswered question, is in which patient should we suspect PE? And as you know, in most diagnostic trials, patients were investigated if they had shortness of breath or chest pain and syncope without any other obvious explanation. If there was another obvious explanation, patients were not investigated for PE. And this gives somewhat a definition of suspected PE in these trials, but as you know, in everyday clinical practice, it remains a real challenge to know when to suspect PE and when to begin a diagnostic strategy in a given patient. And there is clearly somewhat a gap between management outcome studies and real life, in the sense that this definition, which has been used in clinical trials, does not sufficiently help clinicians to determine if they should suspect PE in a given patient. However, some efforts have been done to avoid any further testing in patients tested for PE, and this is the PERC rule, where PERC stands for pulmonary embolism rule-out criteria. And as you may see, if your patient has none of these 8 items, then the risk of developing a symptomatic VTE is less than 2%. The study was derived in the United States by Jeffrey Klein with a low derivations, with a patients with a low prevalence of the disease. And you may see that in this context, the proportion of patients with PE despite a negative PERC rule was quite low. However, in some external validation with higher prevalence of the disease, the rate of PE was much higher, and therefore this data suggests that we cannot safely use the rule in Europe. However, the study has been tested in the proper trial, which is a French study. It was a non-inferiority crossover cluster randomized clinical trial aiming at assessing the safety of the PERC rule strategy. 14 emergency units in France included patients. Only patients with a low clinical probability were included, and then the PERC rule was used, and obviously patients with a negative PERC rule were left untreated. Here you have the design of the study. 7 centers randomized patients to the PERC rule and then to control, and 7 centers randomized to control and then to PERC rule. Overall, 1,000 patients were included. And here you have the results, which may seem appealing because the 3-month thromboembolic risk was of 0.1% in the PERC rule group. However, it was exactly the same in the no PERC rule group. And this is mainly due to the fact that the prevalence in this study was very low, as it was of 1.5% in the PERC rule group, suggesting that these patients should maybe even not have been investigated. So a very nice, very well-conducted study, but which doesn't bring the evidence we can use the PERC rule in Europe, whereas the prevalence is still around 10 to 15%. So if I go back to diagnostic strategies for PE, they have obviously much improved because the assessment of clinical probability has been recognized. Many non-invasive instruments are now used, like D-dimer, like CTPA, and we now have a non-invasive diagnostic workup with no need to perform pulmonary angiography. We had also in the past quite complicated diagnostic strategies that I will not discuss today, and as showed just previously, Olivier, we now have an easy or simple algorithm which is based on the assessment of clinical probability. If it's low or intermediate or unlikely when using a 2-level score, we will perform D-dimer. If D-dimer are below the cutoff, PE will be ruled out. If D-dimer are above the cutoff, or if the clinical probability is high, we will perform CTPA, and most patients will be treated according to CTPA results. And this kind of diagnostic strategy has been endorsed by almost all international recommendations, as you may see here by the ESC. And I think there are 2 remaining questions. The first one is what to do with patients with a high clinical probability and a negative CTPA. Some centers will consider these patients do not have PE, but some centers will propose further testing. And the other question is obviously what to do with subsegmental filling defects, which are reported as subsegmental PE, but I will not discuss this point today. So the assessment of clinical probability has been endorsed by almost all guidelines with a high level of evidence. one question which is often raised: why should we really assess our clinical probability? And this is again a French study. I think it's still the best demonstration that performing clinical probability improves the outcomes of our patients. And you may see here that in patients receiving a correct strategy or a correct strategy based on the assessment of clinical probability, the rate of thromboembolic events or unexplained deaths were less than in the other group. So at least some data suggesting that we can improve the outcomes of our patients. The second step in the strategy is D-dimer. I will not go into details. There are many and many different D-dimer tests, ELISA or alpha tests, and the immunoturbidimetric tests, which are widely used because they can be easily automated in the hemostasis lab. The test is very safe to rule out P, and you know that very well. For example, in the systematic review, you can see that the 3 months thromboembolic risk in patients left untreated after a negative D-dimer test is around 0.14%. The test is very useful, at least in outpatients, and this is quite well reflected by the number needed to test, which is around 3 for the 2 tests I just mentioned, meaning that in outpatients, you need to test 3 patients to rule out 1 PE. However, as you know, the test is clearly less useful in elderly patients, in patients with cancer, in patients with renal failure or during pregnancy. And so many efforts have been done to increase the diagnostic usefulness of D-dimer, and this is all the chapter of adjusted or adapted cutoff. Today, for the sake of time, I will discuss only the age-adjusted and the clinical probability-adapted cutoff, and also because both have benefited from a prospective validation. So these are the recent developments according to the adjusted or adapted cutoff. In fact, there is also a 4th study that I will discuss in the end. So the first study was the ADJUST-P study, where we used an age-adjusted cutoff in patients of more than 50 years, meaning that these patients had P ruled out if the D-dimer level was less than age per 10. The second model is the years model, where the assessment of clinical probability was done with 3 items of the Wells score: signs of DVT, hemoptysis, and P as most likely diagnosis. And then you may see that patients with none of these 3 items were using a 1000 cutoff to rule out P, while the standard cutoff set at 500 microgram per liter was used for the other patients. And the last study, which was published in 2019, was the PEGED study. They changed a little bit the Wells rule so that patients with 0 to 4 points were considered as having a low clinical probability. These patients were using 1000, so a cutoff of 1000 was used in these patients to rule out P, while the standard cutoff was used if the patients had a Wells score between 4.5 and 6 points. So this is the ADJUST study. I will not go into details. More than 3,300 patients. You may see that this study was interventional in patients with D-dimer between 500 microgram per liter and the age-adjusted cutoff, and the 3 months thromboembolic risk was of 0.1% in patients with D-dimer below 500 microgram per liter, and it was of 0.3% in patients with D-dimer between 500 microgram per liter and the age-adjusted cutoff. And you may see that the confidence intervals are widely overlapping. The second study was the years study. You may see here that they were using a cutoff of 1000 microgram per liter to rule out P in patients with no years items, while the standard cutoff was used if 1 years items or more were present. And here you have the results. You can see that there were more than 1,300 patients with 0 years items and D-dimer below 1000 microgram per liter, and you may see that in the worst case scenario there were 8 thromboembolic events during follow-up, suggesting that the strategy is also very safe. The last study is the PEGED study. As I said previously, they modified a little bit the Wells rule to increase the proportion of patients who could benefit from the increased cutoff of 1000 microgram per liter. Patients with a Wells rule between 4.5 and 6 points were using the standard cutoff, and you may see again that there were no thromboembolic events during follow-up. The last study which was published this year in Circulation is the RELAX-P study, which was an impact analysis of the age-adjusted D-dimer cutoff in real life in centers which are already using the D-dimer, the age-adjusted cutoff. And again, I will not go into details. However, in this real-life study, you may see that the age-adjusted cutoff increases by 20% the proportion of patients in whom PE is ruled out on the basis of the age-adjusted cutoff. And also, it remains very safe with a 3-month thromboembolic risk, which is around 0.07%. If I go back to the 3 main studies, I reported here the proportion of CTPA avoided when compared with the usual cutoff, and you may see that it's 12% with the ADJUST study, it's of 14% with the EOS model, and it is of 17% with the PEGED model. And this difference may seem important, but what we have to look also is the prevalence in these different studies, and you may see that it was of 19% in the ADJUST-P study, of 13% in the EOS model, and of 7% in the PEGED model. And this is obviously very important because the lower prevalence you have and the higher you will be safe with a higher D-dimer cutoff. And for example, I show you here an external validation of the EOS model in studies which had a higher prevalence than the original EOS study. And obviously, it is a retrospective validation, but you may see that we had 1,142 patients with no EOS items and D-dimer below 1,000 microgram per liter. So these patients would have PE ruled out on this basis. And in fact, in this retrospective validation, we had 17 PE. We would have 17 PE, so a failure rate of 6.3%. And you may also see here that if you separate these patients with the age-adjusted cutoff, this cutoff is able to identify all failure because all patients who had PE had D-dimer above the age-adjusted cutoff and below the 1,000 microgram per liter cutoff. And this is not at all a criticism to the clinical probability adapted cutoff. It's just to say that it's more efficient, but obviously it's less safe if the prevalence is higher. Is there a way to sum up or use all these cutoffs together? There is a nice work which has also been published this year in JAMA Cardiology, which is the 4PEPS study. And I think it's a very nice retrospective study, and in fact, in this new way to assess clinical probability of PE, patients are separated in 4 classes. Patients with very low clinical probability do not go further testing, a little bit like with the PERC rule. Patients with a low clinical probability will use the 1,000 microgram per liter cutoff. That means clinical probability adapted cutoff. Patients with a moderate clinical probability will use the age-adjusted cutoff, and obviously patients with a high clinical probability will undergo thoracic imaging. There are 2 main limitations: no prospective validation at the moment, and the 4PEPS model is a little bit complicated and should be helped by if it is on a handheld computer or on a smartphone. So in conclusions for this part, this age-adjusted or clinical probability-adapted cutoff may now be used in outpatients with suspected PE, and overall they decrease by 10 to 20% the proportion of patients in whom CTPA can be avoided. Another thing that I wanted to show you is this recent study. These are not published data yet. This is an individual patient data meta-analysis on almost all diagnostic studies in the field of PE. This study is led by Dr. Geersing. It includes more than 40,000 patients with suspected PE. And in this work, we separated patients according to different clinical settings with an increasing prevalence of the disease. You may see emergency care, primary health care, referred hospital care, or in-hospital or nursing home. And obviously then what you have here is the failure rate of the different diagnostic strategies which were used in these different studies. And I can give you here some examples. For example, if you use the PERC rule in the emergency care, it's quite safe because the failure rate is below 2%. But if you use it in referred hospital care, you will see that the failure rate is much higher. And that's exactly what we saw in the derivation sample where the PERC rule was not so safe. Another point, if you look at primary healthcare, for example, the situation of a physician who goes to his doctor, you may see that the age-adjusted or the clinical probability-adapted cutoff have a similar safety. What is not shown here is that the clinical probability safety is more efficient. However, again, if you look at what happens in the referred hospital care, which is probably the situation to which most of us are faced, you may see that the age-adjusted seem to be a little bit safer than the clinical probability-adapted cutoff. But I think the most important thing I wanted to show you is that even if all these studies were performed in Europe or in North America, you may see here that in the situation of in-hospital or nursing homes, our failure rates are really much higher than the 2% which are recommended by the ISTH. And this is probably not true, obviously, in Europe and North America in this particular setting, but also in many countries and many other continents, as I said previously. So the last step in the diagnostic strategy is CTPA. I will be very short on that. You know that there are many prospective management outcome studies, and as it has been said previously, the 3 months thromboembolic risk in patients left untreated after a negative CTPA is around 1%. Only one slide in the case of hemodynamic instability. Obviously, you do not have the time to make a complex diagnostic strategy based on D-dimer and assessment of clinical probability. And as you may see here, then the strategy is mainly based on the detection of right ventricular dysfunction on bedside echocardiography. If you have no right ventricular dysfunction, you should search for other cause of shock or instability. If you have a right ventricular dysfunction, either your patient is stable enough to go to the CTPA and you have the results, but in each case, these patients should be treated as high-risk P patient, that means with systematic thrombolysis or other options if there are contraindications. So in conclusions, we now have easy, cost-effective, and safe diagnostic strategies, obviating the need for invasive testing, which have been widely validated in prospective outcome studies. We now have a simple algorithm for what was formerly a complicated disease, and probably we should adjust or adapt our strategies to the clinical health care setting, which is probably a better message than adapting to the prevalence, which is often unknown to physicians. And I thank you very much for your attention.
Thank you. Thank you. Mark, thanks again. Beautiful. For sake of time, we continue directly, and we ask Professor Ainle to stick in time because officially at 11:30 we would start the poster presentation. People are getting very nervous, so please cool down for a minute, and we go to Fionnuala, and afterwards we have some minutes for discussion. This is, of course, a compromise. Would love to have more questions. And while the slides are coming up, Fionnuala has made one of the longest journeys because she came from Ireland and she had to change flights somewhere in Europe.
In Munich.
In Munich, okay.
Exciting to be here.
But that's okay. But you are here, and we welcome you to discuss the special population for diagnosis. Please,
so in less than 10 minutes, I thank the organisers very much for the invitation to cover diagnosis of PE in pregnancy, and honoured to follow on from Dr. Righini's superb talk. As you all know, pulmonary embolism in pregnancy is a crucial area where diagnostic and therapeutic strategies and excellence in evidence base is so important. Because maternal death is a devastating event for the patient, the family, and wider society. And it is one of the leading, and PE is one of the leading causes of direct maternal death reported here in the UK and Ireland. And in survivors, long-term health outcomes can occur. So I'd like to begin with a very common clinical scenario. A 35-year-old woman at 28 weeks gestational age presents with shortness of breath, but no hemoptysis, and importantly, mild leg edema. Pulmonary embolism is suspected, and both she and her care providers ask, do I really need to undergo diagnostic imaging, or can we use clinical prediction rules and D-dimers? And until very recently, clinical prediction rules and D-dimers were not validated in this setting at all. And therefore, the prevalence of PE in pregnancy was very, very low. It's an honor today to discuss two very important prospective management studies led by Dr. Righini and Dr. Huisman that have transformed guidelines and changed the way we deliver care to these women. And it should be pointed out, and we should reflect on precisely how challenging it is to conduct academic clinical management studies in pregnancy. So thank you to both of you. So the first of these two studies, which used a similar design, withholding of anticoagulation in women deemed to be at low risk with follow-up at 3 months, was the Geneva CTPE study. And in this study, pregnant women with clinically suspected PE and a non-high Geneva score and a negative D-dimer had PE ruled out without the need for diagnostic imaging. The prevalence of PE in this study was about 4%. And for the first time, it was demonstrated that PE could be safely excluded in nearly 12% of patients. And the importance of this outcome cannot be overstated. The second study using a similar strategy was led by Dr. Huisman and was the Artemis Prospective Clinical Management Study, published in the New England Journal in 2019. And again, Dr. Righini discussed the years algorithm earlier on, and this was a study in which women with suspected PE in pregnancy underwent assessment according to the years items described here and D-dimer levels. So women with no years items could have PE excluded without the need for CTPA if the D-dimer was less than 1 microgram per mil. And those with 1 to 3 items, like our patient, could have PE excluded if the D-dimer was less than 0.5 micrograms per mil. The prevalence of PE in this study was about 7%. And again, the algorithm was deemed to be safe with an upper bound of the 95% confidence interval, as you can see, well below the threshold recommended by ISTH and discussed by Dr. Righini. And remarkably, CTPA was not indicated in overall 40% of patients, slightly higher in the first and slightly lower in the third trimester. And the years algorithm was subsequently externally validated by Dr. Righini and colleagues in the CTPE population. And in this study, 371 women were available for analysis. Data were prospectively gathered. Slightly lower percentage of women had no years items than in the Artemis study. But it's important to note that 21% of women met the criteria for PE exclusion and would not have undergone a CTPA had the years algorithm been applied to the CTPE population. I suppose a lower number of women overall, and therefore the wide confidence interval, but interestingly showing that almost twice as many women could be ruled out without the need for diagnostic imaging. And there has been quite a lot of debate, understandably, in this area recently, but it is interesting to note that recently the group reported 3-month thromboembolic risks using the pooled data of the CTPE and Artemis studies. And it's important to note that when we pool the data, women left untreated after the negative diagnostic algorithm, the upper bound was 0.74. Whereas even when we look at women left untreated after a non-high pretest probability and a negative D-dimer, the 95% confidence interval upper bound was 1.83, which is reassuring. So back to our patient. If she had no years criteria, the application of the years algorithm would result in exclusion of pulmonary embolism and clinical follow-up only. But because she had 1 year's criteria and a D-dimer of 0.9 microgram per mil, she would have gone on to have further imaging. There's also very interesting data recently published surrounding the use of D-dimers alone to rule out VTE during pregnancy, and this was a systematic review meta-analysis very recently published by Dr. Righini and colleagues. And in this study, the 3-month thromboembolic rate in pregnant women who were left untreated after a negative D-dimer was 1 out of 312 women, again 0.32%, and again the upper bound of the 95% confidence interval there was 1.83, with a yield overall of 34%, which is interesting. In terms of what imaging study to choose for pregnant women, again, this is an area of passionate debate, but it's important to note that the safety of CTPA and lung scintigraphy appear similar, with similar rates of negative prediction value and inconclusive rates. And when we use modern protocols for diagnosis of PE using CTPA, actually the estimated maternal radiation exposure to breast tissue is extremely low. So collectively, these prospective clinical management studies and other studies have impacted directly on the most recent iteration of the ESC guidelines on acute PE in pregnancy. So it was recommended that in a woman with suspected PE during pregnancy who had a high pre-test probability or an intermediate or low probability with positive D-dimer, that anticoagulation with low molecular heparin should proceed. Chest X-ray should be considered next. However, the diagnostic yield can be low. And again, as was explored in both of the prospective management studies, compression proximal duplex ultrasound can be useful, and in particular, as shown in the Artemis study, if there are symptoms and signs suggestive of deep vein thrombosis. For women with a proximal DVT, PE is considered diagnosed and anticoagulation is commenced, and others undergo either a CTPA or a perfusion lung scan, depending on the nature of the chest X-ray, and again, depending on local availability. And it's important to note that radiation doses for both fetal and maternal exposure are extremely low with either type of imaging, provided, of course, that modern techniques are used in CTPA imaging. And PE can be ruled out on that basis. So for women with a proximal DVT present on compression ultrasonography or a positive CTPA, obviously low molecular heparin is continued. But importantly, we did endorse the role of the multidisciplinary team because, of course, so many care providers are involved in the care of the pregnant woman, including anesthesiology, obstetrics, potentially hematology, and an experience of PE management in pregnancy is important. And written care pathways are certainly used in our institution and discussed with the patient. So in conclusion, PE is such a crucial area in pregnancy, responsible for a higher number of preventable deaths arising out of the pregnancy than any other cause. Symptoms and signs of PE can overlap with those of normal pregnancy, and we're dealing with high competing risks. And consequently, the recent publication of the prospective clinical management studies led by Drs. Righini and Huisman have really been seminal in providing evidence for the first time for the use of these diagnostic algorithms that can avoid diagnostic imaging in pregnancy. Thank you for your attention, and if Dr. Righini is free, we'd be happy to take any questions. Thank you very much.
Thank you, thank you. Yeah, Mark knows what I would have asked him to come forward. So to both of them, questions, please. There is a question here on the front, so I never let the first being Stavros, because I know that takes time. No, it's a joke. Come on. Short question, Stavros. Thank you.
No, I paid for the Congress, so I can ask a question. It's a very brief question. Fionnuala and Mark, congratulations. There is, of course, a lot of emphasis on avoiding a lot of diagnosis, of radiation diagnosis in patients with suspected VTE in both studies, pregnant patients, and both studies have contributed to that. But I wanted to ask for your opinion from real life. In Germany, we rather have the problem not of overdiagnosis, but of underdiagnosis. People being extremely afraid of doing any CT or not even a chest X-ray. And do you think that perhaps the benefit may be another one? So urging physicians, saying we have now safe algorithms, so please do some diagnosis based on rules. So our practice is that we miss some cases in pregnancy. I don't know.
Okay, this is a question for Fionnuala, I think, per se. Fionnuala, please.
Thank you, Stavros. And I think that's a fascinating point that just demonstrates the variability of patient perceptions in different countries. I think that would be a fascinating study in itself. And we don't have that issue in Ireland, to my knowledge, and in many other centres. But I think you are absolutely right. And I think here the role of counselling, and I think I understand you're right that we should be using an evidence-based approach for those who are not suitable for rule-out according to the algorithm, and we should be reassuring our patients that once we're using modern protocols with iterative reconstructive techniques, with the use of different anatomical coverage, with lower kilovoltage and reduced contrast monitoring of the scan, we can deliver radiation doses that are far below what was reported before and are safe for both mother and baby. Thank you for that point.
I think that this point to take away, but please comment.
I just wanted to add that in the study that I presented, the French study, to be pregnant increased by 7 times the risk of having an incomplete management strategy. So it's really a true problem.
Yeah, so there are 2 points: dissemination of knowledge based on the studies, and on the other hand, that within this knowledge, bring this back to your country, you don't always have to do a CTPA based on these algorithms. So this, I think, is very important. Other questions, other points of remark? So let me come back to the not yet published meta-analysis of independent patient meta-analysis of Geert-Jan Geersing, Mark. I think you pressed a very important point because you took out of this analysis points to be taken to the practice. Now, of course, there is a danger that this is all post hoc analysis. So is this still evidence-based? Could you just comment?
Yeah, I mean, the studies which were included in the meta-analysis are prospective management outcome studies, which are very robust, I think. Yeah. So I think these inferences are correct. And the other thing, what we really wanted to do is, the problem when you say people just adapt your strategy to prevalence, it means nothing to most of people. Yeah. And then if you say, okay, you're in a nursing home, you have 40% of prevalence, you have to do CTPA because you can do the strategy without, and then you're at a physician or the GP just use the 1,000 cutoff to rule out P. I think this kind of message can help improve the strategies. Yeah. And I think it's a much easier message than just adapt to the prevalence because nobody understands what it means.
So the study will put through to its publication. We are underway. Another point, let me ask you a personal question. So having discussed either the probability-based and the dimer dependent on presentation and the HD dimer. So in your hospital, having seen the results of years, having seen the results of the current study, how have you proceed? Have you still stick to the HD dimer or have you changed?
No, we didn't change because the prevalence in Geneva is around 19% still now. So we feel that we are better with the age adjusted, but I will happy to change if our prevalence goes down. We will have to change, but for the moment we still are around 19%.
Do you measure the prevalence once yearly?
In continuous.
Okay, we should do it, because we don't do it. Who keeps an eye on the prevalence of PE in their hospital? David does, of course. David, what's the prevalence in the Ramon Caja? 19. That's the same. All right. Okay.
We started 5 years ago with 25%. So your comment is very pertinent. We should measure it on a yearly basis.
Okay. Thanks. Other burning questions? Yes, there is a burning question. Andrew.
Hi. D-dimer seems an imperfect test for pregnant women. Are there any other markers on the horizon, theoretical or in early stages, for predicting the presence of a PE in a pregnant woman?
Fiona, please.
Yeah, so thank you very much for your comment. I would probably respectfully debate that point in that I suppose the recent systematic review published by Dr. Righini and colleagues, and also the 2 prospective clinical management studies, have given us some, a high level of confidence now that a negative D-dimer can rule out important thrombotic events in pregnant women safely. And I am not aware of any other biomarkers that are at a sufficiently advanced stage to be considered for incorporation into a clinical management study at this point.
Yeah, I was thinking something with a better positive predictive value.
Gotcha. I'm not aware. I'm sorry. Yeah.
The problem is always, of course, to get enough data to substantiate this and then to prospectively validate. But I think the point is taken. We also should be aware of not only diagnosis, coming back to the presentation of Stefano, it's an important reason for death in younger women. And especially pregnant ladies are a danger. So diagnosis, please bring it back to your hospital, is so important. And then, of course, the clinical situation-based therapy. I think we have done with this very important subject. Let me thank you once again for your excellent presentation. And now it is poster time. Don't let the nurse get away from you. Control them. And I think we need a sort of practical advice. Where do we go to? But we stay here for the presentation.
So
okay.
Very briefly. Yeah, so I ask our two moderators, Elena and David, who will be supervising the process, very briefly, because this is something, I mean, we practiced it last time. We will have, this is not your abstract, it is the highlights of your abstract. So briefly, as we said, within 2 slides, briefly present what are the main messages. We have those beautiful screens outside where people can come to you and you can have the whole e-poster and then discuss it. We do not have printed posters anymore. So please stick to the time, and Elena and David have been advised to be very strict on this, and there may be, if there is time, some burning question, but overall we said we have 3 times for the presentation and a total of 3 minutes and a total of 5 minutes because people have to come up and then step down and so on. So I say nothing else and move. Give over to you.
Good morning. I'm delighted to introduce this first session of the abstracts. I must say that all abstracts are high level, so we quickly start. The first presenter is Dr. Aluja from Mainz, Germany, and she will be present. She's coming, okay. The title of the abstract is The Increased Expression of oxygenase 1 in myelomonocytic cells reduces hypertension and the risk of cardiovascular damage. Please.
So, thank you for the introduction. So, hello to everybody. I'm really glad to be here today. My name is Melania Aluja. I come from Italy. I'm currently a PhD student in the Center for Thrombosis and Hemostasis in Mainz. So the title of my presentation is The Increased Expression of Hemoxygenase 1 in Myelomonocytic Cells, Reduce Hypertension and the Risk of Cardiovascular Damage. So first, I would give a brief introduction about hemoxygenases. These enzymes are responsible for the catabolic pathway of INB in mammalian, and they are members of oxidoreductase family. We can distinguish 3 different isoforms, hemoxygenase 1, hemoxygenase 2, and hemoxygenase 3. The first and the second isoform are responsible for this pathway, and from this pathway we can obtain 3 different products: iron, carbon monoxide, and biliverdin. Biliverdin is rapidly converted in bilirubin by biliverdin reductase enzyme. Hemoxygenase 2 is a constitutive isoform always expressed in brain, testes, and liver. Hemoxygenase 1 is an inducible isoform that is able to increase its expression in response of hemic stimuli and non-hemic stimuli. It's expressed especially in spleen, liver, and bone marrow. So in my project, I'm currently using 2 different groups of mice, lysenkree mice as a control mice and hemoxygenase 1 inducible mice crossed with lysenkree.
Both models are subject of pump implantation and angiotensin II infusion for 7 days. In this way, we are trying to answer two different questions. The first one is how hemoxygenase 1 can contribute to vascular protection in the cardiovascular disease. And from the intravital microscopy results, we can confirm that hemoxygenase 1 can contribute to decrease the leukocyte adhesion in the vascular wall. The second question is, which physiological process are modulated by hemoxygenase 1 activity? Hemoxygenase 1 is able to increase its expression in response of stress condition, and we can confirm that it's able to decrease the systolic blood pressure and restore the endothelium function in hemoxygenase 1 inducible mice crossed with lysine-3 subject of angiotensin II infusion. The last question is, does bilirubin play a crucial role in the protective mechanism of hemoxygenase 1? This one is one of the end product of the catabolic pathway of heme. It's an important antioxidant element that is able to scavenge reactive oxygen species and reduce the VIII expression. So with this, I would like to conclude my presentation and say thank you to all of you for the kindly attention. I will be happy to answer to any question.
So thank you very much. We will have the opportunity to discuss these presentations afterwards, so we will move to the second one. Thank you.
Thank you.
Second one by Dr. Vaidildinova, differential relactate plasma signatures for platelet activation in subtypes of acute pulmonary embolism.
Good morning, everyone. I'm happy today to present my project, but first let me introduce myself and T-Cardio project. My name is Gauhar Vaidildinova, and I am from Kazakhstan, where I did my bachelor in biotechnology at Al-Farabi Kazakh National University. And after I moved to London, where at UCL I got my degree of Master of Research in Biosciences. After graduation, I came back to Kazakhstan, where I worked at 2 universities as a junior researcher and deputy head of the Department of Science and Innovation. And also I was a part-time teacher for medical students giving lessons in molecular biology. In November 2019, I was honored to join the T-Cardio program. And T-Cardio abbreviation stands for thromboinflammation in cardiovascular disease. And it funds 14 PhD students that are allocated to 3 universities that are Marseille University in France, Maastricht University in the Netherlands, and the main institution is the Center for Thrombosis and Hemostasis in Johannes Gutenberg University, Mainz, Germany. So let me skip to my project. And the title is Differential Relactate Plasma Signatures for Platelet Activation in Subtypes of Acute Pulmonary Embolism. This year, our laboratory published the article in Blood, where the main message is that pulmonary embolism subtypes that are isolated pulmonary embolism and DVT-associated pulmonary embolism have different plasma protein profiles when traditionally these conditions were not considered that be different. And this study was performed using the data from multi-center prospective cohort study, which is called DMP-VT-VAL in Germany. And the protein expression was measured using the proximal extension assay technology under the commercial name O-Link. Later, laser regularized logistic regression models were utilized to find associations between protein levels and this or another isolated pulmonary embolism phenotype. And the aim of my project was to go deeper and to define which of these proteins have relation to proteins. And later, also this year, I finalized my review where I looked at potential markers for platelet activation in patients with cardiovascular diseases and found out that not that much was discovered in venous thromboembolism patients. So this is the aim of my research, and if you are interested, you are welcome to give a glance at my poster.
Thank you. Let's move on to the third presenter, which will be Dr. Broker from Maastricht, the Netherlands. And the title is Pathological Vascular Smooth Muscle Cell Phenotype Switching Increases Expression of Tissue Factor Pathway Inhibitor.
Thank you, everyone. Thank you for the invitation. I'm Vanessa Brækkan, and I'm a PhD student at the Karim School for Cardiovascular Diseases at Maastricht University. And today I'm going to talk to you about the role of tissue factor pathway inhibitor in phenotype switching of smooth muscle cells. So most of you will know tissue factor pathway inhibitor, or TFPI, as an endogenous inhibitor of coagulation. And it does so by binding to the complex of activated factor 7 and tissue factor in an activated factor 10 dependent way. In human, we have two isoforms. We have TFPI alpha, which is the full-length isoform, and we have TFPI beta, which is lacking the K3 domain. But TFPI is not only important in coagulation, it was also shown to have some protective effect on the generation of atherosclerosis. And this varies from expression of integrins or selectins from endothelial cells until giving stability to the plaque of the atherogenesis later, and thereby preventing thrombosis. So what I have done in the laboratory was that we have taken SMCs from human aortic tissue, and we are able, by changing conditions in the cell culture, to drive them into a contractile, so a healthy state, or to a synthetic state, which is the pathologic conditions. You can already see in the middle and the lower panel that they change in shape, in number, and in density. And then we take our samples, RNA, protein, and cell culture supernatant, and we measure TFPI, because previous studies were mostly done in mice. And what we did, we just confirmed that our SMCs express SMC markers, so we actually have SMCs in our culture, and this was tested positive, so we were happy to proceed on with our analysis. Oh, sorry, I didn't do anything. Yeah, thank you. And we also had an increase in inflammatory cytokine interleukin-6, and this contractile marker was expressed on genetic level as well. And looking at TFPI, we had an interesting outcome. We had an increased expression of TFPI alpha and beta. In alpha, it was only a tendency, but for beta, we had a significant increase. And also TFPI cofactor we measured, but there was no significant difference. But then we looked into the cell culture supernatant. We used an in-house developed ELISA, and we saw that TFPI expression was significantly decreased in synthetic phenotype. And looking at the respective TFPI isoform of this, which is responsible for extracellular secretion, we see that normally there is a tendency to have increased gene expression, but secretion into the extracellular matrix is decreased. So that is really interesting for us. And this is really recent, so we just had these results some weeks ago, and our next step would be to test intracellular protein expression to gain further enlightenment in this. If you have any questions for this, feel free to contact me later in the poster sessions. I would like to thank my two groups at Maastricht University and also my second supervisor, Philip Wenzel at the CTH in Mainz. Thank you.
Thank you.
Next one will be Dr. Camilleri, and the abstract title is Pleiotropic Influence of Rosuvastatin on apolipoproteins under association with coagulation factors.
Yes, thank you for the introduction. Indeed, my name is Eleonora, and I'm a PhD student at the Drenthe University Medical Center. And today I will briefly introduce my abstract on the pleiotropic influence of rosuvastatin on apolipoprotein and coagulation factors. So as you all know, dyslipidemia is a well-known risk factor for arterial thrombosis, but its role as a risk factor for venous thrombosis is debated. As we heard also this morning, the role of lipid-lowering drug in secondary prevention of VTE is still an unknown issue. The START trial was a randomized controlled clinical trial that showed that treatment with rosuvastatin for 28 days decreased the level of several coagulation factors, among which factor VIII and Willebrand factors in a patient with a previous venous thrombosis. So in these studies, we were interested in investigating the mechanism behind this decrease, and we hypothesized that statins might decrease apolipoprotein, and that this decrease might be associated with the decrease of coagulation factors through shared mechanism of synthesis and of regulation. So what we did is that we measured apolipoproteins and coagulation factors in the patient, in 126 patients randomized to rosuvastatin at baseline and after 28 days of rosuvastatin. And we assessed the mean difference of apolipoprotein and then also looked at whether this mean difference was associated with the mean difference of coagulation factors. In this slide, in the graph, you can see the relative difference of apolipoprotein between the 28 days of rosuvastatin treatment and the baseline. And as you can clearly see, all apolipoproteins were clearly decreased, with the exception of ApoA1 and ApoA, which were instead increased. And if instead we look at the association with this difference between the difference of coagulation factor, we can see that ApoA4, ApoC1 and ApoC2 were associated with the decrease of factor 7, and ApoA2 and ApoB100 were instead associated with a decrease of factor 11. But there was no association between apolipoprotein and a decrease of factor 8 and Willebrand factor, which were instead the two factors that were most decreased in the START trial. So we concluded that rosuvastatin decreased the level of several apolipoprotein, and this decrease seems to be mostly associated with liver-produced coagulation factors, but not with decrease of factor 8 and Willebrand factor, and therefore there might be other possible mechanisms behind this decrease. Thank you, and I'll be happy to answer any question at the poster.
Next one, Dr. Hartle. Transcription factor inducible cyclic AMP early repressor modulates cardiac monocyte macrophage response in acute myocardial infarction due to metabolic acidic stress.
Yeah, thank you for the introduction. My name is Annabel Hartle, and I'm a medical student and currently working on my doctoral thesis at the Center for Thrombosis and Hemostasis in Mainz. My research is about the transcription factor ISA and its role in myocardial infarction. So let me first give you some background information on ISA. ISA is short for inducible CAMP early repressor, and it is a transcription factor that regulates CAMP-dependent gene expression. CAMP is short for cyclic adenosine monophosphate, and is a ubiquitous second messenger that is involved in regulation of immune cell function. So roughly speaking, elevation of CAMP levels has an anti-inflammatory effect. Therefore, interruption of CAMP signaling is a potential target in autoimmune and inflammatory diseases and disorders. And as the expression of ISA is influenced by changes in the pH, I am examining the role of ISA in myocardial infarction, which is known to cause an acidic milieu. So we work with mice that have a myeloid cell-specific knockout of the ISA gene. These mice, as well as littermate controls, were subjected to ligation, permanent ligation of the left anterior descending artery, resulting in myocardial infarction. Besides the measurement of blood pressure and blood glucose, we examined the heart function with ultrasound, and we were able to detect that the ISA knockout mice show an impaired cardiac function with reduced left ventricular ejection fraction and reduced cardiac output. We also detected an increased infiltration of the infarcted myocardium with CD11b positive myeloid cells as well as inflammatory monocytes, together with an increased expression of myeloid cell adhesion molecules such as WECAM1 and CX3CR1. So altogether, our findings point towards a pro-inflammatory phenotype of the ISA knockout mice. And for more detailed information, for example, on the RNA sequencing that we did of cells that we isolated from the infarcted myocardium, I invite you to have a look at my poster. And with this, I would like to say thank you, and I'm looking forward to getting in touch with you during the next few days.
Dr. Kelliher will present COVID-19 is associated with endothelial dysfunction and enhanced plasma thrombin generation despite pharmacological thromboprophylaxis.
Good afternoon, and thank you for the opportunity to present. My name is Sarah Kelleher. I'm a haematology specialist registrar at the Mater in Dublin and a PhD student with University College Dublin and the Irish Clinical Academic Training Programme. As we all know, hypercoagulability and endothelial dysfunction have emerged as hallmarks of COVID-19 and have been shown to predict disease severity. As discussed earlier, thrombosis, despite thromboprophylaxis, is very high amongst these patients across the world, and we have seen from recent clinical trials that in therapeutic intensity heparin may confer a survival benefit for patients with moderate severity disease. Therefore, in this study, we hypothesized that patients with moderate severity COVID-19 may exhibit enhanced hypercoagulability and endothelial dysfunction despite treatment with standard dose thromboprophylaxis. We recruited 14 patients with moderate COVID-19 as defined by patients that were treated at ward level care, compared to 11 matched controls of patients that were admitted to hospital with an acute infective illness but who tested negative for SARS-CoV-2 by PCR. All patients received standard dose thromboprophylaxis with enoxaparin 40 milligrams once a day, and blood samples were taken 12 hours post-dose with measurement of anti-10A levels. Thrombin generation was measured in platelet-poor plasma using calibrated automated thrombography, and we showed that despite similar clinical and laboratory phenotypes between the two groups, thrombin generation parameters were enhanced in the COVID-19 group. You can see here in the graph on the left, oh sorry, actually it's a different figure. So the graph on the left shows that the TFPI ELISAs in both groups were the same. However, when we analyzed calibrated automated thrombography in the presence of an anti-TFPI antibody, that sorry, I need to start that part again. So we found using that calibrated automated thrombography that endogenous thrombin potential was enhanced in the COVID-19 group, and we also showed that there was a prolonged lag time in the COVID-19 group compared to the hospitalized controls. We then hypothesized that the TFPI released from endothelial dysfunction may have a role to play in the prolonged lag time. So despite both groups having similar levels of TFPI by ELISA, when we repeated the thrombin generation in the presence of an inhibitory anti-TFPI antibody, we showed that the lag time shortened in the COVID-19 group, and that there was no statistically significant difference between the two groups. Therefore, we've demonstrated in this study that patients treated with standard thromboprophylaxis and moderate severity COVID-19 have enhanced thrombin generation compared to hospitalized controls, and that we've postulated that TFPI associated mechanisms may contribute to this. Thank you very much.
Okay, the seventh presenter is Dr. Lu. Inhibition of coagulation factor 11 improves vascular dysfunction and decreases cardiac inflammation in cardiac ischemia reperfusion injury.
Yeah, thank you for the introduction. My name is Chi Luo, a PhD student from the CTH in Mainz, and I'm also a T-cardio early stage researchers. My topic is inhibition of coagulation factor 11 improves vascular dysfunction and decreases cardiac inflammation in cardiac ischemia reperfusion injury. Factor 11 is the part of contact activation pathway, and it can convert to activated factor 11 by factor 12A and the thrombin. It plays an important role on hemostasis and the thrombosis formation. And there is the evidence emerging that the factor 11 could be the novel target in the anti-thrombotic therapies. In a research of Israel, they showed that patients with lower factor 11 activity level has the lower risk of cardiovascular disease and venous thromboembolism events. And also in the hypertension models, that there is the factor 11 thrombin GP1B alpha loop that can affect the platelet and the leukocyte interaction and then affect the endothelial cells. However, the factor 11 and the ischemia heart disease, their interaction is still unknown. So we designed the experiment that the normal black 6 mice were injected the factor 11 antisense and the scramble control for a period of 2 weeks, and then we followed the operation. We will temporarily ligate the LAD for 45 minutes and followed by the reperfusion for 3 days. And then we analyzed the vascular function and the cardiac inflammation by the cytometry, flow cytometry and the real-time PCR and the histology and also the IVM method. We try to answer the following questions. Please check the result in my poster, and then we can easily draw the conclusion that the depletion of the factor 11 can reduce the cardiac inflammation and vascular dysfunction in the ischemia reperfusion models. Thank you for your information.
Next one, Dr. Pavlaki will present erythrocyte components contribute to nitric oxide availability at sites of intramural microhemorrhage.
Good morning. Thank you for the introduction. My name is Catherine Moiko, and I am from University of Thrace in Alexandroupolis. I would like to present to you our work showing that erythrocyte components contribute to nitric oxide availability at sites of intramural microhemorrhage and how it can be a possible mechanism of vascular calcification and dysorogenesis. In our recent work, we show that in sections from patients with aortic stenosis have a calcification of aortic valve lesions, as you can see with red alizarin stain. Calcification was colocalized with red blood cells. Then we could also show in vitro in cell cultures that indeed RBC membranes enhance calcification, while interestingly that the effect was from RBC membranes, but not from intact or lysed RBCs themselves. We could also show in vivo, using RBC membranes from mice knockout for endothelial nitric oxide synthase, that there was no calcification on experimentally induced carotid lesions. Finally, nitric oxide synthase, also in humans, colocalized with red blood cells. So the question is, why RBC lysate show no effect? We first saw that it's hemoglobin-induced effect, and we found that RBC lysate on top of ghosts appear to suppress calcification. As you can see, black bar represents the effect of combining different doses of RBC lysate with ghosts, going from left to the right to more dilute lysate. So suppression compared to ghost alone was high and was reduced with more dilute lysate. Hemoglobin acts as a no scavenger. When hemoglobin is converted to methemoglobin by treatment of RBC lysate with sodium nitrate, the suppression was gone. In fact, as you can see with gray bars, there was recovery of osteoinductive activity of ghosts and even enhancement. Another factor examined that interferes with nitric oxide activity is arginase, an enzyme that competes with inos for their common substrate. Using Western blot, we were able to find appreciable amount of arginase in both, in cell lysate and RBC membranes. So we found that in cell lysate, the amount of ghosts is about 1,000-fold higher compared to the amount distributed to ghosts. Please note here that there appears to be less arginase in cell lysate, but it must be corrected to the amount of housekeeping protein. In ESMC's assay, inhibition of arginase resulted in enhancement of calcification induced by ghosts and RBC lysate as well, and as you can see with gray bars. Please note that in case of RBC lysate, the effect was seen only following neutralization of hemoglobin and not before. So conclusively, RBC lysate and membranes to a higher extent enhance calcification via nitric oxide signaling. Collectively, hemoglobin and arginase interferes with the osteoinductive activity. Thank you, and I'll be happy to see you at our poster to discuss further more details.
Apologize for the mistake, Dr. Moiko.
Next one, Dr. Sanchez from Paris, France. Evaluation of the effects of ultrasound-assisted thrombolysis in a new porcine model.
Thank you. Good morning, everyone. My name is Matteo Sanchez-Borja. I'm a pneumologist in the European Hospital Georges Pompidou in Paris, France. And I'm very grateful for this opportunity to present my work entitled Evaluation of the Effect of Ultrasound-Assisted Thrombolysis in the new porcine model of high-risk or intermediate high-risk pulmonary embolism, or as I call it, the PICP study. This work was performed in the Research and Innovation Unit of the Hôpital Marie-Lannelongue in France. As you may know, ultrasound-assisted thrombolysis is an alternative to systemic thrombolysis and to surgical pulmonary embolectomy for severe pulmonary embolism. Yet, whether it can significantly improve hemodynamic or right ventricle dysfunction in the acute phase for high-risk or intermediate high-risk pulmonary embolism remain unknown. To advance knowledge on this topic, we aim to create an original model that closely recreates hemodynamic dysfunction and right ventricle dysfunction as we see on our most severe patient, and then use this model to test a catheter of ultrasound-assisted thrombolysis. Using a combination of occlusion with autologous clot and obstruction with an occlusion balloon, we managed to achieve the pre-specified severity without killing the animal. Under general anesthesia and sedation, we performed several measurements of hemodynamic, right ventricle function, imaging, biomarkers, dosage at baseline, after embolization, and after 2 hours of using the ECHOS catheter to perform ultrasound-assisted thrombolysis, and each animal was used as his own control. Here are some interesting results. The first picture is there to show you the level of severity we managed to achieve with our model. Look at the mottled skin indicating severe end organ hypoperfusion. The second and third pictures are 3D modelization of the pulmonary circulation before embolization and after embolization. You can see there in white the thrombus in the right pulmonary artery, and in the left pulmonary artery the occlusion balloon. The last picture is an example of the kind of revascularization we managed to achieve after 2 hours of using the ECHOS catheter. You can see more lengthy. If you want to know more about our detail, I will be happy to discuss it with you more lengthy. Thank you for your attention.
Thank you.
And the last one will be presented by Dr. Sang. The thromboinflammation, SIC, and Bratton tyrosine kinase are regulated by multi-site phosphorylation in human platelets.
Hello, can you hear me?
Yes, yes.
Yes, we hear you.
Okay, hello everyone. So my name is Pengyu Zhang. I attend online. I'm from Shanxi province of China. I received my bachelor and my master at the Dalian Medical University, including 2.5-year internship at Dalian Institute of Chemical Physics, Chinese Academy of Sciences for a year. After that, I worked there for 4 months. Later, I got a PhD position in EU-funded project TICADIO. So since 2019, I started my PhD position in ESA Dortmund, Germany. Later, I visited Turkey in the Netherlands, and now I'm visiting the CTH Mainz. Next slide, please.
Okay. Okay.
So, sorry, I could not see the presentation, but I hope it works. So here, the simplified scheme highlights the role of, Next, please. Can you click enter? Then there should be, yeah, okay, great. So this simplified scheme highlights the role of BTK in the intracellular signaling pathway induced by platelet receptor such as GP6, GP1B, and CLAC2. For example, if GP6 is activated by agonists, later the Zuc, BTK, PLC GAM2 phosphorylation, later platelet aggregation, which can lead to a thrombosis or deep vein thrombosis, infection-derived thrombosis. Here, BTK inhibition downstream of platelet GP6 and CLAC2 as a new strategy to prevent these diseases. Next, please. In my lab, selective agonist convoxy was used to active human platelets by cyclinic kinases. It can cause dual phosphorylation of protein with item. Here is the 2SH2 domain, which can recruit Zuc to the membrane, and the Zuc targeting 525, 526 phosphorylation and targeting 352 phosphorylation. Then after Zuc activation, the Zuc substrates like LAT, BTK, also the PLC gamma-2, GP6 activation not can only induce the Zuc targeting phosphorylation, but also the PKC drive the Zuc serine 297 phosphorylation feedback pathway. So in my project, what I'm going to do is to investigate of GP6 mediated multi-site phosphorylation of BTK compared to Zuc in human platelets and the role of PKC. So if you want to know more about my project and the results, please go to my poster. There are more detailed information, and you can also write me. My email address is here. Thank you so much for your attention.
Okay, this was the last presenter. Thank you so much. We finished perfectly on time, and we are all encouraged to go to the poster session to discuss during the lunch session and this afternoon.
Yes, so something housekeeping. So first of all, thank you very much. To be honest, it was not needed to put any pressure on the colleagues who did it perfectly, so everybody was very fast. So thank you so much for this perfect professional way of presenting your work. I would propose, if you also agree, that we can now see, so now that this is still fresh, that we can now speak to our poster presenters. So they have our e-poster there. We have 6 screens, so we will have 2 presenters per screen, and you can actually open a poster from every screen, but there will be 2 presenters per screen, so they will be happy to discuss with you. And then we will have some time, let's say 30 minutes or until 1 o'clock, and then we can go for lunch. So that would be great. And many thanks to you also. I'm totally amazed we made it on time, and thank you to our speakers. Do not forget to come in the afternoon, right? I mean, we have very interesting... So, welcome back. I mean, some colleagues may arrive a couple of minutes later. Just again, some very brief housekeeping information. You have seen we now have our chairs with a very interesting decoration of the table because, you know, that's Professor Sharp's English sense of interior decoration. So this is for the workshops, don't worry. It's a little bit romantic, you know. I mean, you didn't want just to have a sterile table. I mean, so just for you all to know, we will now have our second abstract session. It will be exactly like the first one. So we will be asking you one after the other to present. It went perfectly well, so I'm sure you will be as perfect as your colleagues before you, so please stay within 3 minutes. There can be one or a maximum of 2 burning questions by our chairs. I mean, our chairs, Dr. Baumgartner and Dr. Sharp will decide this. And then, of course, when the session is over, then, of course, we will not immediately go to the abstract like last time. We will wait until the break, because after that we just have 10 minutes break for you to arrange for the workshops. Just something to say in advance, I will say it again later. You know, the workshops, every workshop is repeated once, so it is being given twice, and that means you will have the chance to have every workshop. And you have registered for the workshops that because the second hall that we have is a small one, we will allow up to 30 people to come to the second hall. But if you cannot enter the workshop that you chose now, today, of course you'll be able to watch it tomorrow. So do not worry, none of you will miss any workshop. We also expect you to attend both. So with these few words, I hand over to our chair.
Okay, thanks very much, Stavros. We're going to launch into the second abstract session, and I'll ask my colleague, Dr. Baumgartner, to introduce the first abstract.
So I would like to welcome Dr. Camilleri for the first abstract entitled Coagulation Factor Levels During and After Anabolic Androgenic Steroid Use. Thank you very much.
Thank you for the introduction. So my name is Eleonora. I'm a PhD student at Leiden University. And for this abstract, I will show you the results of our study on the association of changes of coagulation factor levels with anabolic steroid use. So, as you might know, anabolic steroids, although illegally traded in many European countries, are frequently used by professional and non-professional athletes to easily increase their muscle mass and physical performance. It is pretty difficult to establish the prevalence of the use of these steroids, but it is approximated at 1 to 6% of frequenters of gym regularly use steroids. Steroids are generally regarded as harmful, and they have been associated with an increased risk of venous thrombosis, but the mechanism behind this association is unclear. So we hypothesized that steroid use might induce changes in coagulation parameters that might then mediate this increase in risk, and wanted to investigate this in our study. So we used the data from the Harlem study, which is a study that was conducted in Harlem, as the name suggests, and enrolled 100 men intending to start a steroid cycle and then follow them for over time. As you can see in the timeline, we measured coagulation parameters at 3 time points: one before steroid use, one during, and one after. And we compared them using a linear mixed model. We were also interested in looking whether higher cycle intensity, so higher steroid dose or a higher cycle duration, were associated with a more prominent change in coagulation factors. So in this slide, you can see the relative changes of coagulation factors comparing the parameters during steroid use with the baseline level. And in red, you can see depicted the changes with a procoagulant direction, and in blue, the one with anticoagulant direction. And as you can clearly see, steroid use affected several coagulation parameters, increasing mean levels of factor 2, factor 9, and factor 11, whereas interestingly, it did not affect von Willebrand factors and factor 8 levels. The 2 most increased parameters were D-dimer, with a 53% increase, and protein S with a 22% increase. When looking at our second aim to look whether the cycle intensity was associated with more prominent change, we actually found that only protein S, so a higher dose of steroids and a shorter cycle duration were associated with increased change of protein S. If you're interested to know what happens after steroid withdrawal, I will invite you to look at my poster or just come to me for any question. Thank you.
Thank you very much. Maybe I still have a short question. Sorry. So you mentioned that you enrolled men who said they intended to use steroids. So did you counsel them to tell them you should actually not use steroids?
Yes. In Harlem, there's a so-called anabolic poly, so for a steroid user, in which they are actually, these people come and they are actually counseled not to, but some of them just do that anyway, and you cannot stop them. So after several years, the people in Harlem just decided, well, that's at least something to study and see whether it's actually harmful, and we can just use this data to counsel them better and maybe find more evidence.
Okay, thank you very much.
Okay, so next up is Dr. Bosevsky from Skopje in North Macedonia, who's going to be talking about pulmonary thromboembolism with cardiogenic shock as a first manifestation of COVID-19. Is Dr. Bosevsky here? Hello, is Dr. Bosevsky here from North Macedonia? Okay, well, let's move on to number 3 then. Maybe they've been indisposed.
So the third abstract will be presented by Dr. Makowski, and we will hear about characteristics of the group of patients with acute pulmonary embolism infected with COVID-19, a single-center study. Thank you very much.
Good afternoon. My name is Michał. I work in Warsaw University, Medical University in Infant Jesus Teaching Hospital. I would like to express my gratitude for the organizers for letting me share with you some of our observations. My hospital is one of the oldest in Warsaw that dates back to the beginning of the 20th century, and it has a very unique feature is that it consists of many different pavilions because it was most likely to die of infectious disease at the beginning of the 20th century. And to connect tradition with modern times, during the second and third COVID waves in Poland, we were converted into COVID-19 only treatment center, and what was unique about us is that we were one of the 2 cardiac centers that were especially dedicated to treatment of COVID-19 patients with cardiac conditions. One of the 2 centers in Mazowieckie Voivodeships that cover a really significant portion of Poland. For that reason, we were equipped extensively in the devices, especially in high-flow nasal cannulas and additional ventilators. Before COVID and between next waves, we are one of the reference center for the treatment of VTE in Poland. So that is only natural that we were especially interested in patients with acute pulmonary embolism that we hospitalized during the COVID-19 pandemic. We decided to compare patients admitted to our clinic that suffered from COVID and from APE and those without APE, and we found out that those both groups were quite similar. Nevertheless, when about our short research, I would like to invite you cordially to join me after the sessions. Thank you.
Thank you very much. So it's interesting to see that you didn't find an association between mechanical ventilation and acute PE. We heard this morning that PE is more frequent in patients with more severe illness. Did you look at other parameters of illness severity, like ICU level care or some score of severity?
Not really. We tried to analyze different parameters and we couldn't really find any differences between the groups. Maybe we should just do it more precise. Nevertheless, we were quite surprised that those both groups were similar. Even the lung involvement was similar in both groups. So in fact, we've heard that sometimes APE was something that would require patients to be ventilated mechanically, but not in our case. Nevertheless, we had patients treated interventionally because it's also a specialization of our center for the APE, and he suffered mainly from COVID. And then his clinical state decreased, and he required mechanical thrombosis thrombectomy for the rheolytic thrombectomy for the APE.
Thank you very much.
Thank you. In case you haven't worked it out, we're going to ask you all a question. So thank you. Anyway. Everyone was so disciplined the first time around. The second group get a question now because we know we've got time. So I'm going to invite up Dr. Gendron from Paris in France to talk about increased suspicion of heparin-induced thrombocytopenia during the COVID-19 outbreak. So a lot of science about COVID-19 here, a lot of interest.
Thank you for the introduction. Good afternoon, everyone. My name is Nicolas Gendron. I'm hematologist at the Georges Pompidou European Health Hospital. I will talk about heparin-induced thrombocytopenia during COVID-19 pandemic. Heparin-induced thrombocytopenia is a prothrombic adverse drug reaction caused by antibodies against platelet factor 4 and heparin complex that lead to platelet and endothelial activation that lead to venous and arterial thrombosis. So due to the frequency of thrombosis during heparin therapy in COVID-19 patients, diagnosis of HIT and the frequency was still a matter of debate. So the aim of our study was to describe HIT suspected patients during the first wave of COVID-19 during March and April 2020 in patients with or without of COVID-19. So we include all the patients with a HIT suspicion during this period, and we compare also to the same period, study period in 2019. So you can see in 2019 we had 17 HIT suspicion, but only one case of HIT confirmed diagnosis. And during the first wave of COVID-19 pandemic, we had 42 HIT suspicion, 19 HIT suspicion in COVID-19 patients with 4 diagnoses of HIT confirmed. And in COVID-19 positive patient, we had 23 HIT suspicion, but we had known case of HIT in this group of patients. When we compare clinical and biological characteristics in our group, there is no differences. The 40 score was able to exclude HIT patients in 60% of COVID-19 patients. A note, there is a trend of higher mean duration of heparin in patients with COVID-19. So to conclude, during COVID-19 outbreak, we observed a twofold increase of HIT suspicion. We did not diagnose more confirmed HIT in COVID-19 patients, and the classical use of the 40 score and the antibodies against platelet factor 4 antibodies is useful in COVID-19. Thank you.
Don't run away. So what we haven't got is a hypothesis. So do you think this is coincidence, or do you think something has caused this?
No, I think we had, during the outbreak, we had more patients in ICU. We use more heparin. We use therapeutic dose or intermediate prophylactic dose. So we had more patients in ICU with more heparin, so we have more suspicion. And COVID-19 don't lead to HIT.
And did you notice a dose relationship with this, or was it just?
There is no dose relationship.
Yeah. Okay, great. Thanks very much.
Thank you. So the next presenter will be Dr. Graziani. She will present the abstract entitled Role of Heparin Prophylaxis at Different Doses in Patients with COVID-19 and Respiratory Failure, a Systematic Review and Meta-Analysis. Thank you very much.
Thank you. Good evening. I am Mara Graziani. I come from Perugia, and I'm going to introduce my meta-analysis. We know that a high incidence of thromboembolic complication was reported in patients hospitalized for COVID-19 that seems to persist despite the use of standard heparin prophylaxis. The aim of the meta-analysis is to compare standard dose versus high dose, intermediate or therapeutic heparin prophylaxis for the prevention of venous thromboembolism in patients with respiratory failure due to COVID-19. Regarding methods, we included in the meta-analysis studies on hospitalized patients with COVID-19 if VTs and measured bleeding were reported by treatment group and if greater than 10 patients were included. Primary study outcome was in hospital VT. Secondary study outcomes were measured bleeding, all-cause death, fatal bleeding, and fatal pulmonary embolism. At the end of the selection studies, the selection process, 26 studies satisfied the criteria for the inclusion in the meta-analysis. 6 were randomized controlled trials, 4 were prospective, and 16 were retrospective cohorts. Main findings were a significant reduction of VTE in the patient receiving high-dose heparin prophylaxis compared to those receiving standard dose heparin prophylaxis with a risk ratio of 0.75. Measured bleeding are nearly double in patients receiving high-dose heparin prophylaxis compared to those receiving standard dose heparin prophylaxis with a risk ratio of 1.85. Furthermore, all-cause death occur in 19.5% of patients receiving high-dose heparin prophylaxis compared to those receiving standard dose with a risk ratio of 0.85. In addition, we perform a sub-analysis on ICU and non-ICU setting, and no reduction in VT or death was obtained with high-dose heparin in ICU setting. In conclusion, the use of heparin at high dose reduces the risk of VT, but increases the risk of measured bleeding compared to standard prophylaxis. And also, the use of high-dose heparin in non-ICU setting should be further evaluated. Thank you for your attention.
Thank you for this very interesting presentation. So I was wondering, did you also do a subgroup analysis according to study design? So did you just also do an analysis only looking at the randomized trials? Okay.
According to the study design, we selected studies with 2 group treatments, standard prophylaxis and versus high-dose heparin dose, intermediate or therapeutic.
But you didn't look whether the results differed in randomized trials compared to observational studies?
Yes, we observed that there is no difference between the intermediate or therapeutic group, for example, in the ICU setting.
Okay, thank you very much.
Okay, so we're going to go on to Dr. Huisman from Amsterdam in the Netherlands. The topic is evaluation of the Corana, PROTECT and 5 SMP scores for prediction of venous thromboembolism in patients with cancer. Thank you very much.
Yes, thank you. Hello everyone, my name is Huisman from Amsterdam. As we were told by Professor Huisman this morning, cancer is one of the most important risk factors for venous thromboembolism. And several risk prediction models to identify those patients at highest risk of VTE who may benefit from thromboprophylaxis have been developed. Today, the Corana score is the most renowned of these models. However, with this score, most of the patients who will develop venous thrombosis are classified in the low-risk group of the score. So in this study, we aim to evaluate whether the PROTECT score and the 5 SNP score could improve risk prediction with the Corana score. We performed a retrospective study in 2,700 patients with advanced-stage solid cancer and excluded all patients with ongoing anticoagulants and patients with non-melanoma skin cancer only. For the primary outcome, we maintained symptomatic and incidental deep vein thrombosis and pulmonary embolism during 6 months follow-up. In the analysis, we first calculated the C-index of the scores, which is comparable to the area under the curve statistic. Then we dichotomized the scores to classify patients in a high and in a low risk group, and calculated the cumulative VT incidence in both risk groups. We also assessed the relative risk between the high and the low risk groups using subdistribution hazard ratios, all accounting for death as competing risk. Last, we calculated the sensitivity and the specificity of the scores. As you can appreciate from the results section, the median age in our cohort was 63 years, 50% was female. Most frequent cancer types were breast, melanoma, lung, and colorectal cancer, and 90% of the patients received systematic cancer treatment. If you look at the indices for the scores in the table, we see that this varied between 0.54 and 0.6, which indicates poor, continuous predictive performance of all the scores. If we then look at the dichotomous Corana score above, we see that in patients with a score of 3 points or more, the risk was 12%, whereas in patients with a score lower than 3 points, it was 6%. The subdistribution hazard ratio was 1.9, which indicates a twofold increased risk in the patients in the high risk group. But the sensitivity was low, namely 17%, which indicates that 83% of the patients who did develop VTE were classified in the low risk group. For the PROTECT score, at the positivity threshold of 3 points, the results were similar, with a somewhat higher sensitivity of 30%. The 5-SNP score was evaluated at the cutoff of 1.8, and what we see is that the patients with a score above 1.8 had a VTE incidence of 10%, whereas the patients with a score lower than 1.8 had the incidence of 6%. The subdistribution hazard ratio was 1.7. And this is interesting because this shows that merely with prothrombotic SNPs, we can actually identify patients at higher risk of venous thromboembolism. But it should be noted that this was generally lower than with the clinical scores, and the sensitivity was lower as well. So in conclusion, we found poor predictive performance of all the scores. The dichotomous scores could identify patients at twofold increased risk of VTE. However, up to 70% of the patients with VTE were actually classified as a low-risk patient. And these results do therefore not support the use of the 5-SNP or PROTECT score above the Corana score. It would be interesting to see what happens if we combine the genetic and the clinical predictors together in one model, and that's something we're currently working on. If you want to see what happens when we lower the positivity thresholds in these scores, please have a look at my poster. Thank you.
Don't run away. Don't run away. That's excellent. That's excellent. So one of the things about scores that predict for clotting events is they frequently also predict for bleeding events. Do you have a sense from your data whether these were the same patients at high risk of bleeding as were at high risk of coagulation? Because it presents a conundrum as how we prevent the clotting problem if they're at high risk of bleeding.
Yeah. Thank you for your question. So to start with the Corana score, I think there have been studies which actually assess whether the Corana score could predict bleeding, but this wasn't a prominent effect of the Corana score. Whereas for the PROTECT score, the additional factors in the PROTECT score are the use of gemcitabine therapy and platinum-based chemotherapy, and these are known to increase the risk of bleeding, the risk of thrombosis, so not the risk of bleeding. And also the SNPs in the 5-SNP score, which are included, are all prothrombotic. One of these is, for example, factor V Leiden, and this is not associated with increased risk of bleeding. So I don't think that these would also predict bleeding. Of course, when we think of giving a patient primary thromboprophylaxis, we should also consider the bleeding risk, but I think we should using other risk factors than these scores.
Thanks very much.
Thank you.
So the next speaker will be Dr. Juretic with the abstract entitled Pregnancy Outcomes in Women with APS Compared to Women Without APS Treated with Low Molecular Weight Heparin and Aspirin, a comparative retrospective observational study.
Hello, my name is Andrei. I come from Ljubljana. Thank you for the opportunity to be presenting here. So, as you all know, antiphospholipid syndrome is an autoimmune disease which is defined by the persistent presence of circulating antiphospholipid antibodies and by its clinical manifestations of thrombotic and/or pregnancy-related complications. APS is an acquired prothrombogenic state, and pregnant women are at particular risk for its complications. The cornerstone of medical therapy in patients with thrombotic APS is anticoagulation treatment with vitamin K antagonists, whereas during pregnancy, treatment with low-dose aspirin and therapeutic dose low molecular weight heparin is suggested in order to prevent thrombotic and obstetric complications. Data regarding the suggested treatment is scarce. So the aim of our study was to evaluate the efficacy and safety of the established medical management in pregnant women with thrombotic APS and compare them with results with pregnant women without APS who received anticoagulation with low molecular weight heparin. So we followed the outcomes of pregnant women treated with therapeutic dose low molecular weight heparin who were registered at our outpatient clinic. We divided the patients in two groups, the APS and the non-APS group, and then we later compared the pregnancy outcomes and the incidence of new thrombotic and hemorrhagic events in both groups. So these are the results. We had approximately 140 cases, 28 in the APS group and 112 in the non-APS group. So we then checked the fetal adverse events and maternal adverse events. Fetal adverse events, we looked at preterm delivery, fetal miscarriage, intrauterine fetal death, intrauterine growth restriction, and fetal distress. So with maternal adverse events, we looked at clinically relevant bleeding, new thrombotic events, and preeclampsia. So basically, we observed no statistically significant differences in hemorrhagic complications, new thromboembolic events, and most fetal adverse events. So our results are similar to what has been reported in a limited amount of other studies, and we conclude that the treatment with low molecular weight heparin and low-dose aspirin is a safe and effective choice for pregnant women with thrombotic APS. Thank you for your attention.
Thank you for the presentation. So what character or what kind of women were the women who were treated with low molecular weight heparin and did not have APS? Why were they treated with low molecular weight heparin?
These were women that had previously a previous thromboembolic event. So that was deep vein thrombosis. Perhaps they had other procoagulable states like factor Leiden 5 mutation and so on. Also, some of the women I think had an arterial emboli and so on. Yeah.
Thank you.
Next up, we have Dr. Kaptein from Leiden in the Netherlands, talking about prevalence, treatment and prognosis of tumor thrombi in renal cell carcinoma. Thank you, Dr. Kaptein.
Thank you. Thank you very much for the introduction. Good afternoon, everyone. On behalf of all co-authors, I'm very happy to have the opportunity to present our study today. Renal cell carcinoma can be complicated by a venous tumor thrombus, which means there is intravascular tumor extension, which usually occurs in the renal vein, but can grow into the inferior vena cava and may extend all the way up into the right atrium, as you can see in the figure. Several studies indicate that tumor thrombi patients have a higher risk of venous thromboembolism, but those studies did not assess the use of anticoagulation or the bleeding risk. So at the moment, the optimal treatment regarding anticoagulation in these patients is unknown. Therefore, the aim of our study was to assess the prevalence of tumor thrombi in renal cell carcinoma, its current management, and its prognosis, focusing on the association with venous thromboembolism, major bleeding, and survival. We performed a retrospective chart review in renal cell carcinoma patients, and we followed those patients for 2 years. We included 647 patients, of which 86 had a tumor thrombus at diagnosis, which corresponds with a prevalence of 13%. We did not find a uniform treatment of tumor thrombi regarding resection or anticoagulation. We did find a very strong association between the presence of a tumor thrombus and venous thromboembolism, as you can see in the figure on the left side, where you can find cumulative incidences adjusted for the competing risk of death of tumor thrombi patients in the blue line and of patients without a tumor thrombus in the red line. But on the other hand, we also find an association between tumor thrombi and more major bleeding events, as you can see in the figure on the right side. Also, tumor thrombi patients faced a higher mortality. In our cohort, we did not find a significant decrease in venous thromboembolism events in tumor thrombi patients that were treated with anticoagulation versus patients without anticoagulation. But it may very well be that only certain subgroups of tumor thrombi patients may benefit of anticoagulation, but it has to be further elucidated. So if you're interested in the remaining of our results, I hope to see you at my poster later on. Thank you for your attention.
Okay, I'm actually going to ask a question to the audience rather than you in the first instance. How many are surprised by an incident of 13%? Were you surprised by that? That's quite high.
Yeah, it's quite high, but I have to say that we also included patients with only a tumor thrombus in the renal vein. So usually this gets resected. Yeah, I say that. They just perform surgery. But the majority even had extension into the inferior vena cava. This is still quite high.
And did these patients undergo routine screening in some way? Is that why it's such a high pickup rate, or is this what you think is the pickup rate?
No, it's like retrospective, so we just, what's the clinical picture? Yeah.
Okay, look forward to the rest of the results. Thank you very much.
So the next speaker will be Dr. Micheli with her abstract, Global Use of Risk Assessment Models and Thromboprophylaxis in Hospitalized Patients with Medical Illnesses, a systematic review and meta-analysis.
So, good evening, dear colleague. My name is Sevi Micheli, and I work at the University Hospital of Zurich at the Department of Angiology. I would like to present you our study about the global use of risk assessment model and thromboprophylaxis in hospitalized medical illness patients. So we know from the multinational endorsed survey from 2008 that the thromboprophylaxis among medical hospitalized patients was underused, and we made this research to assess the current use of it. So we had basically three outcomes. The first one was the indication of thromboprophylaxis according to different risk assessment models. The second one was to assess the use of thromboprophylaxis among these patients. And the third one was to understand the contraindication. So we found out 27 studies with a total number of patients for 140,000. And we find that the thromboprophylaxis was used in 54% of the patients who was considered at high risk for VTE, and there was a difference across the used risk assessment model, and there was also a very big difference in the different continents, and the widest used was in North America and the lower was in Asia. And about the contraindication, we found out that the most frequent were the active bleeding, thrombocytopenia, bleeding disorder, and renal failure, and they account for more or less 10 to 50% the patient. So we concluded that the thromboprophylaxis among medical hospitalized patients has improved in the last 10 years, but is still underused. And thank you very much for your attention, and I would like to thank all the colleagues that collaborated with this project. And if you have questions, I'll be glad to answer at the poster area. Thank you very much.
Thank you for these insights. So there is still a lot of potential to improve, as you said. So what would be your suggestion on how we can improve the rate of thromboprophylaxis use?
Yeah, it's a very difficult issue, but I think we have to understand, first of all, why the doctor don't want to use it. Because I think there is a reason that the doctors say maybe it's not so necessary. So maybe we should demonstrate that it's very important for the outcome of our patient, and it's not so dangerous, because the safety is very important. That if we understand the reason, then we can fight against this tendency.
So you think the reason would be that the doctors are not convinced about the efficacy of thromboprophylaxis?
Yes, I read many studies to do this investigation, and in some of these papers, someone also gives some reason why they are not convinced to do that. So I think the doctor, maybe it's also a problem that we have systematic to screen our patient, and we have to use more the score. That's okay, that's a point. But I think it's also important to understand other reasons, not only because the doctor, they forget it.
Thanks a lot.
You're welcome. Thank you.
Okay, so next up we have Dr. Pilares Robles from Mainz in Germany, talking about unsupervised clustering of venous thromboembolism patients by clinical features at presentation, and how it identifies novel endotypes that may improve prognostic stratification.
Hi, hello everybody. So my name is Alejandro, I am from Spain, and I'm doing a PhD in 2 different institutions, in the CDH in Mainz, and also in Maastricht, the Netherlands. And today I would like to present a different alternative approach for the stratification of patients with an acute venous thromboembolism using unsupervised clustering and clinical characteristics with the aim of improving the prognostic stratification. So I hope everybody in this room agree with me that venous thromboembolism is a complex disease, it's also heterogeneous and multifactorial, and anticoagulation is still the cornerstone for the treatment strategy. Therefore, new ways of exploring subgroups of patients with venous thromboembolism could help to develop new strategies for treatment and also decrease morbidity and VD-associated sequels. So therefore, we propose the use of unsupervised clustering. Unsupervised clustering is a machine learning technique that allows the identification of clinical patterns across multidimensional data that due to our low computational brain we are not able to detect. Also, this approach, the main goal is to identify subgroups of patients that share similar clinical characteristics. And this approach has been applied in different complex diseases such as heart failure, atrial fibrillation, and chronic obstructive pulmonary disease. So using individuals with an acute setting of venous thromboembolism from the GMP-VTE, a prospective cohort from Mainz, we propose to use a survived cluster in this list of clinical characteristics but also routine laboratory markers to identify subgroups that differs in clinical outcome. So using this huge amount of data, we identify 4 different clusters using hierarchical clustering. So these endotypes not only differ in clinical characteristics that we can see summarized in this table, but they also differ in the clinical outcome for the combined endpoint of recurrent VD or death and arterial events for a follow-up period of 3 years. And surprisingly, also, these subgroup of patients also differ in several plasma protein measured with high sensitivity immunoassays, depicting not only the high heterogeneous complexity of VD patients, but also the molecular complexity of VD patients. So briefly, I would like to summarize each subgroup of patients. Endotype 1 was composed for older patients diagnosed with pulmonary embolism and deep vein thrombosis with a higher history of VDE, higher burden of cardiovascular risk factor, absence of provoking risk factor, high inflammation, and low glomerular filtration rate. And as you can expect, they have the worst prognosis, not only for recurrent VTE, but also for arterial events. In contrast, endotype 2 was constituted by individuals with pulmonary embolism with or without deep vein thrombosis, also with absence of provoking risk factor, but they have a lower burden of comorbidities, high leukocyte count, and they were treated more frequently with factor 10 inhibitors. And surprisingly, they have the lowest incidence of recurrent VTE and also arterial events. Endotype 3 is a small cluster composed of younger females diagnosed with deep vein thrombosis and provoking risk factor mainly associated with the use of oral contraceptives. And they have a moderate risk for recurrent VTE and arterial thrombosis. The last endotype was constituted mainly by males with deep vein thrombosis, provoking risk factors such as surgery, mobilization, and a higher history of VTE. And they have the second highest incidence of recurrent VTE, but also arterial events. So if you are interested to know more about clustering techniques or machine learning, and also discuss about these subgroups, I will be pleased to answer your question in the poster session. Thank you for your attention.
Thank you, that's very interesting. This is what I imagine artificial intelligence is going to do in the future. It's going to put in hundreds of parameters and categorize people like this and give us...
But I'm doing it right now.
Yeah, you are the artificial intelligence right now. So what's the next steps from this? Do you see...
Yeah, the next step will be taking... I mean, the GPVD is a rather small subgroup of patients. It has around 663 individuals with an acute venous thrombosis. So another step, we'll see if we can identify this cluster also in the chronic state of the disease, and also using larger cohorts and validate these subgroups, or maybe identify new ones, and try to understand what is also the molecular pathophysiology of the disease.
You can go both ways, can't you? You can look backwards and forwards and see if you can adapt treatment as well as understand what led them here. Yeah. So nice work, thanks very much.
Okay, thank you.
So the next speaker will be Dr. Simeon from Padua with her work entitled Comparing the Coagulative Profiles of the First versus Second Wave and Post-Discharge of Medical Patients with COVID-19 Pneumonia.
Good afternoon. Thank you for the introduction. It's a pleasure to be here today. I'm Simeon Chiara from Padua, Italy. I'm currently attending the second year of geriatric residency at the Thrombotic and Hemorrhagic Diseases Unit of University Hospital of Padua. As we all know, COVID-19 pneumonia has been associated with a peculiar coagulopathy with high levels of D-dimer, prolonged coagulation times, and a marked hypercoagulable profile at thromboelastometry. However, some studies showed that during 2020 SARS-CoV-2 pandemic, the effect of the virus varied between the first wave in spring and the second wave in autumn and winter. But currently, it is unclear whether COVID-19 patients presented with different coagulation profiles too. So we enrolled 28 patients from the first wave admitted to our internal medicine wards with mild or moderate pneumonia, COVID-19 pneumonia, and 64 patients during the second wave. Clinical characteristics, blood parameters, coagulation panel, and roten thromboelastometry were collected within 48 hours after the admission. According to our findings, second wave patients were older and presented with a more pronounced inflammatory state, as demonstrated by a higher SOFA score and a higher levels of neutrophils, CRP, procalcitonin, fibrinogen, and D-dimer, as well as a longer clotting time in extem and a longer clot formation time in extem and intem. not significant differences were found between the two waves according to maximum clot firmness in VIII, which is a marker of activation of fibrinogen-driven coagulation. Finally, the risk of venous thromboembolism and the overall prognosis were comparable. Moreover, the coagulation profile after the resolution of the infection was assessed. In fact, we collected during the second wave the same above-mentioned parameters for 20 patients, 28 days post-discharge. In conclusion, compared to admission, we found a normalization of both the standard laboratory data and the Rotem parameters. Maximum clot firmness in VIII was reduced, even if it persisted at the upper limit of normal. And that brings me up to the end of my presentation. Thank you for your attention.
Thanks a lot. How did you recruit your patients? Did you just take all that were admitted during the first or second wave, or did you choose a random sample for your analysis?
We were transformed in a COVID ward, and so all the patients were for all the patients we collected these parameters, but we excluded some patients. There was some patients which were COVID positive, but that did not have pneumonia. There were some patients who were before in anticoagulation therapy. There was a patient with cancer active, and there was also some patients who were first admitted in other wards, such as ICU, and then transferred into other wards. So we excluded that patients.
Okay, thank you. And how do you explain these differences that you observed?
I think in the second wave we had more older patients, and they are more fragile and so more prone to develop infection, bacterial infection other than COVID-19 pneumonia.
Thanks a lot.
Thank you.
Okay, and then coming to the end of an excellent session, we have the final speaker. Apologies for the pronunciation, Dr. Stees from Leiden in the Netherlands, ruling out pulmonary embolism in patients with COVID-19, a prospective cohort study.
Yes, hello, good afternoon, everyone. My name is Milou Stals.
Thank you.
But thank you for the kind introduction. And on behalf of all the co-authors, and also on behalf of the Dutch COVID and Thrombosis Coalition, I'm very happy to give a brief introduction on our study on ruling out pulmonary embolism in patients with suspected COVID-19. So patients with COVID-19 are known to be at high risk for venous thrombotic complications, and especially pulmonary embolism is frequently observed. Yet guidance on the best diagnostic approach for suspected PE in these patients is lacking, as diagnostic strategies for suspected PE have not been prospectively validated in the setting of COVID-19. And therefore, the aim of our study was to prospectively evaluate diagnostic strategies for suspected PE in patients with COVID-19. And in order to do so, we performed a prospective multi-center outcome study in 707 patients with both suspected and confirmed COVID-19 and clinically suspected pulmonary embolism. So we included patients between March 1 and October 29 of 2020. All these patients were managed according to validated diagnostic strategies for suspected PE, and we then evaluated the safety, which was defined as the 3-month failure rate, and the efficiency, which was defined as the number of CTPA scans avoided of these applied strategies. In the end, we included a total of 707 patients, and from these patients, 255, or 36%, were managed according to the years algorithm. From the remaining patients, most patients immediately proceeded to CTPA, and only a small minority was managed according to the Wells rule. But focusing on the patients that were managed according to the years algorithm, from the patients in whom pulmonary embolism was excluded without CTPA, so the patients on the left of the flowchart, one patient was diagnosed with a non-fatal pulmonary embolism during follow-up. Consequently, the 3-month failure rate was 1.4% with a 95% confidence interval of 0.04 to 7.8. From the patients in whom pulmonary embolism was excluded after negative CTPA within years, so patients on the right of the flowchart, 10 patients were diagnosed with a non-fatal VTE during follow-up. Consequently, the failure rate in these patients was 8.8% with a 95% confidence interval of 4.3 to 16. In conclusion, these study results underline the applicability of the years algorithm in suspected COVID-19 patients, as CTPA could be avoided in 29% of the patients managed by years in the presence of a low failure rate. Still, importantly, the failure rate after negative CTPA was non-negligible, and this reflects the high thrombotic risk in these patients. Last but not least, I want to thank you for your attention, and please visit my e-poster for the other study results. Thank you.
Thank you, Dr. Stiles. So, did anybody go back and look at these CTPAs and see if there was something that was missed, that was dismissed in the periphery, or do you just think this was entirely de novo pulmonary embolisms occurring in these patients after discharge?
Yeah, well, we did not ourselves look back at the baseline CTPA scan. We did of course, had an adjudication committee to look at the individual diagnostic failure cases. And we did saw that, for instance, some patients had at the baseline presentation a CTPA scan with no indication for a pulmonary embolism, even not a subsegmental PE. And then after a couple of days or a couple of weeks, patients deteriorated and got a new CTPA scan, and then they had a PE. So most of these diagnostic failures were observed in patients that were still hospitalized, and even despite pharmacological thromboprophylaxis.
Okay. So what's your conclusion about what to do about these findings?
Yes, well, I think that we can use these diagnostic strategies. At least, well, of course, we looked at the years algorithm. Only a small minority was managed according to the Wells rule, so only 4.2%. So that is too small to really base a conclusion on. But based on these study results and then focusing on the years algorithm, we can use these algorithms to diagnose these patients. So I would advise to not immediately perform CTPA scan. Of course, what I did mention was that the failure rate, even after a normal CTPA scan, was very high. So we have to really be careful if patients deteriorate, that we perform new diagnostic tests.
That's great. Thank you very much.
Yes.
Okay. Okay, so I think that brings us to the end of this session. So, Christine, would you like to close out?
So thank you very much to all the presenters. It was really a very interesting session. I appreciated to hear your work a lot. I think we all did. I think we have more time to ask questions to the presenters at the poster session later on.
Okay,
so,
Stavros.
Many thanks to our excellent presenters and excellent chairs for this very nice session. Again, everything absolutely on time. So what we would do now is that we have about, well, let's say 17, 18 minutes until the workshops. So as you know, we have parallel workshops, and the workshops are also repeated. That means those of you who will go instead of workshop 1 to workshop 2, they will go attend workshop 1 the next time. Now, it's a little bit more complex because we have COVID-related restrictions. That is, when we will have the odd number of workshops here today, with one exception in the end. We will talk about that at 7 o'clock. But now we will have workshop 1 here, and workshop 2 in the other room, in the Apollo room, which is smaller. And then in the second session, we will have workshops 3 here and workshops 4 in the small room to make it more simple. Now, so there is now one thing. This is a big room, so here we are allowed to have up to 60 persons for the workshop. We do not want to have very many so that you will interact, right? It will not be lectures. We may show some slides, but we will be a workshop. So we will make sure that there can be no more than 30 of you in the small room, right? And of course, also not 5 there and 70 here, because on the next day you will not be able to watch the other workshop. I hope you understand what I mean. So approximately 2/3 please stay here, 1/3 go to the other workshop, and on the next day, of course, you will exchange. And those of you, the fewer of you who were there, will be in this case. And so I hope that by doing this, we will be able to.
Should we partition by room, and then they can swap tomorrow?
Yes, we will. As I said, we will have the first. We will have the. So the workshop that will be here will always be the workshop that will have the largest number of patients. We will have 1 here, 2 there, then 3 here, 4 there. Patients, participants.
Yes.
Okay, but you know what I mean. But now we have a small break. You can also meet the presenters, but perhaps it is a little bit better to meet the presenters at the break, right? Because there we have half an hour, and here it will be 15 minutes, and it may be a little bit stressful. So if the presenters also agree, let us visit the posters when we have the half an hour, the 30-minute break. So now you have the time a little bit to find your way through the workshop.
People pre-registered to go to which room or not? Yes, they have. Okay. Okay. I was just thinking, because there'll be a scramble. Okay. I was going to suggest we just take the back third of the room and send them that way. So, thank you very much. I think Stavros mentioned that, but I don't know.
Just a mic. Thank you. So, once more to be absolutely clear. So let's say we have 90 colleagues, right? So 60 Okay, so we start with our first hands-on workshop. This is a workshop that I will be doing also with Dr. Michele Dalto from Napoli. He will be joining us a little later, and he will be showing us a little bit some more details on his technique, but now we will do it practically. And you will also have the opportunity, and I would really invite you and urge you to use it because we are very thankful to the Cathy company that builds this simulator, and they are here with us. They came from Germany to have it. So this is supposed to be a human body or a patient in whom we will insert the catheter, and you will be seeing here the hemodynamic parameters and what we are doing. And of course, if you wish, of course, we cannot have you all come to us like this, but you can also come closer. And tomorrow, we will have the opportunity at the afternoon break, so half an hour before the start of the afternoon sessions, there will be another demonstration so that you can see it. Can I ask you, how many of you treat patients with pulmonary embolism in practice? Okay, so this is the vast majority. How many of you treat or see patients with chronic thromboembolic disease? Okay. So how many of you see other patients with pulmonary hypertension, perhaps? Okay, again, the majority, 60%. How many of you can do a right heart catheterization? Well, that's a shame, you see? So that's a workshop. So what are you telling those patients? So it is important. Of course, you do not have to do yourself everything. I mean, if you drive a car, you don't have to be a car mechanic, but of course you have to know what to open, right? I mean, if the car breaks down, and you have to know the parameters. So this is a little bit to, hopefully, to help you. Can I ask one more question? How many of you are working or have worked in an intensive care unit? Okay, that's quite a number of colleagues, but there you must have seen the right heart catheterizations, hopefully, right? I very much hope. Very good. So, if you know the steps and if you know the normal values, that's okay. Otherwise, we'll be trying to discuss it together. So, yes, so we have here a patient. This can be a patient who is for an elective procedure, so an outpatient comes in because after PE, for example, you found out in the echo that the pulmonary pressures appear to be high, right? Or it may be a patient in the intensive care unit who needs some assessment of the hemodynamic status. So this is a so-called Swan-Ganz catheter. Have you seen this thing before in your lives? Yes, you've seen it. Very good. So this thing, as you know, is a multi-lumen catheter. So there has been a Nobel Prize in medicine for this thing because it's a beautiful way to assess the pulmonary hemodynamics without going, into the left cavities of the heart. So there is a distal lumen where you can inject saline and it comes out here. There is a proximal. This is the yellow lumen. Oops. So this is the yellow lumen. Here I suppose it is, yeah, it's that one. That is the distal lumen. So you inject here and it comes out here. As with every catheter, of course, you have first to remove all the air from the catheter, right? Never forget this. It's not a good thing if you inject air. So, and this is the blue lumen, which actually ends up a few centimeters before the distal, so it's here, before the distal lumen, and the, here. And when the distal lumen is in the pulmonary artery, the proximal lumen is in the right atrium. We will see why this has an importance. And then we have, of course, another lumen in which you do feel air, and this is the lumen for the flotating balloon, so that the catheter is driven by the circulation to get into the pulmonary arteries. And then this is, of course, a third thing. This is the temperature measurement, the transducer, which will let you know what the blood is at the tip of the temperature of the blood is at the tip of the catheter, and we'll see why this is, for those of you who have not done it, why this is a good thing. So, of course, to get into the heart, you can get from a number of veins in the body. So, which vein would you think is the most practical for the doctor? Which is the best vein to get into the heart? Yes, this is true. It's the jugular vein, because this is the best vein. And why is the jugular vein best? Why is it the easiest, the most practical vein for the doctor? I mean, first, of course, you have to get into the jugular vein, and then? Yes, it goes straight to the heart from above. I mean, you have to remember, and this is a catheter. This has a so-called C shape, right? It looks like a letter C. That's the C, here, like this. And so when the catheter is inserted, and does our balloon work? So this one, we do not have, of course, a balloon. So this is the way to fill the balloon. So our balloon is a little bit broken here. But when the catheter is inserted, then the catheter goes, you will see it now here. I think we will have to turn off the lights, and in the worst case, I mean, the cameras will not be able to see, because you always have to look at the fluorescent, right, the fluoroscopy. And you will see that the catheter enters from the superior vena cava, the right atrium, and then because it has all this turn, it goes immediately up from the right ventricle into the pulmonary circulation. So let's try this. I will do it first, and then the colleagues will do it. And then you will show them what they measure. Yes, so I will do this first. So let's accept that we have gone into the internal, right, jugular vein. Yes. So we insert the catheter, and we have marks here to show how many centimeters. So we have 10 centimeters, 20 centimeters, depending, one mark 10 centimeters, two marks 20, up to 30 and 40 centimeters. So, and of course, when we are in the body, then we inflate the balloon. I think that's quite logical, right? You do not inflate before you enter the sheath. So, okay, so now we have inflated the balloon, and we have the stop here. Oh, okay. So, and now is the question, now we can see also the, so we now inflate the balloon. So, what are the ways now to know where we are? Of course, you say, best thing is fluoroscopy, right? See the fluoroscopy? I mean, don't press on that pedal all the time when you're in the cath lab, right? This is all radiation for the patient, even if it is not much. But, so, you see it? Where is it? Oh, here it is. Is it here? One second. Oh, okay. So you see our catheter has been, yeah, that's not the right way to insert it, so let's try it once more. The catheter should be inserted, you know, with the tip first. Now here it is. That's better, right? Now you see the catheter. Is that okay? And you see the balloon. So this balloon is normally should be filled with CO2. So in practice, I mean, it's a very small balloon. You can also fill it with air. But of course, first you have to check that the balloon is intact. So what we do is we have here a bowl with water, and we inflate the balloon outside, and we put it into the bowl and make sure we have no bubbles, right? So otherwise, it should not burst in the body. So that's fine. So where are we here? What is this? Which vessel is that? Superior vena cava, right? So this is the right atrium. And of course, you know, I mean, if you do like this, right? If you are in the body and you do like this, then your catheter can go down, you know, immediately. So the direct line is going down to the inferior vena cava, right? So you have to make sure that your catheter, and you check this, you give the catheter a turn, and you have to make sure that your catheter will turn, because this is exactly the plane of the tricuspid valve, here, right, behind the sternum. Okay. So, this one, do we have the pressures? It's below, right? So this one is now the right atrial pressure. What is the normal right atrial pressure? For those who are not in the have not done a heart catheterization, you know that. 0 to 5 millimeters mercury, right? That's the normal pressure. A high right atrial pressure indicates what? Yes, congestion, so right heart failure. It could be right heart failure and thus congestion of the right atrium, or it could be, of course, a damage to the tricuspid valve and massive tricuspid regurgitation. So now we're doing fluoroscopy again, and you can see that what happens. So what do we measure now? That's the right ventricular pressure, right? And we have a systolic pressure wave, always measure in parallel, right, with the EKG or ECG, so that you know, I mean, this is very clear that it's a systolic wave, but so you have about 25, right, 23 systolic, and you can see it there, 23 systolic. The minimum pressure, the diastolic pressure is 0, so that is here the mean pressure. Is that a normal pressure in the right ventricle? Yes. Can you say that the right ventricle, what else do you need to know that the right ventricle is normal? The hemodynamics in the right ventricle are normal. Which other pressure do you need, which the device does not tell you, but you can read it from the curve? Can we make the curve faster? Can we go up to 50? That's 25, right? That's a 25?
30.
That's 30. Let's go to 50.
Yep. 50 is this.
Okay. Do we have an even faster one?
10,
You have 100?
10 and 100.
Let's go to 100. Okay. What other value do we need to say that this right ventricle is normal? Which other pressure is important? The end diastolic pressure. So the end diastolic pressure, right, is at the end, is exactly at the time when the right atrium, when the tricuspid here, right? So it's the value before. So this we have had all the filling of the ventricle from the atrium, and if this pressure is high, Dr. Dalton is here, you can correct me if I'm not wrong. If the end diastolic pressure, which normally it should clearly be below 5 millimeters mercury, so here it is 1 or 2, that's normal. If it was high, if it were high, that would mean that although the tricuspid valve was open, the atrium could not empty itself into the ventricle, right, and would still stay congested. That would mean that the ventricle has a problem. So the information that you have here is first that you have a systolic pressure, and this is the systolic pressure, not the one you measure on echo. You know, on echo you estimate pressures. You do not measure pressures in echo, right? Echo is an estimate. The hands-on echo will be here today in this room. So it is in the other room right now. So you have the systolic pressure, which is normal, and you have for the ventricle the end diastolic pressure, which 2 to 3 millimeters mercury. It is below 5, so these are normal hemodynamics. Now, okay, so I decide to go further up. So now I get this curve. Can go a little down with the scale? Yes, thank you. So what is this? Pulmonary artery. So in the pulmonary artery, so this is a pulse wave. This is exactly the pulse wave that you get also for arterial pressure. Of course, not the same pressures, but the form of the pulse wave is the same. So here, what you can see, we do not have a laser pointer, but here what you can see is, of course, the systolic pressure, 27. That's what the device tells you, right? You have the diastolic pressure, and here, of course, you have no... Thank you very much. Thank you. Perfect. So here you do not have an end diastolic pressure, right? The end diastolic pressure is important only for the ventricle, right? It's only for the ventricular pressure, but you have the device calculates the mean pressure. So, which is the normal mean pressure in the pulmonary artery, and what is the point from where we have pulmonary hypertension? That's it. 20 or 25, question mark.
Yeah, 20 or 25 because it depends on the center and whether we are considering adults with congenital heart disease.
Yes, so... Okay, so let us take the 20 first and go to the 25. So let us take the 20. How do you know? The question is, when we say 20 is normal and more than 20 is not normal, for example, I mean, there must be a reason why we say that, and we do not say 15 or 25. Do you know how this 25 comes, is derived? No, it is statistical. First of all, you start measuring people who are normal, who are supposed to be normal. So the normal persons have a mean value of 15 with a standard deviation of about 2 to 2.5 millimeters mercury. So you can say, okay, when do you regard people as being abnormal? When they are more than 2 standard deviations away from the mean. So in this case, it would be about 20. In the old nomenclature that most of us have used, and which has been used for all drugs for pulmonary hypertension, people said, okay, let's give them 5, no, another 5, and just make sure that we will not, we'll have a buffer. So they came up to 25. So statistically speaking, when you have 1 million of normal people and you get a mean pressure of 15 and 2 SDs goes up to 20, so apart from 20, this is not normal. This is the statistical, the physiological explanation. But of course, for practical reasons, the 25 was used in the past just to make sure that we do not treat too many patients. But as you said, and Dr. Dalto will also go into this, this has begun to change. So, okay, so this is now a normal pressure. You see, I did not do fluoroscopy to do that, because this is the genius of this catheter. So this catheter is not here because it has 3 lumina, right? I mean, that's not a big deal. But it's also here because it has the ability to guide itself with a flotating balloon, so you do not need the fluoroscopy. Of course, it's convenient, but you do not need it. And so here, indeed, if you do the fluoroscopy, you find out you are in the pulmonary artery. And then, of course, if you keep on pushing, then the catheter, because it has a C shape, in most of the cases when you do from the jugular vein, it will go into the right pulmonary artery. That's the shape of the catheter. And then, if you keep pushing, then you get this. So what is this? Now the pressure has fallen. So what did we do? The balloon burst or something? What happened now? This is the wedge pressure. So this is the pressure. So now the catheter is wedged, so it is stuck into the vessel. So it is supposed now to reflect the capillary pressure of the pulmonary vessels. And actually, that's not so important. We don't want to know the capillary pressure of the valve. But which pressure do we want to know? That of the left atrium. So we can, this is an indirect but very elegant way to find out what the pressure in the left atrium is. So this is approximately the pressure in the left atrium, and the pressure in the left atrium, the mean pressure, is approximately similar, the same with the pressure in the right atrium, so about 5 millimeters mercury. In our case, it is about 8, so it's a little bit higher, but this is also a normal wedge pressure. So what was my mistake here? What have I done wrong here? I've been talking to you, let's say, for 5 minutes, so what have I forgotten? So you cannot just leave an inflated balloon in the body, right, and in the pulmonary artery, which is a very fine vessel, and just walk around and speak with people and make jokes, because this thing, it may burst or it may cause hemoptysis. And then, of course, it's like what Stefano said today. It was not the patient died of PE and had hemoptysis, and Dr. Huisman said the year score is high. So this is hemoptysis because you caused injury to the pulmonary vessel. So never do this. You always have to deflate the balloon. So in this case, so this one is the wedge pressure. So, and I'll do another 5 minutes, Michele, then I will give over to you. So, okay, so now we know the wedge pressure, and you see immediately when we deflate the balloon, then of course the catheter again records what the pulmonary artery does. So now we have this catheter, And this catheter is in the pulmonary artery, and we have measured the pressures in the right ventricle. We have measured the pressures in the pulmonary in the right atrium first, right, in the right ventricle, pulmonary artery, and we have measured the wedge pressure. So, okay, are we finished? What else can we do with this thing? Or what else do we need? I mean, we can do whatever we like, but what else do we need? Yes, so what is resistance? Physically or technically, hydrodynamically or electrically, what is resistance? So you're young people, you've been to school, hopefully, right? And quite recently. So how is the resistance defined? Let's say electricity, what's resistance? So let's say in hemodynamics, so resistance is the ratio, right, of pressure by flow, right? So, you know, it's this V by I ratio. So in electricity, it is the tension of the, so 220 volts and by the number of amperes, for example, and you get a resistance. In hydrodynamics, it is the pressure by flow, and the flow is the cardiac output. And what is the tension? It is the pressure that is consumed in pushing the blood from the pulmonary artery into the left atrium. How do we know how much pressure is consumed? What do we have to deduct? So how do we get this? Yeah, before we go to cardiac output. So the cardiac output will be the flow. So we will have to measure the cardiac output. Before we measure the cardiac output, so we want to have the pressure above, right, in that fraction. And below we will have the cardiac output. So now we have measured all pressures. Which of all these pressures will we have up in the numerator? Which of them? Shall we say 26, 27, 12, 17? It's the pressure that is consumed. So it's the mean arterial pressure, pulmonary arterial pressure, right? So 17 minus the mean wedge pressure. So this is why you need the wedge pressure, because the wedge pressure is before, the mean pulmonary arterial pressure, the wedge pressure is after, and the mean pulmonary arterial pressure is before. So you deduce 17, let's say we had a 7 mean pressures, right? 7 mean wedge pressure, 17 minus 7, we have 10. So this is the pressure that we will use in the numerator. And now we need the denominator, we need the cardiac output, and this is what we do. And has any one of you heard, I mean, those of you, of course, who have done it, know it. Do you know what thermodilution is? This is also something. So I told you that here the catheter can measure, it can be connected to a transducer. It can measure for you the temperature at the tip of the catheter. So what does this mean? You can have a thermometer, put it in here or in the mouth and measure the temperature. Why do you need the temperature of the blood? So this is what is cool. So now let's measure thermodilution. So we have a syringe, which is, one second, yeah, exactly. So we have a syringe, and this is a syringe that will, with a lot of, that will inject into the proximal lumen, which now, when we are here, is in the right atrium, a quantity of 10 milliliters of cold water. I mean, the modern systems can do it with water of room temperature, but let's say we need, Michele, right, 5 degrees Celsius cold water. So we will inject this, and then our catheter here will measure the drop in the temperature from the cold water coming from the right atrium. And by the curve of this, so by integrating the area of this curve in the drop of the temperature, our device here, our catheter, will measure the cardiac output. So look at this. So now we have it. We have 10 milliliters exactly, because if we have less, we may underestimate the cardiac output, and otherwise we may overestimate. So we have 10 milliliters of cold not water, but normal saline. And so this was the change in temperature. It should be below, of course, because the temperature was colder, but the system inverted. And now we have here in this patient, we estimate a cardiac output of 15 liters per minute and a cardiac index of 7. So what I did here, this may be too high, you have to have exactly the 10 milliliters for which the catheter is calibrated. If you have less, because I think I misspoke, I must have put it correctly, if you inject less volume than the 10 milliliters, but the catheter thinks you have 10, because the catheter has been set to read 10 milliliters, then your wave is of much shorter duration, and in that case, the catheter understands that you have such a high cardiac output that you had an immediate spike, and then it went back to normal. So it will have a very high cardiac output. If you have more, then it will be more protracted, and you will have a lower cardiac output measurement. So but you must have exactly 10 liters. Shall we do it?
Yeah, I click and you do it.
Yes, okay.
Now.
You see, that was now with exactly 10 milliliters. The previous one was with 8.5. Now we have 10 liters per minute, which is of course quite a good cardiac output. That must be a very healthy person, and a cardiac index of 5. What is our normal cardiac output? You know that? How much cardiac output do we have? How many liters per minute blood? 4 to 6. What's the best that we can achieve? 10, 11. You know the cyclist, there was a cyclist in Germany, Jan Ulrich, who was measured at 39. And he was taking drugs, but nevertheless. But anyway, I mean, 39 is extreme. But when you are, someone who is normal like you is exercising, you can get up to 15, right? Without a problem. 39 is too much, right? Okay, so I think these are the principles. So now you put this 10. So what did we say? We said that we had 10 pressure, right? That was the difference that we had, the pressure that was consumed. You have to make a lot of measurements because you saw there is some variation. You have to do 3 to 5 measurements to make sure you will get the average. And now you will say, I have here 10 by 10 means 1. This is 1 Wood unit. Or if you multiply by 80, this is the dims times seconds times centimeters to the -5th. This is the other unit, but now everybody uses the Wood units, right? So it's 10 by 10, it is 1, and this is a person who has normal resistance. So that is a normal person. Michele, would you like to also say a few words? Any questions on this? So it's these parameters we measure, right? We measure, we go through, we can do it with fluoroscopy, but we can just push through because the catheter finds itself. It's not always so simple. If you have a huge right ventricle, you may need some fluoroscopy, but usually it does it. And it's more difficult when we go through the groin because there we have to make a couple of turns, but it works. The catheter has an S shape and not a C shape. And then actually what you do is you measure the pressures, the mean pulmonary artery pressure, the pulmonary capillary pressure, and the cardiac output are the ones that help you estimate the resistance and tell you if the pulmonary hypertension, if there is one, if it is pre-capillary or post-capillary. And then, of course, you also need the right atrial pressure to tell you if there is congestion and the patient has a failing right ventricle.
Okay.
So, now to
thank you, Stavros. My name is Michele D'Alto. I'm a cardiologist from Italy, from Naples. I'm sorry, but I set my presentation 35 minutes. I will run because Stavros covered many of the topics. This is the place where I came from. That is Magna Grecia, it's big Greece. You know, this is from my daughter's book. And this is Neapolis from Crete. This is my city. It's about, it's Neapolis, you know, it's a new city. It's built by Greek.
When you give talks in Turkey, I think I would not do it like this because they would be very angry to have...
Yeah, I'm sorry. So we have the same route. the same cultural root. So thank you so much for inviting me here. That's a nest of European culture. So the aim of my presentation is giving practical issues, because I understand that this course have educational purposes, and many of this has been already covered by Stavros. Just to say you that in terms of approaches, you can use any systemic vein, big vein. At the beginning, we used the femoral vein. There are pros and cons for each approach. We can also use some veins from the arm. That is quite comfortable for the patient. The patient sometimes prefer this one. My favorite is jugular vein approach. This is what usually happened a few years ago. My approach was usually an anatomical approach. You put your finger on carotid artery, and your puncture should be lateral to the carotid artery in the direction of the right breast of the patient. This is a quite good approach if you have a good neck. If you not, you need absolutely echo guide. And we moved to echo guided approach in the last 4 to 5 years. This is a 18-gauge needle that we use for this in this patient. Let me just show what to do in this case. You list here is the head of the patient.
Your needle shows towards the middle of the clavicular, right? So
Yeah.
it shows laterally, so you don't push the needle.
This is an anterior approach. Okay? This is in this position, but some people prefer the puncture here. But you know, you can have this neck. That is very good neck. This man is. I see this is a Modigliani neck. You know, he's an Italian artist. You can have also this one. This is a little bit not so easy to approach, but you can do this. This is a sort of Botero-like neck. It's very difficult to approach this patient. This is the reason why the American Society of Anesthesiologists told us many years ago to use echo-guided approach, because you know the vast majority of people, as the jugular and the carotid artery in this fashion, consider this is medial, this is lateral. So the jugular vein is lateral and anterior. But a certain proportion of patients have in this position. So if this is your finger and you use anatomical approach, it's very difficult to approach the vein, because you put your finger to have the pulsation of a carotid artery, and you do your puncture here, and you miss your vein. If you do here, that is lateral, you don't take the vein. In this case, it is 5% of people, the jugular vein is medial. So this is impossible to reach without having an echo approach, because if you put your finger here, your puncture will be lateral. So you will never do this approach. And this is what happened this is a very big jugular vein, but is in this fashion, so it's very easy to approach by echo. This is my finger pushing on the neck, okay? This is the needle of the lidocaine, xylocaine, just to inject here, and this is the puncture of the vein. This is very easy if you use echo. If you don't, you risk to miss this enormous, huge, big vein on this patient. I will skip this slide. I'm very happy there are many people here, because at the beginning I got depressed because there were 12 people here in this workshop, and 100 in the echo workshop. So I'm so happy. Maybe because there were Stavros here. So this is what has been shown. Just to say you that in this patient at a very low cardiac output and very low cardiac index as well, it's very important also to calculate the stroke volume index. Of course, in this case, you don't need much more parameter. This is a very severe condition of a patient. But let's give a look. The same cardiac output, the same cardiac index have different meaning according to the heart rate. I mean, if you have 5 liters of cardiac output with 100 beats a minute, is different of having 50. So the stroke volume index is an important parameter. Stavros.
One comment here on the curve itself. So you have these 3 curves that were measured, and you got a cardiac output of 3.5 and a cardiac index of 2.5. So this is a patient who does not have a good cardiac output, right? So you see what happens. So this is because you injected the cold, right, the cold fluid, the cold saline, And when the cardiac output is not good, is low, so what happens is that the temperature, so actually this would go down. This is the catheter, the system, the computer inverts it, but it should go down. So it goes slowly upward, and then it comes slowly, because the blood flows, let's say, more slowly. There's less blood flowing in, so the temperature falls slowly, and then it takes some time for the temperature to come back. If you had a very big cardiac output, right, you would have a wave like this, right? And this is why, and so you do not just see the numbers. Always when you are working in interventional cardiology or in the cardiology where you also want to see the raw data, right? Do not just see what the computer gives you, just look at the curves, because if here they said 10.5, that would be ridiculous. I mean, this cannot yield a 10.5, right? So just to learn to work on with the raw data.
Thank you for your point on that. This is a very important issue. Another method to measure cardiac output is this VIII method. I don't want to go in detail, but actually this formula shows that arteriovenous oxygen difference is inversely proportional to the cardiac output. What does it mean? That if you want to measure or estimate the pulmonary flow, you have to, in this, the difference of arteriovenous, you have to do pulmonary vein oxygen, that is more or less the saturation is 97, 98, but is by about 100, minus the pulmonary artery. This is very important. That's the reason why, if the pulmonary artery saturation is very low, the cardiac index is very low as well. You can also use the VIII method just to estimate QPQS. In this case, if you consider that aortic and pulmonary vessel saturation are similar, are about 100, from 95 to 100, the difference is from right atrium and pulmonary artery saturation as well. So what do you need when you perform right heart catheterization? You need a lot of measurement. It's not just to push a probe and just to take some numbers. You need some features for diagnosis, because you need pulmonary pressure. The mean value should be below or above a certain threshold. It is 20, probably with next guidelines. You need pulmonary wedge pressure. You need cardiac output, and if you have these three parameters, you can calculate resistances, because these three parameters are measured. This is a derived parameters. You also need some features for the prognosis, because you know the pressure by itself doesn't impact the prognosis, because the pressure is flow dependent. If the patient got worse and reduced the cardiac output, you can have paradoxically a reduction of the pressure, but the prognosis is very, very poor. So in terms of prognosis, it's very important the right atrial pressure. Consider the right atrium like a black box, like the glycate hemoglobin for diabetes. So the black box of pulmonary hypertension is the right atrium, and right atrial pressure represent the importance of the pulmonary hypertension. You need the cardiac output, you need the resistance, and you need the heart rate just to calculate the stroke volume index. You also have to exclude congenital heart disease. This is the reason why you have to capture the blood samples from at least the two inferior and superior vena cava and the pulmonary artery and systemic artery. You need ventricular pressure, because if you estimate from the TR jet by echo an high value, so you are convinced that a person has 70 millimeters of mercury of systolic pressure, the person should also have pulmonary stenosis, and that's the pressure represent the difference between the two chambers, the ventricle and the right atrium, but do not represent the pulmonary pressure. So that's the reason why you have to image a take of the pulmonary valve and measure right ventricular pressure and pulmonary pressure. Okay, this is very important to exclude pulmonary stenosis. Stavros, you want to comment?
A brief question for the workshop. So everybody knows here what the arterial oxygen saturation is, right? The normal, let's say 99%. What is the normal saturation of the blood in the right atrium or right ventricle? How much? 60? 70? Yeah, about 75%, right? 75 to 78%. If it is very low, what does this mean? So if it is 50%, where do you find, in which situation do you find such a low thing? No, not in sepsis if it's low. If it's low, it's cardiogenic shock. You have a lot of oxygen extraction because the cardiac output was very low. If it is high, then you have a lot of shunting. So if a patient is oxygenated and you have shunting in the periphery, you may have a septic patient who is hypoxic, and then you measure right atrial saturations of 80%, 85. So that's the shunt. The cardiogenic shock, is that correct, is the typical situation in which you have very low pressures.
I cancel just for time, just to show you that this is what's happening in terms of QPQS in normal heart. Consider that should be 97, 96, and so on. This is what happens if you... Yes, if you have something like this, and you have a big difference between pulmonary artery, in this case is 90, and right atrium. Right atrium is with an asterisk because you have to do 2 times superior vena cava, 1 time inferior vena cava, and divided by 3. Anyways, this difference expresses the presence of a shunt. Okay, so the oximetric run at first time that you perform right heart catheterization is very, very important to do. You can avoid later. I will jump for vasoreactivity test just to say you that is very important. Okay, let me. That is very important to perform in idiopathic patient. You know the criteria. A patient is positive if you have a drop of at least 10 millimeters of mercury. The mean pulmonary pressure is below 40, and the cardiac index, cardiac output remain equal or increase. This is very important because the happy patient and the lucky patient that are vasoreactive are a small proportion of patients, not more than 10%, that if are long responder treated with high dose calcium channel blocker, have a very nice prognosis. But I would like to just summarize what are the possible tips and tricks, what to avoid when you do right heart catheterization. The caveat is a Latin word, is cave canem, is beware or dog. So the caveat, what you have to beware. So what is the ideal zero level of the transducer? This is the number 1 is thorax upper surface. Number 2, 5 centimeters below the sternal angle. Number 3 is mid-thoracic level. Number 4, level of the table. Number 5, I don't know, this is nurse's task. This is what you are. Please, 0. Yes. Would you quickly vote for this? Never mind, because in the World Congress some years ago, in 2013, they did the same question, and we were 1,000 people, maybe more than 1,000. Each person zeroed the system in a different point. So the task force became very upset because the working group recommends setting a 0 and mid-thoracic level because this is the indifference point. This is very, very important. I will show you why. Consider that 1 millimeter of mercury is about 13 millimeters of water. So of course is is much heavier. So if this is the 0 ideal line, if you do the 0 on the table of hemodynamic, just to simplify, for example, 13 centimeters below, you increase each value of 10 millimeters of mercury. I mean, if a patient have 11 of wedge pressure, your measure will be 11 plus 10, 22, 21. So this is a different patient, different strategy. And the same, if you zero the system on the upper thoracic level, you reduce every number of 10 millimeters of mercury. This is very, very important. So when you start doing right heart catheterization, please perform the zeroing level at the correct point, that is mid-thoracic level. This is a courtesy from Gabor Kovac that many of you know. So this is the 0 level of the... And he moves the catheter in this bottle of water. As you can see, the number is 0 because the level of the 0 is the same level of the uppermost level of the water. So if we move the catheter, no change. It's always 0. Let's give a look what happened if you move the 0 level. So this is a mistake that you don't have to do. It's very important. He will appear here, Gabor. Just 3 to 1. That's Gabor Kovac here, my friend. If you reduce, this is what's happened, this number will increase. Okay, so each measurement will be falsely increased. So a wedge pressure of 7 will become a wedge pressure of 17. So different patient, different level. Of course, if you go up with the 0 level, this will be under 0, it will be negative. So this is a very important demonstration. So be very, very careful. This is most common mistake because, you know, people are very, very nice, are doing angioplasty, and sometimes, I mean, my cardiology colleagues, but are not able to perform correctly right arterization. So remember, please, that the value that you are measuring do not represent the absolute pressure, but the difference between the pressure at the chosen 0 level, that is mid-thoracic level, and the pressure into the chamber vessel, regardless of the position of the catheter. Because as Stavros showed you before, if you put the catheter in wedge pressure and you deflate the balloon, you measure the same pressure that you achieve in the pulmonary trunk. That's the same, absolutely, because it doesn't matter if it's in the proximal artery or in the distal artery. Just in that case, it's very, very important if you are inflating or not the balloon. Okay, and this is the possible mistake that you can do. I'm sorry, I'm not so good at drawing. I did this by myself. This is the ideal position. You know, the pressure transducer is here, and every flow from the back is completely abolished. And so this is the ideal curve. And let me show you what are the possible mistakes with an overwedge. In this case, you have not inflated completely the balloon, and this is something that is intermediate between pulmonary pressure and wedge pressure, because there are some flow coming from the back. Okay. Other possible mistakes are this one. If you inflate too much the balloon, transducer measure the pressure into the balloon, but you don't need the pressure into the balloon. You need the pressure that is here. Okay, that is left atrium and left ventricle. If you push too much the balloon, you measure the pressure on the vessel wall. And as you can see, these pressure are not reliable. Why? Because the pressure, the wedge pressure, should be at least equal or usually lower than diastolic pressure. So should be down respect to this point. Okay, this is very important. Sometimes it's very difficult. For example, is this a false wedge pressure? Okay, is a false wedge pressure? Maybe because maybe the balloon is not so completely inflated, but what you can do in this case is take some blood samples. This is a real wedge pressure, and this wave that are a V wave are due to the moderate mitral valve insufficiency of this patient. So be careful, because there are some caveats. The wedge pressure should be equal or lower than diastolic pressure. The pressure tracing should have some waves, A wave, V wave, and so on. Respiratory swings should be visible because the catheter is blocked if the patient has some respiration and there's a swing. The catheter position must be stationary. You can aspirate blood, and saturation of the blood, if possible, should be high. This ensures that you don't have non-oxygenated blood, but you are in the correct position. I don't know if we have much time, just I don't think so. I just wanted to show you what's happened in some cases. This is a patient, you know, this is like you must do right heart catheterization, but right heart catheterization sometimes doesn't give you the complete answer. This is a patient, it's a very borderline patient that has pulmonary hypertension, whatever is the threshold that you use. The wedge pressure is 15, resistances are 3.1. So by definition, this should be a precapillary patient, but probably we need more because the guidelines suggest that the interpretation, in particular when the data are controversial or borderline, should be done in the context of clinical picture and echo. So if you consider that this patient is quite old patient with hypertension, diabetes, coronary artery disease, a left phenotype I consider when the left sides of the heart is larger as normal than right heart. So in this case, what we do is performing fluid challenge tests. This is just to demonstrate what is fluid challenge test. And a technique to identify the hidden post-capillary pulmonary hypertension, that mimicking is post-capillary, mimicking pre-capillary. Consider this man that I completely disagree with him. Anyway, these are Italian people. I'm sorry, you probably do not know these people. If you put some water, this is Mr. Berlusconi, this is Mr. Renzi, these are people mimicking Donald Trump. I don't know why, because there's no merit for mimicking Donald Trump, but fluid challenge is important to discover this condition. So in terms of, this is just to explain what is, if a patient has pulmonary arterial hypertension, the patient has a problem in the arteriole, it's very small arteries. If you have a FPF of something in the left ventricle, you have a problem here in the left ventricle or in the mitral valve and so on. So if you give water to these two different patients, what's happened? Having a barrage here, the PH patient have just a little increase of wedge pressure, but the other, and have an increase of mean pulmonary pressure, right atrial pressure, and so on. The FPF patient have an increase in the left ventricular arterial diastolic pressure that is backward transmitted. In other terms, what's happened is that this patient with the left heart problem has a large increase of the wedge pressure. This patient is protected in terms of wedge pressure, it's a very small increase. And this is what's happened in our patient that rise from 15 to 26. And this is what we published a couple of years ago, so some years ago. Patient that have been considered patient with pre-capillary pulmonary hypertension or normal should have an increase, an abnormal increase. So these are patients in optimal medical treatment for FPF, for example, or with the mild forms that are treated with diuretics, ACE inhibitors, and so on, and have a normal wedge pressure. So should be considered patient with the PAH or normal, but they are FPF patient. And if you give a look to this patient, I'm closing, this patient with hidden post-capillary that increased the wedge pressure more than 18, are similar to post-capillary because are older compared to a PAH patient, have much more comorbidities. So as mimicking patients are very, very similar to post-capillary, but are on optimal medical treatment. So just to conclude, the definition of group 2 is very important. Echo imaging, right heart cath, clinical setting, fluid challenge, ECG, just to tell you that you have to do a perfect right heart catheterization, but please do not rely only on right heart catheterization. Right heart cath is a part of an algorithm. The first step is the clinic of the patient. The clinical setting is the patient young or old, have hypertension, diabetes, and so on. Of course, the cornerstone in the baseline right heart catheterization. You cannot ignore echo. This is a left phenotype because the left sides of the heart is larger than right. So this is normal condition of FPF patient. And finally, you can consider fluid challenge test. I'm sorry because I've been a little bit longer. Thank you so much again for your attention.
So really a very kind recommendation. Tomorrow, as we said, we will have, because it's important for you also to touch this thing. I mean, don't worry, it's not sterile, so you can, tomorrow we will have the true hands-on. So Mrs. Werner, who is the head, the CEO of the company, will also be here. So between, I think we start at 3:30 normally, so before 3 o'clock, let's say 2:45, we will have this hands-on, so that we will not be doing lectures, but so please have it in your hands and push it forward and see what you can measure. Again, I believe it is important. I mean, not everyone needs to become an expert like Dr. Dalto. You don't have to be an echo expert, a catheter expert. But when you investigate such things and you write papers about things, it's good to know what you're talking about. Otherwise, we're just writing. And so I think it's, I hope this is helpful. So we will have, again, we will have one more, because that's the most difficult hands-on, right? We will have one more hands-on tomorrow, an extra, let's say, hands-on tomorrow in the early afternoon. And Michele, you will also be here, and I'll also be happy. And we can also then tell.
It'll be a pleasure.
So thank you, and now we're changing. We're a little bit behind time, but that's not bad. And now you will stay here, of course. You don't have to do anything. But we will. Now we will have, perhaps just very briefly, we will have, so first we had our hands on. Now we have 2 methodological workshops. So Catherine, Dr. Catherine Nurse, will be discussing with you some career development opportunities, if I can say it like this. She's responsible at our institution at the CTH for our cardio program. You saw many of the colleagues today who are in this multi-university PhD program, so I think she is the most competent person to give you some information and advice. And we will go over for the workshop number 4, which is on clinical trial, not how to perform the trial, but what the clinical trial unit does for you. And of course, we will change tomorrow. So
Yeah.
we'll leave you here.
Yes, I just have some. Yeah, hello everybody. Thanks for joining the workshop on early career opportunities. I just would like to briefly introduce myself because I'm probably one of the few people here at this conference who don't really work in the field of thrombosis and hemostasis as such. My name is Catherine Nurse, and as Herr Konstantinides already said, I'm the scientific coordinator at the CTH. My scientific background is in the field of neurodevelopmental biology. I have worked in the industry in the field of intellectual property and also in the field of vocational training. And yeah, I have joined the CTH as scientific coordinator last year. So what this workshop will not be about is about different positions you might envisage for your future, because I think everybody knows what kind of positions there is, but it will be more about what is important for a successful research career and how to build and shape your career. So the 5 topics I will be talking about is networking, funding, how to set goals for your career, how to stay updated, and how to become recognized within your field, which of course is really important to have a successful career. So because we are at a conference and conferences are always a good place to network, I will start with networking. And what I think is always important for successful networking is self-marketing, because without presenting yourself, you can't make any connections, you can't network. So this is something you always have to keep in mind if you want to reach out to people, that you're actually presenting yourself, and that it's really important to present yourself in a good way. So, however, we know that networking is not everyone's cup of tea. So you probably ask yourself, well, why should I go out there and talk to people if I don't like that? And yeah, because we're in a workshop, I'm just asking you guys, why should we network? What is your idea?
You're looking for potential
Yeah, exactly, yeah. Sorry, I didn't catch that. Yes, yeah. Yes, yeah, exactly, yeah. Somebody else would like to? Yeah, as the two people already said, it's important to set up new collaborations and also to maybe find a new job because, yeah, you always move on in your career and it's an easy way to find your future employer at a conference. And also maybe there might be somebody at a conference that has materials that you are interested in, or you just simply would like to have advice from somebody from the outside. So where do we network and how? As you all know, going to a conference is one of the ways how to network. And obviously conferences that are important to your field. And also, if you're not too sure which conference to go to, because, I mean, there's so many and sometimes they're just so big, just ask your supervisors or senior people within your field whether they recommend a conference. And sometimes it's the small conferences that are really good to network because you have more opportunities to meet people and speak to people. So just don't go to conference to go to a conference, but think about which conference might be good for you and for your career. And then very important, you should prepare before you go to a conference. That takes maybe 5 minutes. Just go through the list of speakers and see who's actually going there and who you are interested to talk to. And because this is a great opportunity, so don't miss out on that. And then have your business card ready. I know that many people, especially in their early stages of their career, don't have a business card. But I just mean it the way that maybe at the end of the conversation, just finish up with saying, well, can I contact you again? I'm sure I can find your email address on your homepage. And just to make sure you keep this connection and follow up on this connection. And and then once you're at home, just drop a simple message like, it was nice meeting you, thanks a lot for your advice, and make sure this connection stays, and so you can build up on that again for future questions you may have or for future materials you may need. And then really important, think about your self-marketing strategy, how you approach people. But before we come to that, I just would like to talk about popular misconceptions about networking, and probably one reason why some people think networking is something they don't like. So first of all, it's actually not the number of people that matter, that you know, but the quality of people. I mean, it's pretty obvious, but sometimes people forget about that. And if, let's say, you only know 3 people, but they're really good in their field, but they might not know the answer to your question, I'm sure one of these 3 people might know another person. So just see it like this: by knowing these 3 people, you know actually a lot of people. And this is much more important than going out there and talking to everybody, and so just keep that in mind. And then, of course, which is pretty obvious as well, it's not the highest ranking people that always are the best people to connect to, but it's really important to ask yourself about the talent, about the quality of the person. Maybe, the highest ranking person is actually not the person that might help you at this point of your career. And then the biggest misconception about networking is probably that you need to be sociable, which is actually not true at all. You just, before you go out there and talk to people, you just have to think about the questions you want to ask and which information you want to share. And especially if you approach people that do like talking a lot, just ask them one question and they won't stop talking to you. So it's pretty simple, you know? Just ask 1, 2 interesting questions, I mean, that are what you actually want to know, and the other person most probably won't stop talking. So let them do the talking for you. And then some people say if you at conferences or try to network, you shouldn't talk about personal things. That is not true either. Because, I mean, first of all, it's natural, and secondly, it's as soon as you notice that you have something in common with another person, there is a connection straight away. And maybe you can put a picture to that person as well, because people do think in pictures, and it makes it easier to keep these connections then. So, yeah, don't be shy and just, yeah, share some information about yourself. It doesn't have to be your life history, but yeah. And yeah, so how do I self-market myself? I put the word elevator pitch there, but don't worry, we are not going to do an elevator pitch, but I think everybody knows what that is. It's just condensing important information into 1 or 2 sentences. And this is actually what is important if you think about self-marketing. Like, what do you want to share with the other person? And so just think it in the way of an elevator pitch, but in a way of a conversation. Which information would you like to get across? And so now I just would like to invite you to imagine that there is a person at this conference you would like to get to know. Maybe you want to have some advice from them, or some material, or you just want to talk to them. So now just think about, and now I'm actually asking you all have a pen and a paper, just really to think about it and maybe take some notes. Don't worry, I'm not going to ask you what you've written down. I'm just inviting you to make use of this and think, how would you approach this person? What would you say? How would you like to introduce yourself? And then maybe start not telling them, yeah, and I'm working on, but I'm trying to find out, because it sounds much more interesting. You just make sure it sounds interesting so the other person gets curious and might ask some questions. And think about your, what you want to sell. What is your unique selling point? Do you have some really interesting results that you want to share? Have some questions ready. For example, what is your opinion on this research, on this approach, or on my latest research results? And always make sure to keep your body language in mind. Because it's really not only the way you get perceived by the other person, but also how you actually present yourself. Because if you're standing there all crumpled up, you can't really talk in a nice way and you don't seem confident. So just keep that in mind as well. And yeah, now I just would like to invite you to take some notes and think about how you would like to approach this person. And I'll give you 2 to 3 minutes and then we'll just keep on going. yeah, so I hope you were able to find a few sentences to open up a conversation for the next time you trying to approach somebody. Is there anything that you think is particularly difficult, or would you like to comment on anything? Yeah, if not, then I'll just... Oh yeah, I just have one little cartoon about body language again, just to remind you how important it is to, present yourself with your whole body. So, this is my depressed stance. When you're depressed, it makes a lot of difference how you stand. The worst thing you can do is straighten up and hold your head high, because then you'll start to feel better. If you're going to get any joy out of being depressed, you've got to stand like this. So, and I just invite you to observe your body language, in the future, and you'll see that it makes a difference how you stand or, sit in the way you can present yourself and talk to other people. Okay, now I would like to talk about funding. And of course, funding is very important for research and for your career, because it will give you the independence you're probably all looking for eventually. So, especially for the clinician scientists, it is really important to have protected research time, that you have allocated time that you spend in the clinic and allocated time that you actually spend in the lab. And there's many university medical centers that offer clinician scientist programs, and also societies and foundations that offer these sort of grants. For example, the German Society of Cardiology or the German Society of Internal Medicine. Just go out there and have a look where you can find a position that makes sure that you have allocated time for your research, because otherwise it'll be really hard to move on with your research career. Yeah, and then the funding. It's always really important to start locally, especially in your early part of your career, because most institutions have small funds, and they're much easier to apply for example, travel grants or small equipment grants. And so they're much easier to apply for, and it also gives you the opportunity to get experience in grant writing. And once you achieve your first grants, you not only gain the experience, but of course you have them on your CV. And so you can go step by step and then go for bigger grants slowly. Then it's also important to become a co-applicant on research grants. So, and here it's important that you reach out to people, because nobody's coming up to you and will ask you, do you want to be my co-applicant? Just approach your supervisors, senior people in your field, and give them ideas, or ask them, would you like to apply for this grant? Like, just reach out, and once you become a co-applicant, then the next step will be that you can have your own research grants. And again, you will get really valuable experience by writing these grants with senior people. And actually, there is some grants that are specifically asked for one senior and one junior PI, so just have a look for these grants, because, that again gives you advantage to apply with somebody who is really experienced already. And of course, there's different types of funding, so try and apply for all of them, for personal research and equipment funding. Now I'd like to briefly talk about different funding opportunities of the different associations and funding bodies. So here's the European Society of Cardiology, and I'm not going into the details of the grants as such, but if you just go into their webpage and look up research grants and fellowships, then the different grants are listed, and I'm sure you will find the grants that might be interesting for you. The ISTH has sort of travel funds that are for people from developing countries or from high-income countries. And they're basically there to support exchange between research groups so that you can go to another research group and spend some time there. And the European Hematology Association has quite a broad spectrum of funding opportunities. So they do have the junior research grant, the advanced research grants, and the physician-scientist research grants. So here there's something for different stages of your career as well. They also have mobility grants. And as I said before, they actually do have the grant where they want one senior and one junior group leader to apply together for the funding. And here I just have summarized a few sort of databases where you can look up funding opportunities as well. If you work in Germany or if you would like to work in Germany, you can go and find out more about funding opportunities on researchingermany.org. The ELFI database is a huge database that lists a lot of funding, not only in science and research, but you can go and see what they have listed. And then, of course, there's the EU funding, which you can find out on these two web pages. So now I would like to move to the next topic of my talk, which is goals. So, why do we need goals for our career? Because, unfortunately, success does not happen by accident. So we have to think about what we actually want to do to get to this next step or to get to what we want to be in 20 years. So how do we get there? So a start is to just ask yourself a simple question. Where do I want to be in 5, 10, 15, or 20 years? Like, you always have to see your future self to actually get to the next step. If you don't know what you want to be in 5 years, how can you get there? And why is it so important to ask this question? First of all, you basically will define your success, what your future success looks like. If you don't know what you want, why you want to be successful, or what this looks like, you can't achieve it. Then, of course, it helps you to focus. You will see, am I going the way I need to go to get there? Or am I on a detour? Or maybe I am on a detour, but this detour is really important to me. And so you will find out whether you are on the right path. Saying this, it's always really important to have multiple goals. You can't just say, okay, in 5 years I want this, but what do you need to be there in 5 years? In research, you probably need to publish. So have multiple goals. Say, okay, this year I want to publish 1 paper. Next year I want to publish 2 papers. Something like this. And of course, doing this in the long term, it saves energy and resources because you can readjust your goals on the way. If you see, okay, I'm not getting there, maybe I have to take another path. And you won't find out 5 years later when it's too late. And you will gain self-confidence by doing this because you will see that you have succeeded and that you achieve what you wanted to do. And there's also been studies that it actually does make you happier and it prolongs your lifespan if you have goals and plan your career. So, well, I guess everybody wants to live longer, so go ahead and, draw up some goals for your career, I guess. Anyhow, while you're doing this, one really important question is also to ask yourself, do I want that? Do I want that? Do I want to be there in 5 years? And you actually have to ask this question 3 times. So once you have to ask, do I want that? Do I really want that? Do I want to be a junior group leader in 3 years or 5 years? Then the next question is, do I want that? Do I really want that, or am I just doing that because I'm here anyway, or because somebody told me to do so? Just make sure you're actually doing what you want to do, otherwise you won't be successful. And last but not least, you also have to ask yourself, do I want that? Is this actually really what I want to do, or do I need to move? Sometimes just a slight change in your career path might make you much happier. You don't necessarily need to start a new degree, but maybe just go a bit of take a bit of a different path. And then when you think about your goals and try to define them, it's always really important, to follow the SMART rule. I'm sure you all have heard about it. The SMART rule just says how you define something, like, for example, a goal. It has to be specific, measurable, achievable, realistic, and timely. So you can't just say, for your future career planning, I want to work in the field of thrombosis and hemostasis. This is not specific. You need to say, okay, I want to be a junior group leader in 5 years. And make it measurable, not only timely, which is, the T of the SMART anyway, but also what do I need to do to get there? And how else can I measure a junior group? You probably would have your own funding, you probably would have people that you supervise. And really important, always make your goals achievable. And this is also important if you, this is why you also should set multiple goals on the way. To see your success, make little achievable goals on the way. If you say, okay, I want to publish a paper next year, this is really achievable, and then you can say, yes, I achieved that, and that, again, makes you feel better and is good for your self-confidence. And always be realistic in setting your goals, because you might not be the person to lead a junior group. So it's better to realize this now and say, well, it is the normal path, but I'm not the person for that, so it's not a realistic goal for me. If it's a realistic goal for you, that's great, but just keep that in mind. Now, again, I would like to invite you to just take a few minutes, and of course, I know that within 2 or 3 minutes you won't be able to set your goals for the next 20 years, but maybe just start about thinking about what you would like to achieve, and take up on that when you come back home, because we all always have good intentions, but then we never continue. So I'll just give you a few minutes again and invite you to think about your goals for the next year, for the next few years, whichever way you would like to do that. Yeah, okay, and I simply would like to wrap up this part of the talk with the sentence, "A goal without a plan is just a wish." So now I come to the part of my talk on how to stay up to date. There we'll talk a bit about career development and mentoring. But first of all, how do I stay up to date with my research? So we all use search machines and databases like PubMed, and often we just quickly type something in and then we dig for this one paper we want to read. But you also can create alerts and receive weekly updates, and if you don't know how to do these things, just go and have a look in the user guide, and it might take you 10 minutes to set up these alerts, but this is a really easy way to keep updated on, what you are interested in. And also the user guide is really helpful in defining your searches much better, because as I said, often we dig for this one paper, but we can't find it. But if you just take a few minutes and refine your search, it makes it much easier, and for the future you know much better how to refine your searches. Yeah, similar with Web of Science. So Web of Science is really good for to find out the impact factors of the papers and to find out more about authors. And I have picked Bernhard Lemmle here as an example, not only because he's well known in this field, but also because he's one of the authors that has a umlaut in German. And so he publishes under different names, and sometimes it's really hard to find a paper of a person like him in PubMed. So if you then go to Web of Science, they list you all the names he has published under, and also they give you a really nice summary about a brief CV basically about this person. And down here, which is not shown anymore, lists all the papers. So that is really good to find out all the information about just one particular person. And if you would like to stay updated, if it comes to clinical trials, just use the webpage clinicaltrials.gov, which lists ongoing and completed clinical trials, and you can learn more about the terminology. So now I come to the part career development of the part stay up to date. So of course, most institutions and universities offer local training, for example, within PhD or MD or physician scientist programs. So most of them are mandatory and you have to go there, but some of them, or let's put it this way, a lot of the training you get within these programs is part of a curriculum. But there's also part of this training that you can give your input to the people that organize it and say, well, I would like to have a seminar in statistics. Would that be able that you can organize the seminar in statistics for us? And from my own experience, it's really nice to receive this feedback, because sometimes you don't know what people would like to get trained in. And so it's really good to, so go out there and just tell them what you would like to learn about. Then, of course, there's further training that is outside your institution. And just go and have a look what is out there, and keep in mind that usually there's always funding options for that. Your employer always has some sort of funds to send to the employees to further training. So, and here again, nobody will come up to you and tell you to go to the training. You have to be proactive and say, okay, I would like to go to this training. Is there money for me to go there? And usually there's always a way, that the training gets supported. And then, of course, these days there's a lot of online training, and yeah, I'll just refer you to the different societies for that and associations. Just go onto their homepage and see what they do offer. Yeah, that brings me to the part mentoring. So mentoring is really important as well to, yeah, proceed in your career. Why is it important? It's, and saying that, I think all of us do have a mentor and probably don't even know it. You don't have to have an official mentor relationship. But if you go and think about the people that you approach for advice, just if you think about that, you often do realize, well, actually, it is sort of a mentor for me. And so why are they so important? It is really important because you do learn from the experience of others. You don't have to make every single mistake yourself, but you can learn from the mistakes that other people already have made. And it's really important to get the critical feedback of senior people, and especially if it comes to writing papers and writing grants, because the first attempts will be always really difficult. And it is so valuable to get the feedback of senior people on the way. Yeah, you gain advice, encouragement, and support. And it also helps you identifying goals, because you have people that already have gone part of their career, and you can see what they have done and how they have gotten there. Yeah, similar to that, you gain the insight into the career opportunities there is for you. And of course, a mentor most often encourages you and empowers you. And this is of course really important as well. And often this comes that you do have a senior role model then. Now I just would like to briefly talk about the different mentoring models there is, I guess, if you want to call it like this. So of course there's one-on-one mentoring, where you have a senior person that mentors you. You have group mentoring, where one senior people mentors a whole group. And you have peer mentoring. That is often these get-together groups within clinician scientist programs and PhD programs. And they're really important too, because you can talk to your peers about their experience, and they're at the same stage of the career as you. And this is just very valuable exchange as well. And most universities offer mentoring programs. The University Clinic in Mainz, for example, offers a program Momentum, which is for females only. But however, just go and have a look what there is, because often these programs not only come with a mentor you get allocated, but also with workshops. And it's a really good way to gain, for your career. And also what I would like to say is often when you do your PhD or your clinician scientist program, you get asked to put down a name of mentor. Just make use of that as well, because it's really easy to just, put down a name and then never think about it anymore. But you most probably would have asked this person anyway, could you be my mentor for my PhD? So make use of it. This person said yes, and he's probably outside of your institution often. This is what it's asked. So make use of this. This person is outside of your institution, and this person might have a completely different look at your research, at your progress. So, just think about that. Yeah, and this brings me to the last part of my talk, which is recognition. And basically, recognition, how do you get that in the field of research? It's pretty much publications and awards. And, of course, self-marketing, because it's always, yeah, how you present yourself on conferences, etc. But yeah, we have talked about that already. So publications, especially in at the beginning of your research career, it's important to do some advanced training on writing skills. And also to become a co-author. And well, going back to the training skills, these courses are really good, but it's, I have mentioned that before, it's much more important to get your mentor, senior role models, your supervisor to give you critical feedback on your writing, because it is really hard to write your first grant, for example, and just take on this critical feedback. And what is really good as well to achieve recognition through publications is to write reviews, because reviews get cited really often, and so it's a really easy way to become cited if you write a good review within your field. And then, of course, don't be shy and just go to conferences and workshops and present your work and try and reach out to people and discuss your work. And yeah, as I said before, just be open to the feedback you get, because this is the most valuable thing for your career, to take on the feedback of your senior people. Yeah, and then of course awards are really good to gain recognition as well. Again, similar to the funding opportunities, just start locally. Most institutions have little awards, and they're often very simple, like best postdoc paper of the year. Just be aware that you actually have to apply for them. Nobody's going to come and say, oh, your paper was the best of the year. You actually have to apply for them, and it's often really easy. So, and once you have an award, of course, often it comes with a small fund, but also you can put it on your CV. And yeah, the awards are mostly listed, yeah, the institutions often list awards, not only the awards they give, but also, yeah, general awards. Yeah, and with this, I would like to thank you for your attention. And yeah, if you would like to contact me, there's my email address. Thank you. Yep.
Thank you very much for this beautiful overview. I guess that it's very important that your slides are available, because then people can look back. They made notes, I saw, and it can be very helpful, not only for the younger ones, but also for the more senior ones, including me, because what you just mentioned is relevant to all of us. I just want to come back to one of your remarks, and that is peer review and supervising, and especially this spring school is the ideal platform. So please do not be shy, approach us, me, Stavros, other senior members who have done the sending, receiving messages in the straightforward talks while we are getting drinks or having dinner or lunch. Don't be shy, please. And tomorrow is nice weather, so at the pool, you make the best deal. You don't even have to start, can I offer you a drink? No, but you know, like Uncle Sam would say, don't ask what your country can do for you, but the other way around. I hope you understand me, and it can even be at that point when you just ask one question. And you know, I cannot be a supervisor for all of you, but I can just answer a question that you have. And you can ask, you know, what do you think of this guy in that city? And I say, oh no, never take him, or do take him. You know what I mean? So it's without any hurdle here. And that's the beauty, I think, of the spring school. If we attain that at Sunday morning, and you take back at least one answer on one question, you're already there. If you have 3 questions and 3 answers, it's even better. And if you catch a supervisor, come to me and you get a nice bottle. Okay? Thank you.
Microphone's on. Is the microphone on? Great. Are we okay to start? I know we're waiting a little bit because the internet are expecting to join us at 7 o'clock, which is 1 minute from now. So if everyone could take their seats. Can everyone come forward, please? Because we're going to hope for some interaction. So there's plenty of seats down the front, so don't hide at the back. It won't save you. I'm coming down there anyway with my microphone. So I promise you, I always go to the back first. Right, we've got 2 cases today. In the program, it actually says intermediate risk, but I'm going to talk for 40 minutes about that tomorrow with catheter therapies and heparin and all that. So by coincidence, Mathieu and I have both prepared cases that are a little bit more spicy than that. So we don't assume that this is a patient that's ordinary and vanilla. So we're going to hopefully have some more interesting cases for you to discuss. So Mathieu is going to go first from the University Medical Center Ljubljana from Slovenia. So take it away.
Well, first, I would like to thank you to coming so late. I think it's really late to listen, to participate. And I would like to thank organizers, I mean Stavros and Meno, for giving me an opportunity to talk about this disease entity. So, as you see the title, this is the pulmonary embolism patient, and I would like just to remind you that this is an interactive workshop, so you can interrupt me anytime when you want. I'm coming from Ljubljana, and I have no disclosures. First, we should start with this case. It's a man. Not old, probably. And as you see here, nothing special before, but then he has this surgical procedure 1 month ago. He got proper thromboprophylaxis for 14 days, and then this is his history, as you see here. Dyspnea was the most important symptom which drove him to the emergency. And at the emergency, the status was like that. He was, let's say, hypotensive for nearly 50 years old man. Usually they are about they are healthy. Of course, they do not have hypertension because they do not measure their blood pressure, but anyway, about 140, and probably we can expect and increase heart rate. Oxygen saturation without added oxygen was also, and the rate of breathing was increased. So, and all these things here suggest that he has pulmonary embolism. That was working diagnosis at the emergency. Of course, we have to use these scores, but anyway, this was, let's say, obvious, and obvious it is because we are on a workshop on pulmonary embolism too. What to do? I give you 6 options, please. What would you do? Objective diagnosis CTPA, and who is for this? Well, let's say 1/4. Echo and CTPA. Maybe more, yeah. Low molecular weight heparin, 2, 3. Maybe these answers are all correct. Maybe, I do not know. We shall discuss. Thrombolysis, no one thrombolized him. Unfractionated heparin, well, just few. Something else. In medicine, it's always something else.
Yeah. Okay, Mathieu, shall we find out what something else would be? Let's hear.
Something else.
We have to count the BOVA score if it's high. In some words, there is an interventional treatment also.
Okay, so a BOVA score. Have you got a different vote, or?
No, I believe the same.
You're going to go for a BOVA score. Anybody do anything else other than what's on the screen? We've got to vote for another scoring system. Patient's clearly not very well. Stefano, come on. What would you do?
Some diagnostic and some treatment, as the clinical suspicion is high.
Yeah.
So probably a bolus of heparin for 5,000.
So it's interesting that you split immediate treatment from further investigations there. So and in hindsight, I don't vote for any of these because I vote for 2 of them. So, so what would you do?
Well, we did something else. And something else means oxygen, because his saturation was low for, let's say, healthy men. We gave immediately low molecular heparin, as you already pointed out, and afterwards CTPA. I would like just to enforce this our what's now?
Just have to click on the screen. Top button. Perfect.
CTPA was looking like this. You see increased right ventricle and thrombus in central artery, pulmonary artery. Diagnosis was confirmed, saturation was lowered, so they gave him oxygen mask. Blood pressure was lowered. What would you do with this pressure? Would you do something? Sorry?
Monitor closely the patient.
Monitor, yeah, probably, yeah.
Anything else?
Transthoracic echocardiography.
Echo.
Echo,
Yeah,
right.
transthoracic echo.
Okay, we will discuss echo afterwards. Just, I will touch this later. But first, of course, this heparin is important. And it's already in the guidelines that you have to treat even before you have the diagnosis. That's really important because otherwise you lose time. At least in my country, you can wait for CTPA along, and maybe you can get a CTPA, but the result of CTPA, you wait even longer. So risk certification is the next thing you have to do. That's in the guidelines. What is risk certification? If you look at this cartoon from the guidelines, mainly I'm dealing with the guidelines. You have this diagnosis already, anticoagulation, then you have to risk certify, hemodynamic instability, and so on. What would you do? First, I would like just to endorse that you have to risk stratify and hemodynamic instability. I put this slide several times because this is, let's say, funny definition. And of course, our patient is not cardiac arrest, not in the shock, and actually his blood pressure is above 90. So it's not hemodynamically unstable. The pointer is gone. So he's not unstable. Then the next thing comes, risk stratification. As in the guidelines, we have clinical, laboratory, and morphological criteria. And you know this cartoon very well. They include all these criteria. Clinic, hemodynamic instability, we have already discussed that. And then we have clinical presentation, left ventricular dysfunction, and elevated cardiac troponin levels. What would you do for assessing this? I have already shown you some things. Probably you remember he had elevated cardiac troponin, and how to assess left ventricular dysfunction and clinical entity. In the guidelines, we have simplified PESI. I think nobody uses original PESI because it's really complicated, and emergency doctors don't want to be to complications. I think so, but simplified PESI, it's in this case it's a little bit positive. Let's say positive, it's about 1, and then means that clinical parameters of PE severity are positive, and he's in this group, not here, not low, and elevated troponin again, and hemodynamic instability. What about right ventricular dysfunction? What would you do with this? ACT.
ACG of this patient.
No, we have, it's nothing. We have this ECG, I know this new criteria, but it was nothing. No, it was, let's say, normal. It's commonly normal. Not always, but at least in third patient, 1/3 of patients is normal.
Okay. But without any signs of right ventricular stress or acuities?
No, it was normal. ECG was normal.
Coronary ischemia is excluded?
Yeah.
Okay, thank you.
What would you do for right ventricular dysfunction? Somebody at the beginning told echo. I put echo here. It's okay. And last time when we were here, Dutch Meno said that echo is not possible to be done in Holland and probably in some other countries too. And it's an emergency, and in emergency, echo is probably a problem because there are not enough doctors who knows. Even they have a machine, it's very difficult to someone who sees this kind of patient for the first time, or let's say 10th time, to be reliable, and his result is reliable. So echo is helpful, but maybe it's not possible always. But we have this. Sorry. We have this. We have distended right ventricle. So CTPA gives us enough information that we can conclude that this right ventricle is not doing well. So we probably don't need echo if we take into account all problems accompanying echo. I would like just to point for Hestia criteria because they are popular, and I think these are a result of common sense, because if you use just common sense, you come to Hestia criteria, and I really like this point. Medical or social reason for treatment in the hospital. That's really important, at least in my country. I don't know how it's in yours. Well, I would like just to illustrate what does it mean, this immediate, intermediate, high risk. If you look at this study, already old, it means what are the mortality if you look at if you stratify pulmonary emboli patients in let's say 4 classes. P-related death and all kind of death. So it's really important that you know with whom you are dealing with. So what about treatment? What would you suggest? I give you these possibilities. Who is for systemic thrombolysis? No one? Catheter recanalization procedures. Anyone? Only one.
Okay, let's hear why. So the chap on the end here. Why are you going to treat him with catheters?
Well, in my center, we tend to stratify patients with BOVA score, and as far as I remember, it's 5 points, so there's a risk of hemodynamic decrease, and this will also influence outcomes. So in my center, I think that we would rather go for catheter interventional treatment.
Catheter interventions. So, what do you think of that, Matteo?
Nice. Only one. But then you have unfractionated heparin, low molecular heparin, surgery, DOAC, something else. What would you do? Something else? Nobody. DOACs, who is for DOACs? One. Surgery? No one. No surgeons here. Low molecular heparin?
Low molecular heparin. Okay, so
majority.
Let's just get a thought. Low molecular heparin? Why?
Please speak louder.
Yeah, I mean, you can dispute that the patient may deteriorate, but he's only young, and I presume he will get a chance to get better just on heparin.
Yeah.
And will not require any further interventions.
That is what the guidelines say. Start on low molecular heparin, and if they deteriorate, consider rescue therapy. But the ESC guidelines say start on systemic anticoagulation with low molecular heparin, and then, if the patient's deteriorating, then consider rescue reperfusion. That's what the 2019 ESC guidelines say.
If we go on, because we are a little bit late already, first of all, I would like just to point out that in the guidelines you have to hospitalize this patient and to monitor, just as Andrew said. And supportive treatment, we shouldn't wait this. They gave him norepinephrine already, but it was said before it's not needed, probably not needed. And if you look at the guidelines, initiation, that's already explained, and we do not use oral anticoagulants when we expect deterioration, because you can't treat properly. Maybe you can't treat properly with, let's say, thrombolysis, surgical procedure or something like that if you have dogs on board. And routine use of primary thrombolysis is discouraged. So if you look at the guidelines, the low molecular heparin is the right answer. Times go on, and we have this status. After one day monitoring, the status is the same, and the patient is complaining. He's complaining about, let's say, I difficult breathe. My breathness is short. I'm tired if I just get up to go to the toilet, and so on. And is he unstable? Actually, he's not unstable if you look at this definition. Of course not. He has more than 90 millimeters of mercury, but we treated him with thrombolysis. And I would like to discuss with you this. We do not do a catheter because I think it's, let's say, only in experienced centers justified, and it's probably not, we do not have the results of catheter thrombolytic trials yet, the real one. So guidelines, no systemic, but when it's something wrong, you can do. And first of all, when you are thinking about thrombolysis, you have to think about contraindications. And if he has no contraindications, and then you have these possibilities. And if we look at the existing data, you see that intermediate risk pulmonary embolism, intermediate risk pulmonary embolism, the mortality, the deaths, arterial-pericardic escalation, and recurrent P is lower. But, and it's well known, but we have the other side of the coin. We have bleedings, and as you see here, bleedings, and actually we do not know long-term effect. In PITO study, 2 years, echo after 2 years didn't show anything better, not less CTPH. And in PITO also saw 2% of hemorrhagic stroke. So it's a little bit controversial or probably discouraging thrombolysis. But if you look at this cartoon from the guidelines, you see that PITO the tenecteplase was used, and odds ratio for complications are much higher for tenecteplase than for alteplase. So we are using, if we do use alteplase, probably we are using less dangerous drug. And and we of course want to diminish bleedings, and we do not have actually the guidance when the bleeding is increased. This these data are coming from anticoagulation, not from thrombolysis. But it gives you a hint what you have to look for. And the story is long. But this patient, sorry, what's now it's, yeah, the story is not finished. And here you can see the, sorry, the, it's the wrong button always. If you see the statistic for anticoagulant treatment and bleeding, and there is actually no score which would predict higher bleeding risk. And but we have some other studies which are supporting thrombolysis, like this one. And if we look at the possibilities, we can maybe talk about lower dose, because lower dose is maybe less dangerous. And if you look at the data already published, and if you look at the bleedings here with standard dose, lower dose towards standard dose, and the bleeding is smaller. And all other things are nearly the same as if you compare the low dose to heparin, the efficacy is also the same. So lower dose, Konstantinides wrote this in the guidelines. Still we do not have data, but we can think, because patients are not always fitted to the guidelines. And so we treated him with thrombolysis with this low dose. That was 50 milligrams for him, for his 80 kilos. And after thrombolysis, the result was like that. And at that time, we performed echo because we want to know what happened. Maybe this echo is more important than that one at the beginning, because at the beginning we have CTPA for diagnosis. If you look at the guidelines, ASH guidelines, thrombolysis is reasonable to consider for submassive PE when you have something else. I mean, some other disease, or maybe some other conditions like the conditions of these patients. And in European guidelines, you can see that it can be considered when you have deterioration, and you have to have an experience with this kind of treatment. That's all, and I would like to ask you if you have any remarks. Please.
Just 1 second, I'll just give you a microphone.
Yes, I was just wondering why you decided to do thrombolysis in this patient, as he started to feel a bit better. His vital signs were not worse than the day before. It was even also a bit better. So that's one of the things that I was wondering about.
Thank you. Well, that's controversial. If you watch this kind of patients, they are really complaining, and they are young, they are capable, they are physically active, and they are lying in the bed, and they can't go to the toilet because they are so dyspnoic. And maybe this is a condition when we can discuss thrombolysis too. We still do not know all about thrombolysis and its efficacy.
There's another question. Yeah.
Yeah, my question was, when you suspected that he's not improving, did you take into account more tests like repeat echocardiography, what happens in the right ventricle, or some blood tests like lactates, troponin level, natriuretic peptides? I'm just thinking that a day and a half is very short to decide that patient needs thrombolysis. Sometimes they improve after a couple more days.
Well, thank you. You're right. Actually, if you are talking about troponin has, let's say, longer half-life, and probably it won't be very good indicator. But this patient probably has blood pressure about 140, let's say, and when we are looking at him, he had 110, and maybe this is something marginal. I do not think that BMP is important for this early risk stratification and decision what to use for treatment. But troponin could be, but it has longer half-life. Echo, yeah, echo is good thing, and we did echo, but I have no time to explain. Please.
I wanted to ask a question and comment on the topic. I support the decision about thrombolysis, and there is a discussion going on. If patient is deteriorating, we know what to do, but if the patient is not improving, what does it mean that he's not improving? And sometimes it's not that simple in PE patients, but the question is how long we should wait. And personally, I think that we should escalate treatment faster than later. For me, even 36 hours was a bit late. But
Yeah.
and the other thing is that I know that in guidelines we don't need echo to induce treatment. Nevertheless, in our clinic we tend to perform echo, maybe not full echocardiographic assessment, maybe just point of care for the right ventricular dysfunction. Also to compare the results of eventual treatment, whether it will be interventional or thrombolytic treatment.
Yeah,
And
well,
for me, the reason why I would go for interventional treatment is that we know that thrombolysis in PE is may also cause more often intracranial hemorrhage, which is more often than when we do thrombolysis in STEMI. This is why in patients with right ventricular dysfunction in PE, I think that it's safer for them. But
Thank
I know
you.
it's controversial.
Yeah, thank you.
Yeah, Stavros has got a comment, and then we'll come to Christine.
Several comments. So the first question is the most difficult one, namely, so I'll go over there so that I can take off my mask and speak. So the first question is the most difficult one. When is a patient not doing well enough, or when is a patient deteriorating? So the bad news is we do not know exactly. Every doctor does this by intuition or by clinical experience. The good news is that there is news. So the news is that there is in a study which is now ongoing, we are, among others, I mean, it's a study about interventional treatment, but the study is, among others, validating a clinical score which is already used in ICUs or CCUs in the United Kingdom and also in the Netherlands and other countries. Very simple score based on simple parameters in order to be able to say if this patient if the patient is deteriorating or not, based on clinical parameters that everyone can check and measure. That's the new score that you can find also on every website, right? So, so this is something that we do not know if it works, and we have said that in that study, of course, that we give the treatment 24 hours at least. We'll know. So, but this is one thing that we think we will know better because, as you all said, I mean, this is what every doctor thinks by experience, but this can improve. Just have to wait a couple of 2 or 3 years. The other thing is, of course, that, I mean, of course, half-dose lysis, just wanted to say formally, it is not yet validated, but there is a study going on as well. It's probably a good thing. We will know formally. And I think the last question was on the, last comment was on the
echo.
Yeah. No, so this is also not so straightforward. The truth is, with tenecteplase, the rates were high. The rates with alteplase in studies with PE were not in the rate of 2%. So it appeared that tenecteplase was too much in Pytho. So it's not that everything does a 2% stroke, just to give you an idea.
This is yours. This is yours on this.
You were talking about, or you were agreeing with this being a controversial decision, and I was wondering, this patient, he had surgery 4 weeks ago, not 3. if I recall correctly, and he had also
month, yeah.
gastric erosions. Were you not afraid about bleeding? And I think sometimes it's, for us, maybe it would be easier to say first, do not harm, and
yeah, you are right.
You
are right. We hesitating, we're waiting one day, and that's all. That's usual practice. I mean, the patients are not so clear, and they don't fit in everything. So, yeah, you are right, and we were afraid of this.
Chap at the
Of
back.
course, we are not afraid of surgery, but this gastric erosions, although he has no complaints for, let's say, half a year of this. Well, thank you. I would like to...
Just two short comments from these two chaps, if that's all right, and then we'll move on to the second one. Very short, please.
Okay, it was just a small question. I know that there are several methods to measure the RFAO-LFAO ratio. Which is the one you used in your...
This ratio, yeah.
Yes,
In
there are
CTPA.
several methods and to measure it. Which one did you use?
The highest, the biggest, the dimension.
Widest diameter. Widest diameter, the right
one
ventricle.
biggest dimension against the other biggest, not necessary on the same level.
Okay, final comment, very short, please.
If in our center we continue with the option of the thrombectomy, do you consider that this patient is a good option or no?
Well, thrombectomy, I mean surgical one, it's probably not the indicated, but after about catheter, he will talk.
Yeah.
That I leave to him.
Okay. Great. Okay, thanks.
Thank you for great participation.
Yeah, right. Okay, thanks very much, Mashir. That's got everybody livened up. That's fantastic. Right. If I can have my presentation up, please. Okay, so I'm Andrew Sharp. I'm a cardiologist from Cardiff. With Stavros, I'm one of the members of the executive committee of the High-Pythor trial. And I'm going to present a conundrum from a number of years ago. So you're going to have to put yourself in my position 7, 8 years ago. The world looked very different back then.
Before you were so famous.
Oh, really? Yeah. Before I was all over the internet. So, a useful guiding principle, and in many ways we've just seen it. We've just seen a number of experts not really sure what to do with that last patient. So there's lots we don't understand about pulmonary embolism, and the data are not convincing in many directions other than the fact that low molecular heparin helps. So the only certainty is still uncertainty, and it's actually a really important point, and it's why I strongly support the PERT team principle. Because the more opinions you can get from different specialties, different people, different levels of experience, the safer your decision-making is going to be. Because these are always difficult patients, these large volume pulmonary embolisms. They've got cancer, they've had recent surgery, they're pregnant, they've had bleeding. And it's very rare you get a clean 30-year-old who's just stepped off a plane unless you practice next to Schiphol Airport. So I'm going to present a case, and then we're going to see what we would do about this case. So this is a 33-year-old lady. She's on her second pregnancy. The first one had a crash cesarean section. So this is her second pregnancy, which is an elective cesarean section. And she goes into the anesthetic room on Monday evening to have be put to sleep at about 3:30 in the afternoon for her planned cesarean section. They start the induction, and she has a cardiac arrest about 30 seconds after the induction. Okay? They do CPR for about 3 minutes, and she doesn't come back. They assume it's an anaphylactic reaction to the general anesthetic. They give her adrenaline. They give her everything they can think of for anaphylaxis, and she's still in cardiac arrest. So they wheel her straight into theatre, and they take the baby out under CPR. She stabilizes for a short time with the baby coming out. So they're then going through various algorithms trying to work out what's happened with this lady. Now, given where we are right now, it's fairly obvious what's happened to this lady. But you can imagine in real time, if you're an anaesthetist with someone who's just arrested virtually as you give them a slug of your drug, you can imagine how decision-making is all over the place at this point. They managed to stabilize her, close her abdomen, send her down the corridor to intensive care. Thinking, and I've seen the note, query anaphylaxis, query compression of IVC, query fatal hypotensive episode, query air embolism. You know, the list is about this long as to what's happened to this lady. She then arrests again on intensive care. They take her back to theatre because it was a hypotensive arrest. They saw her blood pressure go down and then arrest again. So she's had a crash cesarean section in about 10 minutes. So they assume that she's bleeding. Not unreasonable. They open the abdomen and they find blood in the pelvis. So they do an emergency hysterectomy, assuming a concealed bleed from the back of the uterus. Okay? Goes back to intensive care. Has another cardiac arrest and has about 5 cycles of CPR where she comes in and out of some sort of blood pressure. She's obviously intubated and unconscious at this time. They get an echocardiogram, and this is what they find. So, apart from Stavros, who's a cardiology person here? Okay, great. I've already asked you one question, so I'll go to your colleague next to you. What do you see? Is that on? Let me see. It's not on. Yeah, the batteries are gone.
I'm sorry. So this is a subcostal view of the heart, where we can see that, first of all, it's working. Maybe that's good for the patient because she was in a cardiac arrest. She's very tachycardic, and the right ventricle seems a bit strained. The cavity is very small. I don't know what else to comment.
So there's the liver.
There's the liver.
There's the liver.
Yeah,
there's
and
the right ventricle.
Yeah,
here.
There's some
the right atrium.
echogenic mass in
and
the
what is this thing?
Thrombus, maybe.
Yeah. Do you want to pass to your colleague next door? What do you think?
I can only say that this is a mass, highly mobile mass, and it could be thrombus, it could be myxoma, it could be anything.
This thing shouldn't be there.
Yeah.
Okay. Okay, great, thanks. Okay, so she has what was assumed immediately to be a massive thrombus in the right atrium. And suddenly everything started to click into place. So she's induced and then intubated. And so she immediately has negative intrathoracic pressure. Basically, suction is applied to the deep veins. And then she arrests. And she's had multiple cardiac arrests, possibly because of a pulmonary embolism. So she's currently intubated and ventilated, is requiring both inotropic and pressor support. And these are her bloods. So who's a hematologist? You don't have to be an attending or a consultant. Who's training in hematology? I'm going to ring you in the middle of the night and ask you what these blood tests mean. Nobody going to volunteer? Okay, Stavros, you know what these blood tests mean.
Yeah, I mean, this is a massive consumption, right, of factors. So it is a DIC, the factor. She has not been thrombolized, right? Correct. She has not received. So this would be from someone who received massive thrombolysis and for somehow there's no longer any measurable fibrinogen. So it is a DIC, yeah. And it could be, of course, the result of cardiac arrest, or it could be the result of this extreme situation in which she is, right? But it's a massive consumption of coagulation factors, yes.
Peter?
Yes, but please be aware that in patients with amniotic fluid embolism, DIC is very typical.
Yes.
So I would assume that maybe this is a case of consumption, but maybe this is something underlying.
Yes.
So this is...
So all these things are going through our minds. There is... It looks like she has thrombus in the right ventricle, so it could be two things. But she now has undetectable fibrinogen, and she hasn't yet had any anticoagulation because she's just had 2 major interventions, one of which found about 2 liters of blood in her pelvis. So at this point, she hasn't even had heparin when this comes back from theatre, from the second intervention. So she's in DIC. So there's an attempt to move her to CT to try and work out what's going on, what is in the pulmonary artery. And she's too unstable. It looks like she's going to arrest again as soon as they turn her. So what would you do? Okay, go on. I almost asked you a question earlier. What would you do with this lady?
Well, I would
consult the hematologist, because with the still DIC being in the room, you cannot anticoagulate her because of the high risk of bleeding. I would have to consult experts.
Okay, that's a very good answer. That's what I did. And where's that second microphone? Do you mind if I take that? So, hands up for just anticoagulate with heparin right now. Nobody? Yeah, we got one for two for anticoagulate with heparin. Unfractionated. Yeah, why? Nice short answers if you don't mind.
If she starts bleeding again, then
it's highly reversible.
Yeah.
Okay, great. Correcting the coagulation factors first. Hands up for that. Okay, we've got a couple. Lots of people not putting their hands up. So I'm sorry, Christine, I'm going to have to come back to you. What would you do?
I don't think, or I'm not sure if we could operate on this patient, but I think I would ask the cardiac surgeons to come.
Not a bad idea. So, we at the time, I was not in an ECMO center. We talked about ECMO and the risks of lines in someone who's in DIC. The risks would be extremely high. 16, 18 French arterial cannula, 22, 24 French venous cannula in someone. The blood in the pelvis was probably because she was already in DIC by the time she went back to the second operation. Because that coagulation screen was taken from theater the second operation, about 2-3 hours after the first one. So we contacted our regional ECMO center, and they said no. And they didn't have retrieval available at the time. We talked to our cardiac surgeons, the heroes of the hospital. When I was growing up, they were the heroes of the hospital. They would take on anything. It's a different era. They're still very impressive people, but they do not do patients like this anymore. At least not in my hospital, ever. I'm not there yet. I'm not there yet. So the decision was to put her on IV heparin, and she was stable overnight, remarkably, albeit on support. So they decided, I wasn't involved at this point, they decided that intubation was not helping. If you have a large volume pulmonary embolism, the last thing you want to do is intubate that patient, because 20% will die during induction, 20% will die in the first 24 hours, and a further 15% will die on that hospital admission. Now, there's a chicken-egg situation. Is it the intubation that's killing them, or is it the need for intubation that's killing them? It's a bit of both. But when you put them on positive pressure ventilation and you drop their preload, you make them worse. That's why 20% die as you're intubating them. So she has, so they extubate her, she has hypotension, hypoxia, her lactate starts going up, she becomes oliguric, and then she has another cardiac arrest. Bearing in mind that the whole family were there waiting to welcome the new baby. And then they do a cut and run to the CT to find out what on earth's going on. And as you can see, sorry, let me go backwards. We have clot here, we have clot here, and there's a whole load more, but I didn't want to fit them in too many slides. And she has a dilated right heart. What's interesting is that the left heart is open. The right heart's dilated, but the left heart is open. And that's because she's on escalating doses of noradrenaline, increasing her left-sided afterload, as well as having right ventricular afterload increase from a pulmonary embolism. So, Monday evening was her cesarean. Tuesday evening at 6:30, they asked me to come and get involved because I had various research programs which at this point in time did not involve pulmonary embolism. She was stable on norepinephrine and ventilation. Blood pressure was okay, she's passing urine. So who thinks this patient is stable? Is this a stable patient?
Not so, but it's improved.
It's better. It's better, but not stable. Written all over the notes is patient stable now, patient stable now. But they're on norepinephrine and they're ventilated. So it's not very stable, is it? It's just not as bad. So what now? So the decision was to just carry on with IV heparin and hope we could get through this. She has a rising vasopressor requirement overnight. She's now on 0.4 of NORAD in the morning, which is a sort of moderate level, halfway house for our dilution. We wouldn't want to go that much further without her starting to get problems. Her coagulation factors were corrected. So hands up now for just carry on with anticoagulation. Hands up for catheter-based treatments. Okay, we've got a number of hands. Okay, great. Hands up for systemic thrombolysis. Nobody? Hands up for trying the cardiac surgeons again. Yeah, great. Your surgeons would do this?
Maybe. Yeah.
It's very center specific. Yeah. Do your surgeons publish their results nationally?
No.
There you go. That's how you get a surgeon to do it.
This patient doesn't bleed.
Yeah, they're very, yeah. I mean, they haven't bled on heparin, that's true. The APTR was run as close to 1.5 as it was possible to get. So they were running at the lower end of the anticoagulation range. And of course, heparin is an incredibly weak lytic. Its main job is to stop further thrombus formation. It's not going to clear out that stuff. It's just going to stop it getting worse. And she's not exactly in a good position. So, in the end, we decided to do the first ultrasound-assisted catheter-directed thrombolysis procedure in the south of England ever, after I got permission from my medical director and about everybody else in the whole hospital. There were 13 family members outside of the ITU doing rotational prayer. So we had 24 hours a day prayer from the family, and the baby was in NICU, currently so-so. This is my first procedure ever, 8-9 years ago, whenever it was. And it was, do you remember this? I talked to you the day before. Tell them it's true that this was the first procedure ever.
I can only say it's true.
And I talked to Leo, who rather annoyingly was in Sweden? Finland. Okay, I got Scandinavia right. And he talked me through the procedure. And then one of his colleagues came down, and we sort of talked each other through it. So it's a pretty stressful thing. And the reason we used echoes is that we'd seen some evidence that low doses could be used. And that's the potential of ultrasound, is lower doses. So the device goes in. I decided to do it unilaterally because I figured we only need to get one lung circulation working and maybe we get out of trouble. And I wanted the lowest dose that I could possibly give. So we ran 0.5 milligram per hour through a single catheter into the left main pulmonary artery. Yeah.
And you repeated the echo to make sure that there was nothing in the right atrium or ventricle?
Yes, I should have put that in.
It was out.
It was gone. It was gone. Yeah, the clot in the right atrium was gone. It was in the lung. So I ran that for 14 hours overnight, and the patient stabilized. So review the next morning. The patient was now off inotropes and pressors, still ventilated. Things were going okay, no bleeding. By that time, I'd given her 7 milligrams of alteplase, not the 50 being tested in Pythor 3 that we'd talked about in the last case, but 7. And I decided to carry on and extend the infusion. On the Thursday morning, she'd had 12 milligrams of TPA in total. That's alteplase, not tenecteplase, alteplase. So 100 is for systemic thrombolysis of a grown man, 50 is the half dose, so-called low dose. We've given 12. No bleeding. This is the echocardiogram now. So this is the ECHOS ultrasound beam interacting with the ultrasound beam of the echo. You can see the right ventricular outflow tract suddenly looks a bit better. The left ventricles are opening nicely, and everything looked a bit better. So we decided we pushed our luck enough, and we stopped and pulled everything. These were our hemodynamics, a sheath pull. PA pressure's good, CVP's good, oxygenation's good. On a ventilator still, hemodynamics look good. They'd all been improving. So what now? Hands up for extubate. Yeah? Okay, hands up for leave her on a ventilator for a few days and just allow things to stabilize. Okay, so we got a couple of votes for that. So what they decided was they were so shaken by the previous attempt to extubate, albeit that was before any attempt at reperfusion, that they repeated the CTPA. So this is the side that did not have an Echos catheter in it. So you can see that the clot is still largely there at the right PA bifurcation. It may have thinned out a bit here. Remember that the Echos catheter, I actually intentionally positioned the rear end of the ultrasound holes here to try and inject a little bit of alteplase that way. And this is the side that had the Echos in. So that's before and that's after. So that gave them confidence that almost all of the clot miraculously, and actually this is not normal for Echos, it doesn't normally dissolve that much. They gave them confidence. So the right ventricle had come down from 4.8 to 3.8, and the echo was looking good. So she was extubated on Friday. She woke up, started talking, was back to the cardiology ward on Saturday, walking around on Monday and home on Tuesday. Her baby was out of NICU. This was this lady's echo before discharge. You can see the right ventricle in the long axis is vigorous and normal, and there's no evidence of right ventricular harm. PA pressure was back to normal. 2-year follow-up, she's well, she's jogging, PA pressure's normal, baby's fine. So that was 9 years ago, something like that. So what would I do different now? What would you do different, Stavros?
I may be not very pleasant to some. I would not do an echoes on this patient.
No.
I would have done thrombosuction in this patient.
Yes.
In this, I don't know if you agree.
Yes, that's what I would do.
Okay, so yeah, because I mean everything else was fine, and I mean it worked. So
yes.
So retrospectively, it was an excellent decision.
Yeah.
But I think in that case, you need something just to pull it out of there.
Exactly. Back then,
it's not for everyone, but for such a case.
Yeah, back then, Echos was the only game in town for me. Now, I use Penumbra and Inari as well for percutaneous procedures. The problem, of course, is that they're bigger holes. And she's just had DIC. And the Inari is a 24 French hole if you want to get out clot of that size. You might get away with the 22 French sheath for the 20 French catheter, but that's still a big hole, albeit in a vein. And so I think now I would do thrombectomy, but I'd think hard before I did it. Of course, the right atrial clot, a lot of people are advocating angiovac for that now, which is a cardiopulmonary bypass system. You go in and you suck it out. But again, you need big cannulae in someone who was in DIC at the time that the right atrial clot was bouncing around. And who knows if she'd have done any better. I'm not saying that Echos is the right thing. I wouldn't do that now. I'd do thrombectomy. But the reason I wanted to present this case is that there's clearly no right answer. I think if I'd have put the entire faculty of this meeting on the stage, we'd have got 12 different plans. And the reason I say that is, and also remember, we're not going to present catastrophic failures. If I cause it to bleed to death, I'm not likely to present it at a meeting. But large volume PEs are very difficult. We've had 2 cases here that are difficult. So build a team wherever you end up and make sure you take as many opinions and perspectives as possible. And every different group, hematology, internal medicine, vascular medicine, surgery, interventional cardiology, radiology, they think differently, they've got different experience and skills. So by pulling them together, you've got more of a chance of getting the decision right. It's not about, you don't have a PE team so you can pick cases for the cath lab. You have a PE team to get more decisions right. And so I strongly encourage it. And I've talked for far too long, I'm sorry. So, thank you very much. Yeah. This is my racehorse. So I think we're done now. We're going to go on to the final talk of the evening. Who's next up, Stavros?
Yes. So we will have our next workshop, and we have also a great. So first of all, thank you so much. You were great cases, and I think we already have our expert panel of radiologists here. This is Dr. Michael Sproul. So. Michael, can you hear us?
Yes, I can hear you.
Perfect. So this is, Michael, many thanks that you could join. And so we have here, we'll be talking about patients with acute PE, or maybe not so acute PE, and how the radiologists and the clinicians come together and try to sort it out, what it was. And we also have, of course, Dr. Lilian Maiboom. So tomorrow, actually, Lillian and Michael will also have a more theoretical seminar on this very important issue. It is one of the hottest topics right now in acute PE. But if you both agree, I will briefly present, so I think I can take this out now. I will briefly present, can I present can I present 3 slides or 4, and then of course ask our radiology experts to tell us what they believe. So that will really be brief. And then, of course, the question is, so, okay. Michael, can you also see the slides?
Yeah, sort of. I've got an oblique angle.
Yes. So this is a very brief case we had at the CTH in Mainz about 1.5 years ago. So we had a 53-year-old man. He came in because of increasing shortness of breath. So the whole situation was not as dramatic as Dr. Sharp just described it. But that was a patient who had had DVT and PE 8 years before that, after minor knee injury, and he had a family history. So somehow a typical, well, it's not boring case because I mean, the man was sick, but a very typical case. Patient obese, oriented, he did have tachycardia, he did have marginal blood pressure, saturation, as you can see, was 90% on oxygen, so that was quite a sick patient with respiratory and beginning hemodynamic decompensation, but not decompensated yet. D-dimer levels was increased, troponin level was increased, so typical patient of, let's say, clinically at least intermediate risk PE, right? And he has this CT scan that all of you can see, and I think we do not need radiology experts to say that this patient has filling defects, right? So we even made the diagnosis ourselves, and here we had an RV-LV ratio of 1.8 to 1. So a patient who is not in shock, but everything else that could be abnormal is abnormal. Okay, so that was the patient's echo here. So this is an echo of a patient who has, excuse me, I'll show it again. This is an echo with a paradoxical septal wall, if you see it. Can you see it here? So I know it's not very easy, because, so here, if you focus on the middle, right here, right, so you can see the paradoxical septal wall motion, and if you go here, you see the D sign, right? You see how flat the septum is. So this is a patient with pressure overload of the right ventricle. But one thing here is strange. Does someone who is here, an echo expert, I think it's Dr. Hobon over there, Lucas, what is strange in this acute PE patient who is otherwise quite a typical and boring case?
If you're looking for the RVRA gradient, something about 81?
Yes, so the RVRA gradient, pressure gradient, is 80 millimeters mercury. This does not mean that it is a chronic condition. We have seen it in acute, or at least in acute and chronic PE, and it went back to almost normal. But this, and there is one thing also that we did not find typical. Yes, patient has, they have a small pericardial effusion, so this is atypical for PE. And there is one more thing that I found very strange. It is the fact that the patient, where is Professor Prushik? Is he here? No. Hi. His TAPSI is normal. So this is a strange situation. This is a patient with acute PE, comes in, he is sick, he has hyposaturation, and everything is quite dramatic, but he has a normal TAPSI. That means the basis of his right ventricle has he has a TAPSI of 20. That's quite strange. Yes, please.
The TAPSI measurement is not correct. On the echo.
I have not shown it. This one?
Yeah, because
we should measure this. Sorry, this is anterior-posterior motion. So it should measure like that.
Yes, this is correct. You're right. I mean, this is not, but this is, of course, this is correct, but this is just a snapshot. And of course, the heart was moving like this. So this is, of course, not the best snapshot. You're right.
No, it's not the best snapshot. It's not the correct measurement. You need to met.
So do we agree that this patient has a normal basal movement of the heart?
Yes, but this is the basal segment only.
And maybe there is a right ventricular hypertrophy.
The patient, first of all, in acute PE, it's not always very easy to bring it like this, right? But anyway, I agree with you, of course, that the angle is not the correct angle because the patient has to be perpendicular. But the patient's basal movement is almost normal. Okay. Anyway, so no one cared about this, and this patient, so patient was treated based on the guidelines, and the patient was found to have intermediate high risk. I think we will agree on this. Everyone agrees that's intermediate high risk. And patient received unfractionated heparin. It was decided not to thrombolize, not to do anything on this patient. He was much better. And